based on the report from the Paris Poison Control Center, the increase in the number of use and fatalities in Paris area. Here in our ICU, also a significant increase in the use of GHB, and more recently in the appearance of GBL used among these admitted patients. So that all the French newspapers 1 year ago talked about this important issue with the increase of use of GHB at the recreational scenes. In Europe, this is also the case, and you see here, based on the Euroden data, Euroden work group data, you see that GHB-GBL is also very extensively used among the patients who are referred to the emergency departments in Europe, and it is at the 4th rank among the illicit drugs after heroin, cocaine, and cannabis. So what is GHB? GHB is a physiological neurotransmitter. It acts on the receptors of GHB, but also on the GABA-B receptors. And of course, it can be metabolized to GABA, and thus act also indirectly on the GABA-A receptors. So it's like a sedative drug. So if you measure your concentration, you have endogenous GHB concentration, which is not zero. GHB is rapidly absorbed with relatively low bioavailability with the oral route. Its volume of distribution is relatively limited, no protein binding, and metabolism to water and CO2. And that's why it is used for RAP, because you cannot find GHB when the patient wakes up. It is renally eliminated for 2% with an unchanged form, and its kinetics is nonlinear with a zero order at high dose. What is important is, from a pharmacodynamic point of view, its action is relatively short, during 1 to 3 hours maximum. GBL is it's the molecule that is metabolized in vivo by serum lactonase to GHB. Metabolization is very rapid, within 30 minutes, and it follows approximately the same pharmacokinetics without elimination as unchanged form in urine. Here also the effects are very short. So this slide shows you this metabolism, and you see that GBL is transformed rapidly by lactonase to GHB. You have also another derivative, which is called 1,4-butanediol, which can also be metabolized in GHB. And GHB is a neurotransmitter that goes to GABA, and itself it's metabolized into water and CO2. The toxicity is dose and concentration related, and you see if you increase the dose, you will increase the risk of CNS depression, respiratory depression, and of course you may present even cardiovascular instability with bradycardia, hypotension, and risk of seizures, and finally depression of even brainstem reflexes. In many situations, GHB and GBL is used with other drugs in mixed poisonings, but it seems that there is no clear symptoms that may distinguish this mixed use from the use of GHB by itself. The patients will present a deep coma, And the question, of course, for the management is to know whether you have or not to intubate the patient, because the duration of the coma is very short. So this is debated in the literature, and you see here just a case, a situation where 21 participants to a rave party arrived at the hospital with a Glasgow coma score of less than 8. They were supposed to be intubated, all of them, but none of them wasn't really intubated, and all improved spontaneously. So, of course, intubation is debated, but probably it may secure also the respiration, and especially if the risk of aspiration and seizure is important. There is no efficient antidote. Several antidotes were used: naloxone, flumazenil, physostigmine, benzo, but none of them has any effectiveness to reverse or improve in anything the patient outcome. There is no clear relationship between GHB concentration and the depths of coma, thus suggesting a very important inter-individual variability in the onset of consciousness impairment. And of course, there is a tolerance. So if you are a chronic user of GHB, you will have less neurological symptoms than a naive patient. What is interesting is that there is like an on-off effect with GHB. And you see this relationship between, in one patient, between the Glasgow coma score and the GHB concentration, and you see that a very limited decrease in the concentration around the EC50 of this drug will result in a very important modification of the Glasgow coma score. And finally, before going to the solution of our case, there is, of course, a dependence liability, and chronic use may result in withdrawal syndrome, with, you see, an onset rapidly after the cessation of the use, a duration of 14 days. Withdrawal may be very severe with tachycardia, anxiety, agitation, hallucinations, delirium, seizures. It is similar to benzo and alcohol withdrawal, and it is managed usually with benzodiazepine and sometimes even require barbiturates. So let's go to our case. What was the problem? When reviewing the literature, we found 2 cases with such severe metabolic acidosis with increased anion gap. This is the first case, which looks like ours, self-ingestion of 300 milliliter of GHB, presentation with coma, respiratory depression, bradycardia, and you see a severe acidosis, pH 6.75, with an important concentrations, even though lower than ours, of GHB. The patient presented also a cardiac arrest and was treated with hemofiltration and discharged without sequela. This is the second case published in the literature. Here also use of GHB with severe metabolic acidosis, a high concentration of GHB. The patient was also treated with hemodialysis, which resulted in a rapid normalization of her metabolic situation and discharge without sequela. So what are the mechanistic hypotheses? If you take GHB orally, then you have a saturation of absorption and metabolism. So, as shown by this experimental study, even if you increase the dose, you are unable to increase the GHB concentration due to this saturable absorption. While if you ingest GBL, then you see that you have a dose-dependent elevation in GHB concentration, and you are able to increase GHB concentration because it is much better absorbed and immediately metabolized from GBL to GHB after absorption by the lactonase. So if you drink GBL, you are able to increase GHB concentrations to concentrations which you cannot reach, never, if you ingest directly GHB. And of course, as our patient, if you drink GBL in a binge manner, then you can increase so highly the GHB concentration that you will modify the equilibrium between the anionic and the cationic form, and you will exhibit a metabolic acidosis with anion gap related to the anion form of GHB, which is gamma hydroxybutyrate. So the only solution to reach very elevated concentration of GHB is to drink GBL, which seems to be much more dangerous than GHB. And in this case, you will exhibit a metabolic acidosis with increased anion gap. In practice, there is the diagnosis between GHB and GBL poisoning is not so easy because almost all GBL is metabolized in GHB, and you will not be able to diagnose the presence of GBL. So you will only measure GHB. So you have to measure GBL in the drunk solution only. So it is difficult, and you have to base your diagnosis on the patient report. So in conclusion, GHB and GBL poisonings are increasing. Severity may be increased in case of co-ingestions, mainly other drugs and ethanol. And the biochemical properties allows GBL to be transformed in GHB and to induce metabolic acidosis, which is observed in case of binge-type GBL ingestion by an unusual consumer. So what to do in practice? Clinicians have to be aware of this rare risk of metabolic acidosis due to GBL binge drinking. Diagnosis is based on the screening of GHB and the measurement of its concentration. And of course, in case of very severe acidosis, early ECTR with mainly intermittent hemodialysis is required to avoid organ failure and fatality. Thank you very much.
For one question before we move to the last. Yes.
Thank you very much for that, Dr. Bruno.
What happened to your first case that has a very deep acidosis? It was 6.46. What happened to this patient?
So she improved by hemodialysis, and she was discharged without sequela at home rapidly. Acidosis rapidly was corrected. I showed the slide. Rapidly was corrected by hemodialysis. And the anion gap was related to the anionic form of GHB. And as I have explained, to reach such a situation of anionic GHB, you have to drink GBL because you have to reach very elevated concentration of GHB, which is impossible if you drink directly GHB. Because first, you have not so large amounts of GHB because it's an illicit drug, so you cannot drink so large amounts. And secondly, absorption is saturated. So even as shown in the rat, even if you ingest large amount of GHB, you cannot increase the concentration of GHB. While if you drink GBL, then it is rapidly absorbed, immediately transformed by lactonase, and you can reach very elevated concentration of GHB and present this situation. That's why in the past we did not see such situations of metabolic acidosis, because it's impossible to reach this with GHB. You need to drink GBL. And that's why this situation is rarely reported, just 2 cases in the literature. And our case has the highest concentration ever reached of GHB.
Okay, sure. Another question? Yes.
If I'm not wrong, you started to treat with fomepizole in your first case, right? Did you have any answer for this treatment? I believe that you followed the ABG, so did the patient improve in this period?
We administered fomepizole because based on the onset of metabolic acidosis with increased anion gap, we suspected initially that the patient has drunk
methanol or other
toxic alcohol, even though the history of the patient was not supporting such drinking, because the interval of time between the exposure and the onset of metabolic acidosis was very short. But our physician in charge suspected toxic alcohol and administered fomepizole to block the metabolism. And then the patient was immediately dialyzed. I think fomepizole has no efficiency on the situation, but hemodialysis immediately improved the situation because it corrected the acid-base disequilibrium, and also it allowed the elimination of the toxicant. Because the toxicant can be eliminated by dialysis.
Yeah, I'm asking that because in our hospitals, I don't believe that we can measure this GBL or GHB. So in the emergency department, we need to have another treatment option. So hemodialysis is gonna go after, and it's gonna take time. So I'm actually looking for another solution to keep these patients alive.
No, there is no antidote. But as you understood, such a situation is very rare. I'm not sure that you will meet such a situation because it's very rare. In the majority of GHB poison patients, it's only coma, and it's only intubation or not. As I showed you before, intubation is debated. Because the coma is very short. So either you decide to intubate or not, but there is only a coma with a duration of 1 to 3 hours maximum. This situation of metabolic acidosis is exceptional, and you cannot reach it with GHB. You have to drink GBL.
Okay, thank you.
I don't know if GBL is surely available everywhere because you can buy it on internet.
Yeah.
But the people don't know this. While recently in France, it was advertised. I don't know why. It was advertised in the recreational scene that you can drink GBL and it is like a GHB. GHB is illicit, GBL is available. So all the people started to drink GBL and buy it from the market.
Okay, for the sake of time, you can approach Dr. Megerban during the break and discuss this in details.
Yes, thank you. Thank you, Dr. Bruno. I want to invite, with my pleasure, my colleague, Dr. Mehmet Okumuş. He's an associate professor of emergency medicine at Medical Science University, Ankara Training and Research Hospital. He worked as an emergency medicine consultant in various provinces, Istanbul, Konya, Malatya, and he is an instructor in basic life support, advanced life support, and traumatization course, and he is from board of IPAT. Okay, please, Mehmet Okumuş.
Thank you, dear Bashar Jander. Yes, I traveled a lot in Turkey. Not much in abroad. So I'm going to talk about toxic ECG. ECG is a screening tool for the heart and for the diagnosis of the cardiac toxicity, and we can use it for the prognosis of heart, and the monitoring progress is a guide to manage and disposition. ECG is very cheap, is readily available, and it's not invasive, and it identifies potential fatal cardiac conduction abnormalities. You can see this cardiac conduction system. It an impulse provides by the sinus node, and its current through the conduction system to atria and ventriculi, and then occurs the systole. Here we see the action potential in sinus node. The automaticity depends on the slow sodium channels. As the increase the sodium in the cell, it increases the voltage, and if it reach minus 40, an impulse creates, and this period creates automaticity. And in the muscle, the phase 0 creates QRS, and the phase 2 and 3 creates QT period. As we see in the right, at the end of the phase 3, contraction occurs. So we can see different kind of action potentials and different from generating different part of heart. So I'm going to talk right now mechanism of cardiotoxicity and their manifestations on ECG. When blockade of sodium channels occurs, the slope of phase 0 decreases. And at this time, the QRS widens. And in AVR lead, the R wave is getting bigger, and right axis deviation occurs, and ventricular tachycardia and fibrillation may occur, and brugada phenocopy may present. When blockade of potassium channels, the phase 3 and 2 and 3, it causes the elongation of T wave, and at the end it occurs QT prolongation, and this may cause torsades. And beta-adrenergic receptor blockade causes sinus bradycardia, first, second, and third degree blocks, junctional bradycardia, and ventricular bradycardia. Propranolol and sotalol differs from other beta blockers. Propranolol acts like TCA, tricyclic antidepressants, and blocks also sodium channels, and this causes wide QRS. And sotalol blocks potassium channels, and this causes QT prolongation, and may cause torsades. And calcium channel blockade causes sinus bradycardia, second and third degree heart block, sinus arrest with nodal escape, and may cause stale. We have to keep in mind the prolongation of PR interval may be the first sign of calcium and beta blockers without any sign of other blocks. There are many kinds of drugs and agents that blocks sodium channels, and there are also many drugs that blocks potassium channels. So when we approach and toxic ECG, we have to follow a systematic row, the rate of ECG and rhythm of ECG, PR interval, coarse duration, and we have to check the right axis deviation and also check QT interval and CD, ST segment elevation or depression. First of all, when we check rhythm and rate, when tachycardia occurs, we may suggest symptomimetics and anticholinergic toxication and group 1A and C antidysrhythmics. When bradycardia occurs, the cause of toxication may calcium and beta blockers, digoxin, opioids, organophosphates, and lithium. When enhanced automaticity occurs, the poisoning, the cause of poisoning may digoxin and symptomatic toxicity. When we evaluate the PR interval, when it's long, it suggests calcium and beta blockers or digoxin toxicity and other drugs. When we evaluate the QRS interval, it must be more than 100 milliseconds, usually caused by drugs that block sodium channels, TGAs, class 1 antidysrhythmic, and carbamazepine. And we can see right bundle branch block, prominent R wave in AVR lead. When we evaluate QT interval, usually caused by potassium channel blockers toxicity, we have to measure QT interval at the beginning of Q wave and at the end of T wave. But if we see U wave, we have to measure it with T wave. And we have to be aware of torsades. And when we have bradycardia, constant bradycardia is more likely to be with torsades. When we measure QT interval, we get used to use corrected QT, but in toxications, in cardiac toxications, we have to use absolute QT because of it's more relevant with torsades. We can use to evaluate the QT with QT nomograms. It's available everywhere. If you measure, if the QT interval above the line, torsades is more potential. There are some drugs that prolongs QT that we use often: antihistamines, antibiotics, antidysrhythmic agents. Management of specific cardiac drugs. I want to go with cases. Case 1. A 62-year-old female with past medical history of hypertension, coronary artery disease, and atrial fibrillation. She is tired and weak. She presents to ED, and she appears alert. She reports an episode of syncope, and she was bradycardic and hypotensive. She is afebrile and she has any tachypnea or hypoxia. This is the ECG strip. First of all, if we evaluate rate, it's bradycardic, it's rhythmic, and if we evaluate D2, we can see the first degree block. She has been taking metoprolol at 200 milligrams. She forgot to take it, and after she take it together, 3 pills each time, and at the end she became toxic. What can we do in beta blocker overdose? We have to give fluids when hypotension occurs. When it's unresponsive to IV fluids, we can use vasopressors. And we can use specific antidotes, high-dose insulin. And when bradycardia occurs, we can use atropine. If unresponsive, beta-agonist isoprene infusion. Glucagon, when we can use, but it's inferior to high-dose insulin. Case 2, a 70-year-old man with a history of hypertension, depression, and alcohol use disorder present after ingesting more than 50 tablets of calcium channel blocker. After 8 hours, he was lethargic. His heart rate was 30, blood pressure was low, and his ECG was like this. As we can see, it's written back, but bradycardic. And if we look at the D2, yeah, we can see the P waves and QRS waves are dissociated. Yes. They are complete heart block, and sinus rhythm is about 90, and ventricular rhythm is about 30. Calcium channel blocker toxicity presence with bradycardia and AV block and myocardial depression. If hypertension present, fluid resuscitation is necessary. If it's not response to IV fluid, we can use cardiac inotropes and vasopressors. We can use also ECMO. To bradycardia, we can use atropine, but sometimes it doesn't respond to it, and we can use pacing, transcutaneous or transvenous. Specific antidotes are calcium gluconate and high-dose insulin. The next case is about 61-year-old male patient. 5 hours prior to presentation, he ingested approximately 60 tablets of amitriptyline. He is confused and combative on arrival. Vital signs, he is tachycardic and blood pressure is low. His ECG is like this. Is tachycardic. As you see, QT wave is long, and on AVR is prominent R wave, and in V1 is Brugada-like shape, and in V2 is first degree block. The PR wave is long. Yes, we can use an tricyclic anti-drug poisoning, sodium bicarbonate, and we can hyperventilate patient. It's coming. And we can use in hypotension crystalloids and vasopressors. The next patient present to the AD with syncope. he was on antibiotic use, ciprofloxacin, for his cystitis, and he present AD with syncope, but he recovered rapidly. He's bradycardic and hypotensive. The ECG is like this. As we measure the QT wave, it's long. And if we use the QT nomogram, the QT is above the line. So it can be present, or it can be cause of torsades. And in fellowship, in the fellow of the patient, there are polymorphic BT and torsades occurs. I want to mention the digoxin toxicity. The digoxin toxic dyspnea combines with ventricular tachycardia and slow ventricular response. It's frequently occurs prematurely ventricular systole, sinus bradycardia, slow atrial fibrillation, and any type of AV block and ventricular tachycardia. There are some examples. Sinus rhythm with PVCs, ventricular bigamy. And here is atrial tachycardia with high degree AV block and PVCs. This is a classic of ECG of the digoxin toxicity, atrial tachycardia, and high-grade second-degree AV block with frequent premature ventricular complexes. And this one is bidirectional VT, broad complex tachycardia, and axis alteration in each beat.
Last 1 minute.
So, thank you for listening.
Time, but only one question, maybe one question. No, okay. We have break, after break, opening ceremony. Waiting all to opening ceremony. Okay, thank you.
Welcome to everyone to our opening speech. I hope you are enjoying this section. And now I would like to introduce Dr. Ziad Kazdi, the president of Minatox, for giving his opening speech.
Thank you. I was hoping I get some music and stroboscope so I can get up here with the... What happened to that? Anyway. I want to actually, first of all, address our audience, the Ministry of Health, with Dr. Samih Kurtut, who's not here with us today, unfortunately, because of a competing obligation. But he was supposed to be here, so I want to just address him. Also want to address the Turkish Red Crescent, which is represented today in the ceremony, as well as AFAD. Unfortunately, Turkey has had several recent natural emergencies that have really occupied them, and all our thoughts and hearts go to people that lost family members and friends, and also for those that died or were injured. I also would like to address Dr. Bashar Jandar, President of IPAT, Dr. Bashat Al, Treasurer of Secretary of IPAT, and my sidekick in this conference. Dr. Lisa Moreno, President of the American Academy of Emergency Medicine. Dr. Mohammed Al-Hajri, Director of Emergency Preparedness at the Qatar Ministry of Health. Dr. Paul Wax, Executive Director and past President of the American College of Medical Toxicology, Dr. Charles McKay, immediate past President of the American College of Medical Toxicology, Dr. Ashish Balla, President of the Asia Pacific Association of Medical Toxicology, Dr. Praveen Agarwal, Chief of Emergency Medicine at AIIMS, New Delhi, India, Dr. Amin Kazi, President of the Mediterranean Academy of Emergency Medicine and past President of the American Academy of Emergency Medicine, Dr. Yasin Tunçuk, President of the Turkish Society of Pharmacology, Dr. Kai Kehe, representative of Dr. Horst Thiermann, President of the European Association of Poison Control Centers and Clinical Toxicologists, and one of our two keynote speakers this morning. And our other keynote speaker, Dr. Hussein Hassanyan Mugaddam from Iran, from Tehran, Director of the Poison Center in Tehran. And then guests, delegates, and participants from Turkey and beyond. And I apologize if I missed anyone, but I hope that you will enjoy this amazing conference that we put together as a collaborative effort between MENA Talks and IPAT. We wanted to come to MENA Talks, to Istanbul, for many reasons. But the first reason is we've had an exceptional experience in 2011 in Trabzon. And through the passion of Turkish colleagues like Dr. Bahshat, Dr. Aynur Shaheen, Dr. Jandar, we were invited to come back for this year to beautiful Istanbul. Now, MENA Talks is a non-profit organization, and our mission is to advance the care of poisoned patients and to prevent poisonings. And we want to do that through education, research, and clinical care. We also want to advance public health strategies that prevent poisonings and then improve the situation in our MENA region in terms of hazards to our citizens and community members. We would like eventually, as a vision for us, that we can have a toxicologist, a qualified clinical toxicologist, available to take care of every person living in the MENA region. And we mean by that available in the same city, available in the same hospital, available in the same country. And we are working on that, and we need everyone's support and effort to achieve this vision. We've come a long way. As some of you may know this is our 10-year anniversary for MENA Talks. And we are celebrating this in Turkey. It's a very special event for us. And we've accomplished several steps in this process. We have more challenges to come. Although we've done a lot, we still have much more to do. For example, we need to have training programs in the MENA region to train physicians and pharmacists in clinical toxicology. We also want to have recognition of this training by the Arab Board of Emergency Medicine, for example, and have our first Arab Board of Medical Toxicology. We need research and data. We need to collect data about our chemical exposures, about our poisonings, and we need to share this data and learn from it and act on it. We need to have clinical research that is really relevant to our community and society. Clinical research in the US may or may not be relevant to our region, and we need to keep that in mind. We want to provide technical consultation to ministries of health in the region. And we've done that already for some countries in the region, but we want to do more to help them meet the international health regulation implementation requirement, to help them improve the health of their citizens by protecting them from unwanted chemical exposures. We want to have medical student outreach activities.
Thank you very much, Dr. Ziad. Welcome, everybody, to our beautiful country, beautiful intercontinental city. Only one city in the world, intercontinental city, beautiful Istanbul. I hope you enjoy your time in Istanbul, our dream city. Istanbul is like law for the people, and another law for us is emergency department, emergency medicine. Not only doctor in Turkey, and more of population, people love emergency medicine. Because in one day, some department, like my department, take visit more than 3,000 in one day, patient. In Turkey, in 1 year, we have emergency department visit more than 130 million. So this is very big power for us. Without emergency, you can't do anything. And toxicology, very important part of emergency. All toxicologic patients come to emergency department, of course. And for education, for resident education, for fellowship education, very important toxicology. For that, I want to thank to Minitox for this good collaboration, but this is only the first step for the future. I hope we will increase this collaboration, not only with Minitox and with Kazitu and another all speaker and distinguished speakers. Tamam mı bizim işimiz bu arada? Tamam mıyız? Last day, yesterday, Dr. Becesi said to me, you didn't speak 1 hour. For that program is broken. I said, okay, today I will speak 1 hour. If I have time. Okay, when you say finish, Dr. Ziad, when you say, okay, finish, I will finish. But if we will continue the time, okay? Check the time. Emergency medicine, of course, we have some problem. I want to share what is our life in emergency medicine. You know this video maybe? Ya bu olmaz ya. Acayip. Bu arada söyleyeyim. Bu niye çalışmıyor? Böyle. Okay. We will take everything. Okay. Okay. Violence is okay. Okay. I will go back again. Okay. I try again. Bu çalışıyor mu şimdi? Peki basıyorum. Vaktimiz. Okay. Tamam mı? Geçiyorum. Vaktimiz yok. We haven't time. Okay. Çalışıyorsa çalışıyor. Çalışmıyor. Okay. Violence is very important part of emergency. This is about violence video. I have some video about emergency medicine, but of course we have problem. Ses. Okay. That is any important. Okay. Always technology have problem with you. Okay. Okay. It's nothing for. So everything. Who want to work in emergency department? Only crazy people want to work. This is not problem for Turkey and Middle East and North Africa because we have a lot of crazy people in our country. So everybody come to emergency department. This average age for the life. This is for emergency. Bunun kırmızısı nasıl çalışıyor onu da bulamadık. Emergency. We have another. Media is very important part of emergency department, always. And always they say some wrong thing. This, Okay, this is all. I can't do anything for my speaking. Ya bir daha asla bana konuşma hazırlamayın. İkiniz bir Allah'ım yarabbim ya neyse bu kadar uğraştım. Peki, this is overcrowding is very important for all the world. And this question, why is my bed in corridor? This long ways in the ER, average time, the last time in United States, 100 minutes. We need, of course, some good triage system. But we don't forget the doctor protects all the patient. This is off day for dermatology and radiology and ophthalmology. And this is off day for emergency medicine. Of course, we should be cool and calm in emergency medicine. Always. We should see it. We should understand everything is very good. This is from advanced cardiac life support. Wait a minute. Doctor know better, of course, from patient. They continue. Okay. And we should teach the patient too. Okay, as EPAT, who are the EPAT? EPAT have a lot of big organization in the 1 year and different. This is from opening ceremony, but ses gelmeyecek öyle mi? Ses gelmiyor. Okay. Ses gelmiyor. Peki. This is very different opening ceremony. You should listen from website. I am sorry for that. I don't know what happened with video. Okay. Of course, this big organization, every year we increase the number of member and more than 47 country this year we will be together. This is thanks for all this good organization. Okay, this for thanks. Sorry. And for this year we have a lot of speakers, but one of them he will come for the award ceremony. Do you know him? Yes, he is coming. Brugada will join our congress this year. We always, maybe more than 100 people for months prepare this congress. Okay, I will quickly. Is for our congress. We have more than 300 activation in 1 year. Is IPAT. I will finish quickly. In all the Turkey, not only Turkey, for example, this in 1 day in 3 different continents and 4 countries together in 1 day. In April, in 1 day, 6 activation in 3 countries, 6 activation in 1 day. IPAT very big. organization. This is all activity in one day. We have a lot of organization in abroad, in an international area, Sri Lanka, Ukraine, Georgia, Uzbekistan, Macedonia, all IPAT organization. Again, Georgia, Baku, Azerbaijan, Kazakhstan, and a lot of country, and Mecca, Medina for people, I say all that. We want to increase all emergency care in the world. This is from Budapest, and this year we will go Serbia, Belgrade. And Kappa Tox, another activity of IPAT, toxicology section. Annually we organize Kappa Tox. And for example, ECMO and TREBO are very important for toxicology patient too. In this course. And not only for health area, for example, in football federation and basketball, we give this education. And Sono School, another international area for IPAT. We're building 6 schools together in 6 countries. And these are courses in every area we have another course. This is all the name. We publish 5 journals in one. One of them Asian emergency medicine and toxicology and critical care and case report, and we're waiting for trauma journal too. We have newspaper and TV. Always you can follow all Congress and another activation from TV. And we have story of emergency. Every year we have competition about that, and last year we make emergency sing competition, and this year we finish with emergency short movie. Is singer of emergency. A lot of books together. We give a lot of award. So I want to invite all people, all members, all emergency physicians in the world, this big activation, and IPAT, not only one society, IPAT very big company. We want to make this step to feature together with Minotox, with all society together. Thank you for welcome. Thank you very much.
Thank you, Dr. Bashar Jander, for his speech. Now I would like to invite Dr. Bruno Megarbain, Chief of Minotox Scientific Organizing Committee.
Okay, good morning, everybody. I will not be very long. I would like just to thank you, all of you, to have accepted to come to our meeting, and I hope that you will enjoy our scientific program. I would like to thank all the societies, EPAT mainly, who contributed to the program, all the speakers from Turkey and from MENA region and from Europe and the US for having accepted to participate and to come to Istanbul. And I would like to wish you a very enjoyable stay in Istanbul and very good time in listening to the lectures, and thank you very much. So there are 2 tracks, as you have seen. Please be present, and I would like also to ask the chair to be on time to allow the program to finish on time in the evening. Thank you.
Thank you for Dr. Bruno for his speech. And now I would like to invite Dr. Robert Hoffman, the Chief of Minotaur's Abstract Committee.
Hello. So like Bruno, I don't have much to say, but I do want to say again on behalf of our organization, thanks to our hosts here in Turkey. This is fantastic, and we're happy to be here. For the abstracts, again this year we've had an increase in the number of abstracts that were submitted, which is really encouraging. We've also had a noticeable increase in the quality of abstracts, including abstracts that are really more scientific than case report and otherwise. It was pleasing to see that these are predominantly actually from Turkey, so many very good, outstanding abstracts from Turkey. As every year, we're limited in the number we're able to have presented. So it's always a difficult decision how many to include and how many to not include. But we're pleased with the content that you're going to see, both in our e-abstracts or our e-posters and then in the oral presentations. One thing that we're looking forward to this year is the best abstracts that we have are going to actually expected to be published probably within the next 6 months. But I think again our hosts as well as everybody who submitted abstracts and everyone attending, I encourage you to attend the oral research session or take a look at the e-posters when they're displayed. Thank you.
Thank you to Dr. Robert Hoffman. And now I would like to invite Dr. Ashish and Dr. Praveen for their opening speeches.
Thank you, Minotaurs. I'm not going to give any opening speech. Let me make that clear. Dr. Praveen Agrawal, Chief of Emergency Medicine at AIIMS in New Delhi, and I'm Ashish Palla from PGI Chandigarh, Professor of Medicine and toxicologist. Also here representing Asia Pacific Association of Medical Toxicology as the President of Asia Pacific Association. We are here on behalf of Academic College of Emergency Medicine of India and WASEM. We are here to honor our 2 dear friends, Dr. Ziad and Dr. Basar, and we just want you to please come on to the dais so that we can honor you. This is our traditional way in India to honor our loved ones. So thank you very much.
Thank you. Cousin, I forgot that WASEM, very big organization for us, and we are the part of WASEM, and I have very good news about WASEM Congress, but I don't give now. I don't give now, but we are the leader of WASEM together with Sagar and your organization. Thank you very much, and say hello to all WASEM. Thank you.
Thank you. And I also forgot to thank Integral Global Consulting. Mr. Nabil Ahmad, can you please stand up in the back? Integral Global Consulting has partnered with us and provided support to develop the outbreak investigation workshop, which is happening on Friday. It's been a pleasure to working with Nabil and his team, Jackie and Hannah. Thank you.
So now we'll continue with our scientific program, and we have two plenary lectures. So I'm very happy to introduce Dr. Kai Kehe. He's from Munich. He's a specialist of chemical poisoning, and he will talk about sulfur mustard poisoning toxicity and management. Kai worked with Horst Thiermann in the Bundeswehr in Munich, and he performed several experimental studies on chemical weapon toxicity, and he has probably very interesting original data regarding sulfur mustard complications in case of exposure, and he will communicate this. And I think that this is really an important issue for us in the MENA region. Thank you very much, Kai, coming to Istanbul.
Yeah, thank you. First of all, I have to confess that this is the first scientific session which was introduced by the Pirates of the Caribbean main theme. I hope that you are not disappointed that I'm not Jack Sparrow, Captain Jack Sparrow. I'm Colonel Kier from Germany, and I'm a medical doctor and a specialization in toxicology, and I started my research with sulfur mustard back to 1996, and now I'm head of the medical CBN defense in Germany, and and I want to thank the organizers that they give me the opportunity to give you to share you some experience from Germany about sulfur. Oh, the pointer. I don't know whether you can see the pointer. Very low light. No. Okay, perhaps I can describe it. First of all, I want to introduce you a little bit with sulfur mustard. Sulfur mustard is an old chemical warfare agent introduced in the battlefield, unfortunately, by the Germans in the First World War. It is an oily liquid, which is very important. It has a boiling point, 215 degrees Celsius, and it has a vapor pressure, which means that in humid conditions it produces some important vapor, and it is heavier than air, and what is the main characteristic why it is used as a battlefield agent, it easily can cross the clothes. This is what I show you later in the cases I will present. Synonyms are ypyrit or Senf gas, which is the German name, or mustard gas, which is the English name, which is a typical odor, which is caused by the technical impurity. The highly distilled sulfur mustard has no real odor, but technical produced mustard has a typical mustard-like or reddish-like odor. And it's also called H, or abbreviated HD, which is the abbreviation from Hansstoff. Also Hans were the name of the Germans in the First World War, and the distilled version is HD. This is the NATO abbreviation. The molecular toxicology, or what we think one of the most important events in the cell is alkylation of the DNA. You can see sulfur mustard, which can produce a sulfonium ion, which easily can react with guanine in the DNA to form a monoadduct, which you can see at the lower part of the slide. As it has two reactive sites, it can form also crosslinks. It can crosslink the DNA. And the crosslinks of the DNA is the main reason why cell division is impaired. And, and this can cause DNA breaks and also holds responsible for some mutations. what we believe. And from this molecular toxicology, you can easily understand that rapidly dividing cells are mostly affected. And where are rapidly dividing cells? These rapidly dividing cells are, for example, in the skin, at the stratum basale. The keratinocytes are the most vulnerable part of the body, and later also the blood stem cells. But sulfur mustard does not only react with the DNA, it can react with each part of the cell. It can react with even with water, forming thioglycol, which you can measure in the urine, for example, as a simple biomarker. It can react with the RNA, with proteins, and also with enzymes. For example, hexokinase is one of the most susceptible proteins. Therefore, sulfur mustard can impair the glycolysis in the cell, which was found in the 40s. Taken together, when rapidly dividing cells are affected mostly and glycolysis is inhibited, this is one of the two reasons why this agent is a prototype of modern chemotherapeutic agents, like, for example, cyclophosphamide, which has also the reactive ethyl chloride group. And we believe that DNA mutations can cause cancer, but I can show you later more effects, and also the long-term effects are important, and we are still, it is a matter of ongoing research what is the most relevant mechanisms. But now I want to focus on keratinocytes. Keratinocytes roughly can have several roads to death. They can, after sulfur mustard injury, can go into necrosis. They can die via apoptosis. You can find reproductive cell death and also programmed cell death in form of terminal differentiation. And this is important because this is an effect on wound healing. First of all, the forming of the wound is an effect of apoptosis and necrosis, and the wound healing, which needs proliferation of cells, is impaired. And also, you can find a higher rate of differentiation in the surrounding tissue. And this is the reason why sulfur mustard burns, who looks like, for example, they look very similar to sunburns or chemical burns, but this molecular mechanism is the reason why sulfur mustard burns heal more slowly than, for example, compared to sunburns. A sulfur mustard burn needs around about 1 month to get closed. And these are the macroscopic cutaneous signs. You can find blisters, ulcerations, and erythema. The intoxication starts after several hours with erythema. You can see erythema when it is a vapor exposure on the front chest and also in the axilla and then the genitoanal region, which are moist skin regions. The vapor crosses the sclerosis, and when the skin is moist and there are a lot of hair, it can go deep into the skin and cause this damage, and it starts with erythema, and after a while you can find blisters, which you see on the upper left side, which are thin walled blisters, and then when it is a severe burn, also ulceration. And interestingly, the microscopic feature of this sulfur mustard burn is a clear split between epidermis and dermis. Therefore, the separation of the epidermis from the dermis is the most striking histological feature, and it is still a matter of debate why this small molecule can cause such a specific histopathological sign. And when you look more in detail, you can find a split in 3 regions, which are in the region of the hemidesmosomes and the lamina densa. You can see that whether you see the red line, and where the red line is, there is the split of the epidermal junction. And this correlates very well with laminin 5 degradation and MMP9 activation. MMP9 activation is, I'll come back to this later, which is possibly a therapeutic target. The long-term effects are also very interesting. They are mostly published by our Iranian colleagues, and they describe neoplasms, mostly sherry-like hemangioma in the, on the skin, on the exposure sites, and also some forms of hyper and hypopigmentation of the skin, which you can see on the right side. And also various forms of scarring can occur and can cause disabilities in the patients. But keep in mind, sherry-like hemangioma is an important sign, which means that vessel disturbances are a very important sign. These are the eye lesions, which start with photophobia and inflammation, and this and a blepharospasm, and which is so painful to the patient that they cannot actively open the eye. And when you look at the pictures from the First World War, you can see so-called blinded soldiers guided from the battlefield, and this is the reason what they have encountered, that the eye is a very susceptible organ, and they are blinded. Luckily, 80% of the patients do not suffer from long-term effects, but 20% of them suffer from some corneal erosions, which can persist over decades. And this is mostly responsible to the limbal stem cell defect, which occur in these patients too. And the Iranian medical community published some data that after transplantation and also with limbal stem cells, you can achieve a better outcome for the patients. And sulfur-mustard-induced lung injury is also a severe injury. It starts with coughing, with some infections and inflammation, and also a so-called pseudomembrane formation, which can be a life-threatening effect. Pseudomembrane formation means that the trachea, the epithelia of the trachea can also form a blister, and the epithelium gets off the wall and can obstruct airways. After a while, these defects are replaced by, not by an epithelium with mucociliary function. It is a normal epithelium. You have no mucociliary clearance, and you have a scarring, which you can see on the downstairs on the left side, which is red encircled, and you can see a scarring and narrowing of the airways, which can impair the patients very well. I've had the opportunity to see these patients in Tehran, and some of them were not able to walk 10 meters without shortness of breath, which is really, they were really in bad condition. I think this is the most disabling late effect in these patients, and we have to take care of them. And also, you can see blood vessel disturbances and malformations in these patients, and when you make a bronchoscopy, they start bleeding. In late effects, they start bleedings, and they have also coughing with blood, but not, this is not a sign of malignancy, interestingly. And these are patients from nowadays, which this is a patient from Syria. Unfortunately, in the southern part here of Turkey and Syria, chemical warfares are used, and And I have to thank here the Turkish medical doctors that they take care of these patients, and they do a tremendous job. And they publish also and share also the data with us, which is very important to learn about this poisoning. But I do not want to focus on these patients. I want to show you some patients from Germany. As you've seen in Syria, there were a lot of sulfur mustard present, and as Syria signed the OPCW treaty, all the chemical warfare agent stockpiles, especially sulfur mustard, were destroyed by a ship, the Cape Ray, from US. And the hydrolysis product was shipped to Germany to get rid of these waste and of the burns. And this is the facility in Germany where it was done, and you have these barrels with the waste, and if you destroy 99.9% of a chemical warfare agent, 0.1% is still active. You have to keep it in mind. And this has happened here. When they put it to the oven, was a higher temperature, and there was a malfunctioning of burning. 3 persons were in the room. The oven temperature was 150 degrees, the room temperature over 30 degrees. And then the active sulfur mustard, which was still present, started to evaporate, and we estimated an exposure time of 15 minutes. This is the equipment we normally use. The workers had a mask on, had gloves on, and also some boots, but no adequate PPE, no adequate personal protective equipment. And this is why this agent was developed for. In the First World War, all the soldiers were equipped with a gas mask, but this agent was designed to cross the clothes, which I mentioned before. Therefore, because of this non-proper protection, the patients get a burn, which looked like a sunburn. The symptoms developed 2 to 4 hours later and started with the erythema of the chest and the neck. And this is some pictures of them, and also the buttocks. You can see some blister formation, and also at the arms and at the axilla, and also where the gas mask was not present in the hair. Therefore, this is very, very typical, and I have to go back, unfortunately. And they were treated with flamazine, which is a sulfonamide silver cream, corticoid, and diclofenac oral. This was quite good, but from the point of the patients, not good enough. They still suffered some pain, especially from the genitoanal, or from the scrotal effect, because this is also a very moist region of the human body, and has a lot of hair, and therefore this is very susceptible to sulfur mustard. And when there's a burn, it hurts very much, and the soldiers cannot march anymore. This is one of the reasons why it was very disabling for soldiers. And we had a discussion in Germany whether this was really a sulfur mustard burn. Some guys argued this could be also perhaps a chemical intoxication of the waste. And the lab of Professor Thiermann is an accredited lab from the OPCW, therefore this lab can confirm sulfur mustard poisoning via degradation products in urine, which is from the beta-lyase degradation product, which is this is more specific than thiodiglycol, which I mentioned before, and also sulfur mustard albumin adducts. And as you can here clearly see in the depicted picture, is that there were some distinct pattern and also specific adducts in these patients. Therefore, we can be sure that these burns we observed in these workers were really, really sulfur mustard burns. And taken together, you have a typical clinical picture. You have a sunburn like erythema. You have thin-walled blisters, and we were able to confirm the diagnosis with a specific lab diagnostic. And now I want to come to another important issue, that is epigenetic. Epigenetic is, for those who are not so familiar with this, is very important to maintain tissue identity. For example, if skin cells divide, they remain skin cells. And if kidney cells divide, they remain kidney cells. But all of the cells, all these cells have the same identical DNA code. And why can a cell be sure that it is a skin cell and not a kidney cell? This is because of epigenetic. And epigenetic are several marks on histones and DNA, and these markers hold responsible for the tissue identity. And it can also, we have writers and erasers and readers of these marks, and if this epigenetic code is disturbed, for example, by toxic substances, it can, for example, activate oncogenes. And this is, beside mutation, another reason for neoplasms. And therefore, we digged a little bit deeper into this research, whether sulfur mustard can also induce epigenetic disturbances. And we have several proteins and which can hold responsible for these, as I showed, for these markers, which are stick to the DNA and the histones. And I do not read all these epigenetic modulators. Perhaps to keep in mind that the DNA methyltransferase is important, as well as the histone acetyl transferase. And when you look at the color code, we found an upregulation of several of these modulators in the in cells which are treated with sulfur mustard, with 1.01 micromolar sulfur mustard or 0.5 micromolar sulfur mustard. To give you a feeling what this dose means, 100 micromolar is the so-called blistering concentration. This is factor 100 below the blistering concentration. And exposure with 1 micromolar is a light reddening of the skin. And this light exposure really upregulates DNA methyltransferase. Therefore, we can expect some disturbances in the epigenetic code. And I show you this in the patient. We have had a patient in Germany, 2012, which was a lab technician who unfortunately synthesized sulfur mustard in a lab. And this synthesis did not went well, and there was a leakage in his synthesis apparatus, and a small drop of sulfur mustard hit his lab coat. A small drop hit his lab coat. And this little drop was able to cross the clothes, to come to his belly, and when it touches the belly, it starts to evaporate. And when the evaporation starts, the mustard gas will diffuse to all regions it can reach. And this is what happened. This is where the drop hits the skin, and you see the arrows where it can move on. And therefore, even if it is a little drop on the skin here, you have a reddening everywhere where there's some space below the clothes. This is a really interesting picture. And to show you the outcome of the patient, you see the a little bit disappointing that I have no pointer here. at one day you have a reddening and a blistering formation, and it's on day 8 you see a severe defect on the skin. And this huge defect and huge burn, which showed no tendency to heal because of the, as I told you, you have a reproductive death. The skin cells are at the root edge are not dividing, and therefore you had to get rid of these skin cells. And this is done by surgery. And it was excised, this region, and then the patient received a skin transplant from the thick, which you can see on day 20. And then 4 weeks, 8 weeks, 15 weeks, and 1 year later, you can still see the defect. Some other pictures, it's 15 weeks after split skin graft, and also he had a sign on the left forearm which was not treated. You can see the difference, and this is 1 year after it. And then we were interested whether there were some epigenetic changes, as I told you before. And this was a patient who was worthwhile to investigate, because we were able to get some skin samples from exposed sites, from vapor, which is the upper red arrow, and the wound edge, which is the lower red arrow. And you can see a upregulation or a higher content of 5-methylcytosine, which is a DNA tag on the DNA, which is a tag, a cytosine tag, a methyl tag on the cytosine of the DNA. And this is really a striking upregulation. And when you look at the center of the transplant, which was from the unexposed side of the body and transplanted to this region, it is no significant upregulation. Therefore, 1 year after exposure, we can clearly see an upregulation or a higher methylation rate of the DNA, which can cause perhaps some late effects, and which can be perhaps a cause for DNA, for neoplasms, which can perhaps occur, or these cherry-like hemangioma, which I described before. Now, come to the end. This is the, I've summarized the gross pathology, microscopic pathology, and the molecular pathology. And when you look at these events, I will skip forward. You have several potential therapeutic options. You can use scavengers like N-acetylcysteine. You can modulate cell death by caspase inhibitors or PARP inhibitors, which was not successful. You can try to use MMP inhibitors, like, for example, doxycycline, to prevent blister formation. Also inflammation, anti-inflammatory drug like steroids, non-steroids, and analgesia is important in surgery. And up to today, only these options are still in use at the moment. This is N-acetylcysteine, which is believed to be has to be some scavenging effect. Steroids, non-steroidal anti-inflammatory drugs like diclofenac, or it's also important to have some analgesia, and also surgery. And the way ahead is, if you look at epigenetic modifications to have some therapeutic options to prevent, for example, long-term effects. It is interesting that at the moment we have development of epigenetic modulators. This is mostly in the context of chemotherapy, and we tried to use a DNA methyltransferase inhibitor, because this was what we have found in our patient, that the DNA methyltransferase was upregulated, And there's a drug which is called decitabine. And in cell culture, it is very effective to prevent these methylcytosine. But in fact, it is for clinical use, it is not possible because this is also a nucleotide and has some similar side effects as sulfur mustard by itself, and therefore I think it's not useful, but as a proof of principle, it is worth to think about these kind of drugs for further development and therapy. And now I'm at the end of my talk, and if you have some questions, I'm happy to answer it.
Okay. Are there any questions from the floor? Ziad, the first question.
Thank you. Thank you, Dr. Kehe, for a great presentation. I'm involved in a NIH-funded center for arsenicals, for lewisite.
Yeah.
I'm not a bench scientist. I'm more involved in the education side. But I want to ask you, our researchers are finding a role for the unfolded protein response signaling. So the unfolding of proteins causing the damage, the cell damage. And then we are looking at antidotes, we call them chemical chaperones, that can stop the unfolding process. Have you seen anything like that inside in the sulfur mustard mechanisms, or are they different mechanisms? Between lewisite and sulfur mustard?
Yeah, first of all, lewisite and sulfur mustard are very distinct. They have some similarities in the clinical pictures, but they have a very different molecular toxicology. Yeah? And lewisite attacks the pyruvate dehydrogenase. And as you mentioned chaperones, I think this was also investigated in sulfur mustard injury, but I'm not aware of any further experimental data on this issue. It is still worth to look at it, because sulfur mustard has such a broad mode of action, and you cannot exclude what is really going on. But sometimes it's very difficult to identify what is the most relevant mechanism. This is true. No? But I'm not aware that somebody has really done research on this. Yeah? Yeah. Please.
Thank you. My question, are there any clinical bronchogenic carcinoma because of my people exposed to sulfur mustard during their war with ISIS? And of course, we gave them anacetyl and capsule.
I'm sorry, I can hear you.
Can you speak more loudly?
A little bit more up or more directly?
Yeah. Are there any clinical data that support that the use of anacetyl will decrease the bronchogenic carcinoma in the future? Or just it is from theoretical point of view?
He's asking if mucinous and anacetyl can be used to prevent the long-term effects.
Oh, yeah, effective. I can tell you what I believe. As I told you, sulfur mustard is a very lipophilic drug. There are some data which are published which can show that sulfur mustard is stored in the lipid depot, and there it can be redistributed. And sometimes when you look at the toxicokinetic, you can see a degradation and then an up and down. And as acetylcysteine is a scavenger with an SH group, it can catch free sulfur mustard, but it has to be administered very fast. And when this scavenging effect is, when you administer it very fast and you have this scavenging effect, then it can also prevent long-term effects, and then it is useful. However, most of the patients do not reach the clinic in time. And this is perhaps more for a military setting when you use that the enemy is using perhaps sulfur mustard, then the medical doctors in the field have N-acetylcysteine readily available, then it would be of advantage. But in, for example, Syria or a terrorist attack, when there's a population hit which is not protected and you need a lot of time to get it into the hospital, I don't think that N-acetylcysteine is really of beneficial effect.
Thank you.
Thank you for your presentation. It was interesting to me. I have a question about the decitabine. You mentioned about the targeted therapy. Yeah. Do you have any drug repurposing research studies for decitabine in your institution for the sulfur mustard poisoning?
We are at the moment launching a new program and try to fund it, and then perhaps we can dig a little bit deeper. But at the moment we have only data to decitabine.
Okay, thank you very much.
I have not understand. Your center was in charge to destroy the sulfur mustard from Syria. That's it?
It was a degradation product. The sulfur mustard was hydrolyzed on the ship.
On the ship.
The Cape Ray.
Okay.
And as they stated that 99% was destroyed, the waste was shipped to Germany. But there was still some active agent in it because there was 0.1% left. Which
so it was brought to your center?
Yes.
For which purposes?
To burn it.
To burn it.
Yeah.
And how
to destroy it?
And how was it possible that 2 employees were contaminated? Because you
This was a they were silly. I think
because I thought that the Bundeswehr is very specialized in this field.
We were also very surprised about this fact. I must confess. Normally they stick to the rules and they have to wear a proper equipment, but unfortunately it was too hot. Yeah, this is the reason. It was too hot for them, and then they did it the easy way, and this was a lecture they've learned.
So that means that even in the most famous center that is specialized on chemical warfare and with trained personnel, it's possible to make mistakes and to be contaminated.
Everywhere where a human being is, you can have an error. That's also machines can make errors.
And by burning the product, you eliminate 100% of everything.
Normally, it was signed that it was totally destroyed, and this is a question: how clean is clean, or how much it is destroyed? And as we have learned from this lesson, is that when we destroy most, really 99% of the agent, there's still something left on the walls, for example, of the containment, that because it's very sticky, sulfur mustard, that can survive hydrolysis. And this is when you get it off, it can evaporate. And if you have several tons, and we speak about 100 tons, then you have a little amount.
Okay.
Which is...
Last question, please.
Thank you. I was thinking about treatment with cyclophosphamide, which is a much less toxic alkylating agent, but still, I think, more or less the same mechanism.
Yes.
And of course, we hydrate those patients. I didn't see that as a treatment, or for acute emergency treatment. Would that be one of your suggestions? And the other question is, do you think there's enough evidence now to recommend skin grafting in essentially all affected areas after 1 year? I know you've done it. It looks like a good idea. Would you recommend it universally? So 2 questions, sorry.
Yeah, two questions. As we have seen, these patients, especially the last one, had a quite heavily burned, but there was no need for hydration. Yeah, has a balanced fluid. I think, yeah, I think it's worth to think about it. But I haven't read it in any recommendation so far. Yeah? This is necessary. And the second question about these skin grafting. If you have a single patient with such a severe burn, you can do it, but I would not recommend it universally. For example, the first patients I've shown, this were like sunburns, and they quickly recover, and there's no need to make any transplant. But when this is a deep burn, which touches also the dermal tissue, then I think there's a need to make a transplant, because the wound healing is very much impaired in these patients. Also, because we are a Western country and most of the people are really often concerned. This patient, the last patient, he had really a concern about neoplasm. He Googled sulfur mustard and has seen some reports about malignancies, and therefore he underwent a second surgery, and it was, even this transplant was excised more deeply down to the muscle, because he was so scared about it. Yeah. By the way, I asked him, where did you get this, the synthesis route from? And he answered, from Wikipedia. I can say that I tried to delete it in the German version of Wikipedia several times, but it pops up from other guys and you cannot get rid of the information. Yeah? That's the internet. Yeah.
Okay, thank you very much.
Guidelines, please.
Thank you very much.
I'm sorry. I would like to introduce him. He is chair of a scientific committee of APAT, and he's from the Department of Clinical Toxicology, Lokman Hakim Hospital, Shadid Behçeti University, University of Medical Sciences in Iran. Okay.
Thank you very much for inviting me, and thank you very much for organizing committee to have this great conference and sharing our knowledge and our experience together. Okay. No, this is off. It is off. Could you please turn it on? Okay. No problem.
Sorry, Hussein.
No,
you have to turn your back. If you prefer to sit here, you have the screen.
No, that's okay. That's okay. Thank you. Actually, why we are trying to describe the methanol outbreak here, because the MENA region, including Iran, Turkey, Afghanistan, and other neighboring countries, are involved in methanol toxicity outbreaks from recent years, and we had a lot of fatality after those outbreaks, and we had no guideline how to manage them. So I'm not focusing on the personal treatments of every patient. I'm focusing on public health issues of methanol outbreaks and how we as a physician should deal with methanol outbreaks. So it doesn't work. Thank you. So I should declare that I have no conflict of interest. The importance of this issue is that if we work on the patients and if we treat them, we have a good outcome. especially in early hours. But if we postpone the treatment, we will face a huge amount of mortality because of the delay. And usually there are some prognostic factors that can determine the outcome. And on top of the reasons of those prognostic factors is significant delay of presenting patients to the hospitals. So why the patients are not going to be treated appropriately? Because of the knowledge of the physicians who are involved in treating these patients, and also because of lab facilities, because in most of the our lab infrastructures, we haven't had rapid access to determination of methanol in the blood or in the serum of the patients. So usually we act based on the clinical scenario. And also because there are some special concern about the patients. Many of them, especially in Islamic countries, are in fear of punishment, and they think that if they go to the healthcare facilities, they may encounter with police and on other legal punishments. Especially this story is happening in Iran, in Indonesia, and maybe in Pakistan or other neighboring or other Islamic countries. And also, we are not in the process of case finding for our patients, because usually we, as a physician, we usually just see the patients itself. We wanted to treat the patients just in the emergency department. We are not aware of the out of the hospital. We are not aware of the other people who may come to you. So somehow when they are coming to hospital, they are in a severe and bad position. So we should use our resources. We should use our hemodialysis machines. And in some cases that the epidemic is huge, you cannot use that amount of hemodialysis machines. For example, for 300 patients, you cannot use a lot of hemodialysis machine because your facilities and your resources are completely limited. So we should have a plan. And this plan can be extended to the other toxicological outbreaks as well. And also, there are some vague signs and symptoms of methanol toxicity, especially for young physicians and for unexperienced physicians who haven't seen such ill patients, because most of the time they can come in early stages. And unfortunately, we had such a problem that many of them released after coming to the hospitals, and and even some of them died after leaving the hospital because they hadn't had a good differential diagnosis in terms of their clinical manifestations. And also, lack of enough communication is one of the worst things that we as clinical physicians are encountering. We cannot communicate with our governmental side. We cannot warn them when and what is happening in the future. And sometimes they cannot rely to us because they are in fear of something else in terms of policy and the other stuff. So all of Okay, thank you. Sorry. So all of those stuff may prohibit us from prompt triage and treatment in appropriate time. And you can see that in the next hours, the number of casualties will be increased dramatically because of lack of those stuff. I took this picture from 1 week ago. Exactly at February 12th. We had an outbreak in south of Iran, and 27 patients were involved, of whom 7 died. And this was the responsible alcohol. This is an illegal alcohol that they were selling it in the city as an Acil vodka, and the price was almost $1.50 US, and in 500 milliliters. So many people were interested that someone was kind enough to them and offered them something good. So they start to drinking it, and you can see our patients over there that finally 7 died. This is a small example of a methanol outbreak. It is not just happening in the countries that alcohol is prohibited. It can be seen in even European countries. We had similar outbreaks in Norway, in Czech Republic, and also in the other places because of the tax of alcohol. So because the price of alcohol is high in those communities, many poor people prefer to drink non-standard alcohols. So drinking non-standard alcohols can create methanol poisoning. I want to explain briefly what is happening in an outbreak. You know, here, when you're facing with just one patient, you may have all of things that is necessary for treating a patient, including hemodialysis machine and including antidotes. I'm not focusing on different antidotes, including fomepizole or ethanol, but most of the time we are using ethanol, and statistics shows that there is no difference in terms of outcome between those who use the fomepizole and those who use ethanol. Just using ethanol is more difficult because we should have regular measurements of ethanol for the patients, so it needs more close monitoring than using fomepizole. But the outcome is not so different, as I said, and as the literature actually shows. Just after a while, if an outbreak is happening, you will face a lot of people that are coming to your healthcare facility with no antidote or with limited antidotes. Why it is happening? Because we are not prepared. And because probably you have lost most of your supply in the past for treating of the patients who were not in need of those antidotes. This is our experience in using media to aware people regarding a methanol outbreak. Actually, almost 4 years ago, we had a large outbreak in central Iran, and in the first hours, we have noticed that content of illegal alcohol is distributed in city, and many people actually bought it and started drinking it. So a huge number of people were in danger of methanol outbreak. So after several cases that came to the hospital, we start to alarming the people by sending SMS, by using media including TV and radio, and even in some places by using loudspeakers to aware people that an illegal alcohol is distributed. And the result was very good, because out of 700 methanol poison cases, just 10 cases died. And this is the less, actually, number of mortality among methanol poisoning outbreaks in the world, just by public health concern. We had no access to fomepizole, just we had access to ethanol and also hemodialysis. So, we invite several experts from all over the world to contribute their knowledge and their experience. Most of them were involved in previous outbreaks in their own country, to have a consensus guideline, an international consensus guideline, on how to manage a methanol outbreak. So we gathered together to agree on a definition of methanol poisoning and outbreak, and outline an approach to triaging a methanol outbreak, and define a criteria for prioritizing antidotes, hemodialysis, or totally extracorporeal eliminations, and also indication for transferring the patients. This is not the case for all methanol outbreaks. Sometimes you are in lack of enough facility, and the number of people that are coming to you to your center is much bigger than your capacity. So you have to call the other centers, you have to call the other colleagues and ask them to help you. First, we reviewed the literature and collect enough data from previous outbreaks, and we developed a Delphi method to see the opinion of different experts in different subjects of methanol outbreak. And you see the open label questionnaire that we collected to gather all the data. It was not a simple task. It takes around 6 years because of the huge difference between treatment strategies, and also because of different experiences in different countries. So we asked them to define the methanol outbreak. What is a methanol outbreak? How many people should be involved to call them it is a methanol outbreak? Because after defining a methanol outbreak, you should do something to aware the other people and to bring them to hospital in advance in order to prevent further consequences of severe illness. And we asked them if we should have an active case-finding strategy. We asked them to define who is responsible for case-finding and communication in this context, what method should be used for case-finding, and how to avoid overcrowding of healthcare facilities. It's very important to define an outbreak or not to define an outbreak. Because when you define an outbreak, you should be prepared, and many people may come to you, and you may overestimate the situation, and you may lose those people who are really involved. So it is very important to define it. And also regarding diagnosis of methanol poisoning, we asked them to define how to triage the patients, to prioritize them, because in those outbreaks our facilities are limited. If it is necessary and useful, how can we triage the methanol poison patients? And also, if an outbreak is happening in a poor and limited resources area, what should be done? Are there any existing triage system in terms of outbreak, like something like poison severity score relevant to methanol, but we couldn't find? Are there any ethical implication for triaging patients? Because by triaging patients, somehow you know that you are reducing the chance of survival for ill patients because of lack of facilities. But you should decide. It's like the other triaging system. We should define who should be prioritized. And administration of antidotes, regarding administration of extracorporeal eliminations, and also regarding transferring of the patients in special circumstances. So we asked them, the experts, to define the level of evidence and if they have any reference to their recommendations. So we categorize the consensus in 4 levels. Level 1 was strong recommendation. We recommend something if they agreed more than 95% of the cases. And we suggest something if it was between 90 and 95. And finally, we had another category. It was a neutral recommendation between 50 and 90%. And in these cases, it would be reasonable to suggest something for the other physicians. And finally, in some cases, we had no recommendation. So after a lot of rounds, it came to us that in order to define a methanol outbreak, we should have the previous history of methanol poisoning in that area. So an outbreak actually is defined based on what is happening in the past and what you expect in the same time, in a limited geographical area. If we haven't any data for the past, simply we make a consensus that more than 3% using methanol and affected by methanol, we would face a methanol outbreak if it is coming from a common source. In terms of, and usually it is happening within a limited time, usually less than 48 to 72 hours. And regarding notification of public and health system to the onset of methanol poisoning outbreak and active case finding, we suggest that the context of methanol poisoning happening, an active case finding should be undertaken. We should follow the other people that are not in the hospital, and probably they will come to the hospital in next hours. I can treat a methanol poison patient just by a drink of ethanol in early stages, but I cannot treat the similar patients if she or he came to me after, for example, 24 hours, even by hemodialysis, even by using fomepizole. So the outcome is completely different. So we should seek for the patients. We should not sit there in the emergency department, and we should involve the other institutions that are concerned about the public health problems of the region. And we suggest who should actually collect this data and warn the other people. We suggest that the governmental health authorities should be responsible for active case findings of poisoned individual patients who are not presented to the hospital. In terms of triage, it would be reasonable to use a triage system in the context of methanol poisoning outbreak, and we recommend this triage system should be depend on level of consciousness and also pH of patients on arrival time. Because these two factors are the main factors that can determine the outcome of the patients. I will show you in the next graph that how it would be affect the final outcome of poison patients. And regarding administration of antidote, we recommend that patients with a high probability of methanol poisoning drug are promptly administered an antidote, right? Further assessment is needed. Actually, there are some data, especially from Czech Republic outbreak, that those who actually drink ethanol before coming to hospital, they all survived and nobody was blind. It's focus, it's stress on the importance of early administration of antidotes. These days, actually, we as an Islamic country, convince our Ministry of Health to have ethanol as an antidote in the ambulances. It was very difficult for us to convince an Islamic government like this, but at least they know that we are using this ethanol in order to treat the patients. So they accept, fortunately, and I hope that we haven't had a lot of abuse from the ambulance crew. Even if it happens, it's no matter. In this case, they are using a safe drink. Yeah, we have it already in the hospital. So in the past, we could use the ethanol in the hospitals. But the problem is that when you want to administer ethanol to patients, you should determine that this is a methanol poison patient, and you have not enough facility to determine this is a methanol poison cases. So in these cases, actually, we are postponing administration of antidote to our patients, and the outcome would not be good. And we recommended that, this is very important, that's why I highlighted it. We recommend that antidote administration should occur in the pre-hospital setting, where possible. And also we recommend that in even both fomepizole and ethanol, if they are both available, but in limited supply, patients with more severe poisoning receive fomepizole, and that lesser poisoned patients can be given ethanol. Because the outcomes are the same, but monitoring of fomepizole is much, much easier than monitoring of administration of ethanol. Also, we recommended that patients who are pregnant or less than 14 years old should be prioritized to receive fomepizole. We recommend that sufficient amount of fomepizole, if available, the patients at high risk of toxicity but not current acidosis or end organ damage should receive fomepizole, because fomepizole can prevent hemodialysis. We recommend that in any patients requiring antidote treatment should be receive optimal treatment with bicarbonate, folinic acid, and supportive treatment as necessary. This is very informative graph, and we collect all the data from, I think, 7 centers. We pulled it all together, and you can see this beautiful graph. All the outcomes, in spite of using antidotes, depends on 2 main factors. First, on arrival coma state, and second, pH. You can see in the right side that those people who were not comatose, maximally 25% died, in maximum. You can see risk A, risk B, and risk C. These categories are those who were not comatose. And those who were comatose, at least 42% died. And when we merge them, I mean the comatose state, with pH, you can see those who had a pH less than 6.74, almost all of them died. You can see 83% died. And the remaining, I mean 70%, were blind, if they survive. So we have a big data of methanol poison cases that were treated, and that we could determine that, and we could categorize them based on pH and based on the coma state. And you can see, for example, if in group A, in a risk A group, if they come to you with a pH more than 7, and they are not comatose, just only 5% died. So we could determine that something is happening in the future, and we could have a plan to prioritize patients based on this categorization. So we had some recommendation based on those consensus and based on those facts. We recommended that use what you have. We couldn't determine that which country should use which antidote. It depends on the availability of antidotes and also based on your infrastructures. So our recommendations was a general recommendation, but it was a good guideline for people who are treating and who are involved in the different methanol outbreaks. We recommend that prioritize dialysis for those who had visual disturbances, particularly who are deciding between patients within the same group. Also, we recommended that those people who are in category 3. Category 3 means refers to actually the pink category. Is the highest priority for extracorporeal therapy in context of methanol poisoning if the dialysis machine is not enough and it's not available enough. And finally, the worst group should be the next prioritized group for hemodialysis. And group 1, that group that had the little amount of mortality, little rate of mortality, is the lowest priority for hemodialysis, and because we could treat them with antidotes. And finally, those decisions about extracorporeal therapy follows the requirement that all patients have received optimal treatment, notably antidote, bicarbonate, and other supportive cares, and folinic acid. We had the same strategy for transferring the patients. Those can be transferred, who we can provide enough and optimal care during transfer, and who are not very severe and ill. And that was the general recommendation, and these guys are our co-author in publishing the consensus guideline on clinical toxicology in 2019. And if you have any question, I'm ready to answer, and you can refer to this references.
Dr. Hassan Hussein, thank you for your interesting presentation. And I would like to say that almost 2 months ago, our country prevented a methanol outbreak. They arrested the people who produced illegal ethyl alcoholic drink, more than 1 million bottles, and I think they prevented the big outbreak, methanol poisoning outbreak. Thank you. And I have a question about that. Do you have in your consensus guideline, do you have any guideline for dosing antidotes for both ethanol and fomepizole?
As I said, we are not. We have mentioned the dose, but it is a general recommendation. Just
general, yeah.
we were focusing on the public health.
No,
yeah.
do you have not any specific? Thank you. Do you have any questions, please? We can't hear, please.
Hello? Hi. I'm Dr. Razan. I work in Kuwait. You mentioned that you have ethanol in the ambulances. So are your paramedics actually trained to
We recommend
ethanol?
to have ethanol in ambulances.
Okay.
Not in the routine.
So you don't have it currently, but
yeah, it's legal.
It is legal. So who's the person who
drinking alcohol is not legal in my country.
I know, I understand.
Using alcohol as an antidote is legal.
Yeah, I understand. But I mean, are the paramedics trained to identify methanol toxicity?
In case of methanol outbreak, we are somehow over-treating the patients. And it is not a matter of issue. So no matter, because in an outbreak, we have to prevent further consequences, and maybe you are treating patients more than what is expected to treat. So actually, we expect to treat patients more than usual in an outbreak, and it's not a matter of issue. Because in this way, you're preventing, even when you're suspicious about the methanol outbreak, methanol poison cases, we can start ethanol as a treatment.
Okay, thank you.
Welcome.
Any questions? Okay.
Thank you for your presentation. I am Dr. Tariq Al-Rifai. I'm the past director of Syrian National Poison Center, the oldest poison center in the whole MENA-TOX region. I am surprised it's not represented in here. We have the same outbreak in 2003, plus 127 cases.
Can you please talk loudly?
Okay, we have the same outbreak in Syria, 2003. It was 127 cases. It was homemade methanol, which is, I think it's a special situation because homemade is a mix of almost of 3 kinds of alcohols, ethylene glycol and methanol and ethanol, which is make it toxic time bombs because the ethanol is there and the level which is not enough to prevent methanol toxicity. You know, we give ethanol up to make the serum level up to 100 and above. So the outcome was very bad. It was 25 died and similar number bilateral permanent blindness.
This is the problem of ethanol administrations because you have to, as you said, you have to measure the ethanol concentration in the blood in order to see if the enzyme is blocked and the methanol can be excreted without any change. So, but in the other hand, the price of the fomepizole is very high, and you should take it in advance. I mean, you cannot wait if you have ethanol. You cannot wait to see, I'm looking for fomepizole because fomepizole is a better antidote. You have to start the ethanol.
Yes,
Whatever
of course, and the fomepizole, you know, it's very expensive.
And we have some tricky ways to measure the ethanol level of to measure the ethanol level of methanol poison patients. One of them is using the alcohol-based analyzers that are used by the police forces. You can ask them. You can ask them to bring their devices into your, for example, emergency department to use it and see what level of the alcohols are people taking.
Okay. And the last thing I like, the way you make awareness and alert other people, which was not in Syria. They prevent me even to talk to the media, even to, because there was the local authority, they prevent to do one single alert method at that time.
Yeah.
Thank you very much.
You're right. Thank you.
Dr. Megarban, you are the author for the methanol poisoning and fomepizole. You have lots of papers about that, and what's your contribution to this session?
Okay, thank you. We discussed about the useful antidote, the advantage and disadvantage of recommending ethanol versus fomepizole. There is no benefit in terms of efficacy, but ethanol is much more available. Fomepizole is a medicine. It cannot be delivered without a prescription. So we finally decided that it's better to recommend ethanol even in an Islamic country. And Hossein tried to convince his authorities to allow the administration of ethanol in case of methanol outbreak, and this was possible, I think. I don't know if you experienced this possibility after our recommendations.
Not yet.
Because sometimes there is a gap between what is said and what is actually done. I have also a question regarding the possibility of diagnosis. Dr. Hofda assessed the usefulness of an easy method to measure the concentration of formate at the bedside and even on the scene using mantlets. And I think he was interested, or maybe he did it in your country. Do you have any experience
yes,
with that?
Actually, it was run 6 years ago, and we collect the data, but we haven't published it yet, using actually measuring formaldehyde and formic acid as a reflection of the severity of methanol poisoning. And also, but it is not market. It is not market. And also at the same time, we were working on different possibilities of measuring methanol in alcohol drinks by some easy ways, and we could succeed. So, but we cannot market it because we cannot tell the government, for example, that we are now the producer of something that encourage the people to drink safe alcohol. So we should define a tricky way. Anyway, and on the other hand, we were working on the measurement of the methanol in urine, and it would be available soon as a kit.
Mm-hmm. Is this test is marketed in France?
Not yet.
No. It's not marketed. It's a bedside rapid diagnostic test. It's not marketed.
Not yet, okay.
But you can contact Dr. Hofta, who is responsible for this research, and it seems that he tested it and it has no false positive, no false negative, so it's very interesting to make the diagnosis at the bedside rapidly.
Do you have any questions or contributions from the audience? I think that was a good session, and for getting learning lots of new things and discussing together. Thank you very much. Do you have any contributions?
So now it's time for lunch, and we invite you to be back at 1:30 for the next 2 symposium. Thank you very much.
Thank you.
Okay, welcome back after the lunch break, and thank you so much for attending this panel discussion. We are going to be talking about international collaborations in toxicology, and we are tremendously honored to have 4 internationally renowned experts here to talk about these international collaborations. The first person who I have the honor of introducing is Professor Paul Wax. Dr. Wax has been the executive director of the American College of Medical Toxicology since 2008. He is also a past president of the ACMT. Dr. Wax is a professor of emergency medicine and toxicology at the University of Texas Southwestern in Dallas, and he will be the opening speaker to talk about our collaborations. Thank you.
Yeah, thank you very much, and it's a pleasure again to be here this afternoon. And if we could get the first slide. Okay, great. So as mentioned, I've been quite involved with the American College of Medical Toxicology now for many years, and I just want to go over some of the accomplishments and some of our vision for the future. I think I do need the
All right, let's see the first slide up.
Okay, great. So our organization has grown, significantly over the years, and now it's the largest professional society of medical toxicology physicians in the world. We have a total of about 800 members, of which about 2/3 of them are board-certified medical toxicologists. But we've also opened the society up to other important partner groups to work with over the years, including affiliate members who may not have board certification in medical toxicology, but are physicians interested in medical toxicology, or others such as PhDs or PharmDs, others with advanced degrees with an interest in medical toxicology, toxicology. We also, as I mentioned briefly yesterday, have an international section as well, and this is a section that I feel it really has the opportunity to grow considerably. And I'd like to, invite folks who've attended this meeting to consider joining ACMT, and we'll talk more about ACMT over the next few slides. We also have a bunch of resident members. That's another category for those who are more junior, and also for medical students. So we do a number of different activities. One of our areas of focus, clearly is in the educational arena, and we've developed a number of programs over the years. Our major program is the annual scientific meeting that we have in the springtime. The meeting that's coming up is going to be in New York City just in a few weeks in 2020, and in 2021 we have the meeting in Portland, Oregon. We attract about 350 participants in the meeting. Most of them are members of ACMT, but we also have non-members as well. And it provides us an opportunity to present cutting-edge research and a series of plenary speakers. Many of them who are actually non-members are bringing new information and knowledge to the membership. Usually the day before the conference, we have a symposia which is targeted toward a wider audience than just the medical toxicologists. And this year we're doing an important symposium on opioids and some of the risk reduction and preventative measures, and we'll attract quite a wide diversity of folks to that session. I think it's really kind of a cutting-edge topic, and it's something that we need to keep abreast of going forward. And actually for 2021, we're already starting to plan a whole program on methamphetamine, which is kind of known as the fourth wave of the opioid epidemic at this point. Other conferences we put on, including a board review course every other year to prepare for the board exam. The next course is going to be in Minneapolis in August of 2020. And now, dating back about 12 years or so, we've put on a series of forensic conferences. We've teamed up with colleagues from the Society of Forensic Toxicology and analytical toxicologists to provide a diversified approach to the challenges in the medical legal arena and toxicology. Usually they're very focused on one or two toxins such as ethanol or opioids or stimulants, and it's meant to impart an intensive training to medical toxicologists and others so that may work within the forensic arena, something that's really, I think, useful for the expansion of medical toxicology practice. And we have a number of members interested in doing forensic work. And then, as I mentioned yesterday, we just started putting on this annual course, which is called our Total Tox course. And this is a 3-day course aimed at really non-medical toxicologists, but those who are interested in a comprehensive review course in toxicology, and it's brought together by really a distinguished faculty. Beyond the live courses, we've done a series of webinars, and our webinar program has really expanded greatly over the last few years. And now we're putting on a webinar a week, which is a lot of webinars, but there certainly seems to be quite a bit of demand for this. And this is something that folks can attend really any place where they have access to the internet and or a phone connection. Our main monthly webinar is our National Case Conference, where we discuss a series of interesting cases, but we also have a journal club, we have a grand rounds, and a couple years ago we added an addiction medicine webinar series as well. So this is one of the areas that we're continuing to push out education on a very frequent basis. In terms of the practice of medical toxicology, I mentioned some of this yesterday for those of you who were in attendance, but a lot of initiatives to really push forward the practice of medical toxicology. As described, many of our members only work in toxicology part-time, and they're interested in the society of kind of pushing the envelope and leading the members to have a greater array of opportunities going forward, which is a tall order. It's not so easy. A lot of challenges, as was described yesterday, but something that we feel passionate about in terms of moving forward with the field of medical toxicology. And these were some of the milestones that we met over the last several years with a new billing code and with the development of a series of metrics for medical toxicology practice. as I also described yesterday, really trying to embrace addiction medicine, very important. I look at other fields that really embrace new technologies or new approaches, and the addiction opioid epidemic in the U.S. has provided an opportunity and a lot of attention to the care of the substance use disorder patient, and a lot of potential opportunities and bridges to build. And one of the things that struck me as we've started to develop partnerships is many of our colleagues on the addiction medicine side really have never even heard of medical toxicology. They may have heard of poison centers a touch, but in terms of a specialty field in medical toxicology, many of the leadership of these other organizations didn't even know medical toxicology existed as a specialty, which kind of redoubles our effort to make ourselves known, to build bridges and develop partnerships, particularly in areas where we have a common interest. I also mentioned yesterday our Toxic Research Network, and this is the program that probably engages the most members. I mean, we have, as the map displays, about 40 sites across the country, and these sites, see patients at the bedside. They're entering cases into our toxic registry database. We have about 80,000 cases at this point, and because of, I think, the quality of the data and the fact that it's widely distributed across the U.S., we're starting to attract funding interest from partners that are interested in poisoning and drug adverse effect surveillance, such as the U.S. FDA and CDC. So this is an ongoing process. It's been a labor of love. We started with absolutely no funding at the outset 10 years ago, and we're actually celebrating our 10th anniversary on this program. And it's something that can easily lead to international collaborations. And initially, we tried to invite several international partners to participate as sites, and we've had some bit of traction. But I'd like to re-extend the invitation to anyone in this audience who has a toxicology service, who's practicing at the bedside. You can participate in our program. You can enter cases and then subsequently utilize the data that's collected as a research database and do studies and investigations. I think this is really important. We've done it kind of low tech just because we haven't had a lot of funding in terms of having a very sophisticated system, but because it's web-based, it's easy to enter cases. It's really an opportunity to collaborate across countries, across cultures, and different healthcare delivery systems. So I'd be glad to speak at more depth at some point about the toxic program, but my dream from the get-go was to really make this universal and across not only the U.S. but across our partners from the 5 continents in terms of participating together and building this together. It doesn't take quite the resources of developing a local poison center might, and something that's, I think, potentially lower hanging fruit to engage others in a collaborative way internationally. And this was our paper that we put out in terms of our annual report. We have an extensive CV, which you can find on the website, or you can do a lit search, and we publish a report each year in terms of what's going on with the toxic program beyond our research papers. And this is some of the citations that you can find on our website. Now, moving into some other areas, public health is an important component of medical toxicology, and ACMT has had the opportunity over the last 20 years or so to engage with public health partners, particularly in the U.S. For a number of years, we had a partnership with the Agency for Disease, the ATSDR, Agency for Toxic Substances Disease Registry. Actually, Dr. Kilborn was one of our big supporters in terms of developing the relationship with ATSDR and the National Center for Environmental Health, which is the CDC component interested in environmental health. More recently, we ran during that period of time, we developed this course on chemical agents of opportunity, which is a course I believe has been given at some of the Metatox conferences in the past. We've given it over 100 times. We recently, with Dr. Bala, did this in India with Dr. Kazi and Dr. McKay as well, and hope to do it in other international arenas as well. It remains a very timely course. We developed it in 2003, soon after 9/11, but the issues regarding chemical threat agents remain today, and the education is equally important. And in this case, this course is designed not just for physicians, but for pre-hospital care providers, for public health providers, and other sorts of health providers that may interface with those sorts of challenges. Since from 2014 to 2019, we ran this pediatric environmental health program in the U.S. This was a multi-million-dollar program. We had the opportunity to run under ATSDR and to partner with the American Academy of Pediatrics, bringing both education and consultation to folks around the U.S. on pediatric environmental health problems. And it remains a very important program. We're currently a subcontractor with the American Academy of Pediatrics, moving forward and maintaining both the website as well as developing online teaching modules. And this is part of the classroom. This is free to anyone to peruse. You don't have to be a member. This is a resource that was developed with U.S. taxpayer dollars. And we have a large number of teaching modules about many different aspects of pediatric environmental health. And I welcome people to visit the classroom, which you can access through the ACMT website and take some of these training modules. That's the purpose of them, is to provide this sort of education. One of the activities we worked on is developing this tool for obstetricians known as the PAIR tool. It's to provide both guidance and an approach to taking the intake history from a pregnant patient regarding environmental environmental exposures. And Dr. Charles McKay actually led this program, which is not yet out as a live program. It's been kind of in the kind of caught up in some of the bureaucracy with the federal government, because it was funded by the U.S. government, but hopefully it will soon be out. And it's a tool that really anyone could use. Developing partnerships between medical toxicology and pediatrics and obstetrics has really been an important component, and I think it's been quite valuable and very rewarding to develop those sorts of partnerships. As I briefly mentioned yesterday, with the opioid epidemic, this is certainly a place that medical toxicology has to be front and center, and we're dwarfed by other much larger groups, whether it be addiction medicine or even emergency medicine, that has much more capacity, and some of these partner groups really hadn't even been aware that medical toxicology was on the scene. So we've started to develop partnerships. We've gotten funding. We've developed position statements and try to be very proactive in terms of our contributions to this field, both from a clinical standpoint as well, in this case, from an environmental and an occupational standpoint. So at that point, I quickly ran through a lot of work that ACMT has been doing. I think our potential growth in the future was continuing to build partnerships, developing funding mechanisms to support medical toxicology. Despite the growth of our membership is really small. The dues only account for about 8% of our total operating costs. So to get the word out, to develop these partnerships for other folks to hear that medical toxicology exists as a specialty requires an investment, and we build these partnerships as a means to that end, to develop the right infrastructure to make a mark and leave a more of a consequential impact on society. Thank you.
Thank you, Dr. Paul, for a nice presentation. Have you any question or comment? Later? Okay. Later.
Okay, thank you so much. We will have a question and answer section at the end for the audience to ask our experts. I'd like to introduce our next expert, and this is Dr. David Lanotte, who is a clinical toxicologist, and he runs the toxicology consulting service at Hospital IRCCS Mangieri, and he is at the Institute of Clinical Science in Pavia, Italy. It is our pleasure to welcome you, Doctor. Thank you.
Thank you for the nice introduction. And I would like, first of all, to thank Professor Ziad Katsi, that inviting me and the society to describe our activity. And a big thank to Bruno Megarban that hard work inside our society and is an important role in as bridge for the international collaboration and other societies in emergency medicine, intensive care unit, and a big thank. A thank also for to be here, and I bring you the greetings from the President Martin Wilkes and President-elect Horst Tierman, and from all the executive and board members. I'm very happy to be here as General Secretary of the Society, and we start with my talk, and we talk about the Poison Center activities, and the Poison Centers were developed specifically to provide advice to the clinical and public health, but the primary mission of the Poison Centers has always been an improvement of the poisoned patient, and we are here to do this. And in 1964, Professor Louis Roche and several other visionaries founded the European Association of Poison Center and Clinical Toxicologists with the goal of improving the care of the poisoned patient. And this is the first Congress in Tours in 1964, and the topic of the Congress were the intoxication of the mushroom poisoning intoxication, and the intoxication par le fongicide, and the last topic of the Congress was the importance of the network between the poison centers facilities. And this is important also today. And in 1992, Istanbul hosted one of the Congress, an important Congress of the APCCT, and we discussed the development and controversies in antidote therapy, intensive care and clinical toxicology, hyperbaric oxy in clinical toxicology, and other topic. And I think that it is important to remember that these topics are a problem also today, because we can discuss also for single point also today. And in clinical toxicology, much more needs to be done to improve the patient care. And last year, I'm very proud for this, Italy hosted in Naples Congress in clinical toxicology of our society, and one of the round tables was around in the antidote treatment in clinical toxicology. And we are searching for future location of the Congress. Istanbul may be a future location for our Congress in the future. We are searching for this, and we are open for.
Very nice. Very nice. We will be contact. Yes.
Okay.
We can finish now.
Okay. Okay. And only 47% of WHO member states had a poison control center, and the situation in Europe is this. We have 77 poison center facilities in 33 countries. In some countries we have only one poison center, and in other 2 or more than 2. For example, in Italy, in Germany, France, UK, after Brexit, and in Poland, for example. And we count now 270 members. And the main activity of our society is organize an annual scientific congress, participate to international projects concerned with position statement and clinical guidelines, promote training, and contribute to European initiative and chemical regulation and cross-border chemical health treat. Okay, but in Europe, the activity of different poison centers differs also for organization, poison center facilities, additional work, poison control center staff. And we need to harmonize and to find a standardization of this activity. And since 1980, our society worked on this and to develop a recommendation for a standardized documentation of case data collection in poison center. And in 1997, published in Clinical Toxicology, that is our official journal, the poisoning severity score that is always used to evaluate the severity of the poisonous patient also today. And this is the first document in 2001 about the self-assessment checklist for minimum and optimum standards, quality and accreditation of poison center. This document is now under revision. And another important document that is under revision is the guideline for poison control center, and our members participate in this working group, and many members of EAPCCT are in this group. Another goal of our society is about the classification, labeling and packaging. In 2 years ago, in particular, 2 members of our society, Peter Breckelmans and Ronald de Groot, publish and include in a European document details about the regulation and in particular about the Article 45 in CLP regulation in Europe and around the world. Another point is this, members of our society participate to the pool of experts in a scientific committee of health, environmental and emergency risk inside the European Commission. And in November, last year in November, we participated and described the activity of our society in this field. EAPCCT regularly organizes joint meeting with the European Commission, WHO, and particularly through the auspices of the International Programme on Chemical Safety. Now this is an important point because the scientific activity should be spread around the world and in scientific community. And this is the journal of Clinical Toxicology. Clinical Toxicology is our official journal that reach 4.398 impact factor and increase constantly. And there is an important work inside the editorial board, associated editors, and scientific activity inside this paper. This paper is free for online version for our members, for example, and favorable condition for the paper copies of this journal. And between and together with other society, in particular with the AACT, starting from 1999, we published a position statement in gastric lavage, in ipecacuan syrup use, wall ball irrigation, single or multiple activated charcoal administration, urine alkalinization, and gastrointestinal decontamination. Some of these are updated very recently, and we are working now. There is a group of experts that are working on activated charcoal. This is ongoing, and in QT prolongation in poisoning and in poisoned patient. These papers are ongoing, and we think that will be published in 2 years. We hope. Then I will go to the conclusion, and inside the European Association activity, our members are involved also in survey, for example, in poisonings, rare poisoning, with the aim to harmonize the management around Europe and the world. This is an example for botulism management in Europe. And here are summarized our sister society. We work together with the American College of Medical Toxicology, the AACT, the American Association of Poison Control Center, and the Asian Pacific Association of Medical Toxicology. And we participate regularly to International Congress, UTOX, SOT, Eurotox, and Menatox, and thank you, and EUSEM. There is in this room Kurt Ansju, that is our reference inside the EUSEM Society for Toxicology aspect. Thank you very much. And only 2 slides. Thank you very much to Kurt. We have another way to spread information. We have the APCCT newsletter, Twitter account, and we have a social media working group for this. And we have our website that we use constantly to for the connection with the members, but also for urgent message, for example, because we have, if we use, for example, this forum open to our members, for example, for outbreaks for example, in some countries involving synthetic cannabinoids, for example, or the recent problem about e-cigarette and pulmonary toxicity, okay? We conclude with this word of our dear members, Professor Hans Persson, that in 1992 in Istanbul, talk about EIPCCT activity, and the word of Professor Persson are very important, because inside the comment of our member, the word family comes into the mind. Having attended this Congress for 2 decades now, more than half of the participants are familiar. We are a family, and we need of contribution of all experts in clinical toxicology. And is the important occasion to invite you to join us in Tallinn in May for our annual Congress, and we can find all the information to our website. Thank you very much.
Thank you. So we are going to move on now to our third speaker, who is well known to Minatox, Dr. Ashish Bala. He is a member of the Asia Pacific Association of Medical Toxicology, which our last speaker referred to, and he is also a professor of medicine at the Chandigarh Institute University in India. Thank you, Dr. Bala.
Thank you, Ziad, for giving me the opportunity to come here again. And if, one of my friends asked me, why Minatox? And my response was, I know practically everyone who's trained with Ziad over the years, because I go and I meet them in Atlanta. And this gives me an opportunity to make networking again. So I bring greetings from India, and I bring greetings from Asia Pacific Association of Medical Toxicology, which the previous speaker just referred to. I was asked to talk about what is our contribution. Now, Asia Pacific Association of Medical Toxicology is kind of a very recent organization, a very small organization. I didn't realize till last year that it's been 30 years that we've been into existence when I took over as a president. And at that time, we kind of discussed and we've dwelled into the history. 8 or 10 members from Sri Lanka, India, Australia, Switzerland, London, from WHO. They came together to form a group of interested people in clinical toxicology. And they were all from varied backgrounds, from environmental toxicology to forensic toxicology in Sri Lanka. And they got together, they deliberated, and after a couple of years, they didn't find any worthy, interested people who wanted to take over. The association went defunct for a long time, till the time SACTRAC, that South Asian Collaboration in Toxicology Research, driven by Andrew Dawson, Nick Buckley, Michael Edelston, and like-minded people, came to Sri Lanka. They revived Asia Pacific Association of Toxicology, along with C.C. Yang. People who are toxicologists would know him. Colleagues from Taiwan, colleagues from Thailand, from India, Professor Surjit Singh, who was my mentor. And then they revived this. The idea was to discuss the problems which are unique to the Southeast Asian region, not seen by the Americans, not seen by the Europeans, but seen by us. So we have now members from China, a large group, a very large group from Iran, a very large group from India, a huge group from Australia. But there are very many Asian countries which are not there. We have nobody from Pakistan, nobody from Afghanistan, nobody from South Korea, nobody from Japan. They are just not there. And we don't know what's going on there. So what have we done in last so many years as Asia Pacific Association of Medical Toxicology? We've tried to bring like-minded people together. And mind you, not everyone is a trained toxicologist, like me. I'm an internist who's worked in emergency for nearly 20 years, but then got interested very early in my life in clinical toxicology. 6 years ago, went to London, trained with Paul and David Wood, came back. And I can't forget Paul's line when I wrote to him that I want to come and train with you. He says, what am I going to teach you? Because all we see is paracetamol and club drugs, which is not a major issue in India. What you see there is OP, aluminum phosphide snakebite. We don't see that. So what am I going to train you in? That's where the thought of having a unified kind of a training curriculum for Southeast Asian countries came in. Because David would also, and Bruno would vouch for that. What you see is entirely different. Ziad would remember. He asked me, well, he was teaching me OP poisoning in hazmat course, and I asked him how many cases has he seen. He said, I've treated personally 3 cases. I said, there are times in an hour, I'll get 3 cases in my ER, in 1 hour, right? But he was the instructor for hazmat course, which is an American course. Remember, I won't name this, the teacher from America who came to teach us about snakebite. And he had no idea. of Indian snakes. He's never seen an Indian snake. David Warren came to Chennai and he saw his first case of a cobra bite there. So what we see is something very different. And what we have achieved is that we have built bridges. We have, as Asia Pacific Association of Medical Toxicology, built bridges with AACT. We have a symposium in their conference. They have a symposium in our conference, and we discuss, exchange our research. Similarly, we have exchange symposium with EAPCCT. Minitalks, I'm always there with them, and we are in the process of signing a memorandum of understanding with Minitalks, which would give the trained toxicologists from MENA region to come to Asia Pacific meetings and exchange the research ideas. But our problem is we are just around 230 odd members. Not a very large organization. A single conference. And the major problem is resources, money crunch. Nobody is interested in toxicology. Nobody is interested in funding toxicology. So that's where everyone goes to emergency medicine. You know, get lots of money there, not toxicology. And we do not even have very significant regional representative toxicology society, which would, you know, kind of feed the original Asia Pacific meeting. So that's the problem. We have collaborated with EAPCCT, AACT, and ACMT, sending our representatives from Asia Pacific to work in the projects which David just mentioned. Some of our members are there actively participating in the activated charcoal project. Tanjira is there. So I participated in X-Trip 1 along with a couple of my other colleagues. Now Hussein is there representing the Iranian Society, and Darren Roberts is representing the Asia Pacific Association, and we're working with X-Trip 2 now to kind of... So what is the way forward for us in Asia Pacific Association of Medical Toxicology? So I was just sitting down and thinking, and last time at the ACMT meeting, when we discussed the toxicology training symposium, and I was there, Badaria was there, and David Wood was there, realized that different from the Americans, we have, or nobody has, a structured toxicology training program. There are no structured toxicology training exit exams or board certification anywhere. I was talking to colleagues in MENA region. They are also facing the similar kind of problem. So I think one of the priorities with us at Asia Pacific would be to sit down with the stakeholders and develop a uniform but regionally modifiable tox curriculum, and decide that how are we going to train our toxicologists. The best trainer is not me. The best trainer is the patient. So you have to go to the bedside, sit with the patient, learn from him, manage him. Only then you'll become a good clinical toxicologist. Short of that, you will become a toxicologist, but you can't call yourself a clinical toxicologist. So until unless you've been there on the bedside, managing a patient, you can't be a clinical toxicologist. So that's the way forward. With ACMT, we submitted a proposal to develop a tox curriculum in India. A couple of us got together, 6 university professors, and with Ziad and with Dr. Paul, we submitted a proposal somehow 2 years in a row. We haven't been successful. One day we will be, for sure. We have some regional courses, online courses. There is a SOCTRAC course which is from University of Pasadena, which is an online course. There is a course from University of New South Wales. I think Andrew Dawson and Nick Buckley are managing that course. We have our own Indian course, which is an online course. But it just increases your knowledge base. It does not make you proficient in treating a patient bedside. But gaining knowledge is the first step. Experience would come when you go to the bedside and train. We've started making baby steps, but I think we need to do a lot more. And talking to Antoine Kazi in the afternoon today, I thought of another thing, that we'll need to create 2 different cadres of toxicologists. One, specialist toxicologist, clinical toxicologist, who would be trained in taking care of the patient, doing research, developing guidelines, and then the general practitioners who would have a short-term training in taking care of an acutely ill poisoned patient, at least providing the basics, sending them or feeding them to the specialist toxicology units. For a long time, India only had a single poison center. Now we have 5, and that's the problem with most of the Southeast Asian countries, except for Australia, that we have a single or maybe maximum 2 poison centers. Some of the countries do not have a poison center at all. Many of the countries do not even make their own antidotes, antivenom, for example. Bangladesh, Nepal, Sri Lanka used to depend on India to get their antivenoms. But they have different snakes. Sri Lanka has taken a lead. They have started developing their own antivenom, but many other countries, a lot of need for that kind of development. So I think, in short, this is what we have achieved, but there's a long way to go. A long way to go, plenty of things which we can learn from our European, from our American colleagues, and partner with them and learn from your experiences so that we don't end up making the same mistakes. And we are probably a little wiser than that. Thank you very much.
Thank you so much. It is now my immense pleasure to introduce my colleague and friend, the founding member of Minotox, a member and fellow of the American College of Medical Toxicology, the current president of Minotox, and assistant professor of emergency medicine at Emory University, as well as the founder and director of the Toxicology Fellowship at Emory University. Everybody's favorite toxicologist, Ziad Kazi.
Thank you. Thank you. So I have some slides, a few slides. I'm going to try to finish this quickly, but I want to just hit some points that we heard today. It's clear to me that toxicology development around the world is not complete, and there's a long way to go for most of the world that we discussed today. Minotox is an opportunity for us to do that in our region, learning from the Europeans, from the Americans, from the Asia-Pacific region. So we have many models we can emulate or adapt. So what are we focusing on here in our region? Minotox is focused on several important problems that we are facing, learning from your successes and failures and challenges. First of all, we have a good number of physician toxicologists, we have about 30 to 40 that are in the MENA region, excluding Turkey because we don't have the data for Turkey completely. But these about 40 physician toxicologists, we would like to eventually have proper certification for them, a board certification sponsored by the Arab Board of Emergency Medicine. So this is an important goal that we are working on. We started already the discussion with the Arab Board of Emergency Medicine, and we are meeting in the next couple of weeks to submit a request to look at that. We have one fellowship training in Qatar right now. We need more. And when you have these fellowship trainings, then you will have the curriculum, and then you will have the board certification. So that's an immediate goal that I think we're going to be working on. Our poison centers need some standardization, and we need more poison centers, of course, but the ones that we have need to be standardized. We have several examples we can learn from. It'd be nice to have some data sharing and data reporting. We need to grab the opportunity that WHO is looking at poisonings right now. And I remember when I was a emergency medicine resident or a fellow in toxicology, WHO was not as interested in this field. It was really the Sustained Development Goals and the international health regulations that put us in the forefront of their attention. So we have a period of maybe 10, 15 years that we need to utilize. So MINATOX is working on helping individual countries in our region in improving their poison centers and forming their poison centers. And we've done that in Oman through the national poisoning management guidelines and through technical consultation. So we are willing to provide technical consultation to any Ministry of Health in the region that has requests for support in terms of forming a poison center, creating a data collection tool, performing chemical surveillance. And we have done some of these projects in Lebanon, in Oman, and as well as in the United Arab Emirates. So these are some of the activities that we've done. As far as education, we realized that we have to train our own toxicologists even further to provide continuous development for them, which is why we have MINATOX, which I'm trying to really continue to grow with the help of my colleagues on the board, because we have several board members that you have seen across the conference, and you'll see them again the next couple of days. And we're keen on having education for our toxicologists. It's nice to have our own meeting in our own region. It's also nice to go to the EAPCT meeting or APMT or ACMT, but it's nice to have our own meeting. We also want to train emergency physicians and students and residents, and we're doing that as well through our online webinars, as well as through these conferences that actually are kind of multidisciplinary. We have toxicologists as well as other type of specialists. Finally, we're trying to get some research publications, and we started publishing our abstracts last year in the Journal of Emergency Medicine, and this year in the Mediterranean Journal of Emergency Medicine and Acute Care, which is our official journal for MINATOX. In terms of research grants, we haven't had any grants yet, but we're fortunate to get some contracts. And the contracts we received have been in the area of chemical security. And we have used those contracts to fund some of our meetings and fund some of our participants, particularly in Yemen, Iraq, and Turkey. We've had also participants from India in the past. So we're always trying to broaden the scope of our participant group through this type of funding support. We have a long way to go. Finally, we have a good financial structure. We have a bookkeeper, we have a lawyer, we have a website and a webmaster. So I think that needs some more resources, but those are essential. I've learned a lot from being on the board of ACMT, the importance of these type of administrative resources, because without these, you're unable to really act in a professional way and be effective in your outreach. Our membership categories include, your full voting member. We also have the resident member. We have an international membership that we are going to start, and as well as an affiliate membership. And the good news is, I'm going to stop being president in the near future. We are going to have elections, finally. I've been kind of like one of those, dictators presiding over MINATOX, but I think it's time for me to, pass the torch. I think we are going to have an election in the next few months. We already have several people who are running for various positions, including the board and president-elect and the executive board. With that, I want to just leave a few minutes for some comments. Dr. Moreno, is that okay? Dr. Jander? I know we're behind a little bit, but that's all I have to say. Again, I thank you for being here. And if we have some time for questions, we'd love to entertain them.
Thank you very much, Dr. Kazi. Emergency medicine, I say again, but like doctor from, okay, we need for this motivation, because for the development of toxicology in emergency department or in medicine, first you need bed for patient. You need department for follow the patient. You should intend only you can do this academic position. You should follow the patient, and for that you need critical care unit. You need department. You need bed. And second, for the toxicologist, we need motivation, because you have in polyclinic, for example, if your price or your salary half of the another doctors, anybody don't want to be toxicologist. This is very big problem for development of toxicology in the all, I think. For that, we recommend for clinical toxicology as EPAT. We give very important to toxicology, but we advise to member for that, first you should build your department for toxicology. For example, 10 years ago, I opened the first toxicology intensive care unit and first toxicology unit in Konya in my department. In this unit, only we follow this patient, only for toxicology patient. This is very big experience for us, but if you don't have that and you can't decide how to manage this patient, it's very important.
Right. You're right.
Yes.
I think Dr. Wax mentioned some points yesterday about the practice challenges. Do you want to mention them again, or would you like me to do that?
Into these presentations and noticing all the similarities and the growth challenges that we all confront regardless of where we're from. And I think the driving force is one's passion for the field of toxicology and interest, and in no cases is going to be handed to us. There's really no easy route forward. So I think one has to kind of rely back on their passion and their interests and kind of paving out the right map, whether it's developing some sort of more formalized training approach or certification. I look back in the U.S. way back in the 1970s when there was no funding and there was a group of toxicologists that just put together their own examination and it wasn't recognized by anyone, but it kind of got a start, got their foot in the door, and that ultimately led to greater recognition down the line. But they kind of move things forward, and now as multiple societies have done. Winning recognition by other partners, governmental partners and folks in allied fields. In the end, to move forward, one has to think seriously about how to sustain these partners and leverage one's content expertise for hopefully for funding to support one's members and the society so they can go to the next level. It's a tremendous amount of work. But I think we share so many similarities here. And I think we should also leverage what others have learned so you don't have to necessarily reinvent the wheel, whether it's curriculum or training programs or other ways of getting in the front door. I think we can all learn from one another.
Thank you, Dr. Wax. I think we need to stop this session because we need to turn the room around. So thank you again. Enjoy a 10-minute break, 15-minute break until we resume. Thank you.
Get going. Introduce introduce him. I assume he's... Just introduce the first speaker?
I will introduce.
Yeah,
I have the point for him. You have to start, but I don't know where he is. Okay. Hello. I would like to introduce our first speaker for today, Dr. Mustafa Sabak. So Dr. Mustafa is working in a state hospital in Gaziantep as an emergency physician. He is showing interest in toxicology and ultrasound. He is a member of EBAT and ACEP. Also, he is in charge of ACEP liaison in Turkey. He will give us a talk about sedation of agitated patients, agitated poison patients.
Hi everyone, Dr. Mustafa Savak. Unfortunately, I'm not a toxicologist, but I do work in Gaziantep as a emergency physician, and so I have a different perspective of on the same patient population we will discuss. And I'm honored to be here today to be distinguished group of participants and speakers, and I'm very happy today to talk about the sedation of agitated poison patient. And it's responsibility of emergency clinicians to assess and manage this kind of patients properly and without biases and with the same thoroughness that you assess every patient with. And these patients can present challenge that, to you as a clinicians and the colleagues that you work with and to the whole emergency department. And these patients also have high morbidity and mortality and even can present with a high risk of medical legal issue for their behavior. So I have no financial disclosure to report. Objectives of overview of agitation and causes of agitation and quantifying agitation level and some sort of sedation techniques, and I'm going to mention about literature on agitation management and some complications. And agitation is not a diagnosis, but rather a symptom with a variety of potential life-threatening etiologies. And it is an episodic state of intense anxiety, heightened arousal, and increased motor activity. And it's distinctive condition in which things come together and bring about the significant disturbance for their patient's behavior and ability to interact in a meaningful way with the environment and the people around them. Why is the patient agitations? There are lots of things that we have to concern about it. It can stem from a multitude of potentials, including head injury, substance abuse and intoxication. This is important for today. An underlying mental illness, hypoxia and even manipulation. And metabolic disturbance like metabolic acidosis and hypoglycemia, hypothermia, hyperthermia, seizures like subarachnoid hemorrhage, stuff like that. And these behaviors should be prioritized and promptly to evaluate with the same urgency as the other high risk of patients. But the most important thing is that we have to figure out what's going on about the patients. We see very broad spectrum of agitated patients in the ED, and so we need to categorize them to determine managing procedures. And for this reason, several validated scoring scales can be used to describe the severity of patients' agitations and help predict the risk for violence. And such measures should, can be used to justify clinic decisions, like, for instance, if you want to manage these patients, and we will discuss it later, and for verbal de-escalation or physical restraint, this is a clinical decision for us and help emergency clinicians communicate with the other healthcare providers. This is one of the scales. It's very easy, simplest case, and has good inter-rater reliability. and it does not require answer to questions from the patients. And for instance, the score 4 indicates a normal. It's kind of calm state. But patients rapidly escalate from 5 to 7, which is really a serious condition, combative and violent behavior. I'm going to show a short, brief video about this. Sorry. Voice is a problem. At this kind of severity, agitated patients, we call it excited delirium syndrome. This is a life-threatening medical emergency and underlying psychiatric illness, and often with concomitant drug and alcohol abuse. And wildly adrenergic and remarkably stimulated, strong, and you can see the 4 or 5 police officers couldn't manage the patient, and combative, unable to maintain attention, tachypneic, diaphoretic, and acidotic patients. Why do we sedate them? Because we have to prevent the patient and prevent the other patients, to caregivers and other staff, to avoid serious disruptions and damage to the environment. And we have to evaluate the patient and management the patient. We have 3 types of sedation techniques. One of them, verbal techniques. And words can be used to powerful effect to combat the patients while you manage and investigate the causes. The clinicians must engage the patient and establish a collaborative relationship. And the clinician must verbally de-escalate the situation. And only one person should attempt the initial de-escalation, and measures should be taken to ensure process is safe. We have to respect the patient's space, specifically body language and tone of voice are really important for establishing a good communication with the patient. When appropriate, if you have enough situation and available situation, you can give some simple gesture like giving pillow, blanket, or some foods. It's hard in Turkey, I know. For instance, sandwich, it's easy way in the United States. They can offer a sandwich and some juice, but do not give any tea or coffee because it's hot, and the patient can use it as a weapon to you. This dangerous situation could be. And patient should understand which behaviors are acceptable and which will not be tolerated by yourself. If you're not sure where to start, then you can use this SAVE mnemonic. Support, let's work together. You can say to the patients and acknowledge, I see this has been hard for you. And validate, I will probably be same reaction if I were you. And emotion naming, you seem upset, and like this situation. If you don't remember where to start, you can use the SAVE mnemonic for the verbal techniques. If it doesn't work and you try the less restrictive measures have failed, then medical centers of medical care or Medicaid services support the use of seclusion and restraint for the patients. You tried verbal de-escalation, it doesn't work, then give a final chance to the patients, then show the force. But there are some important things if you want to do physical restraints. It's kind of the protocol for the hospital. The physicians should not take a part of physical restraint to the patient. It is hard in Turkey because we don't have enough staff to manage this kind of patients in the emergency department. And required 6 trained staff. And do not attempt physical restraint if you don't have enough inadequate staff available. 1 person for each limb. One of them above the one of them arm above, and another one below the knee. And 1 person has to control the head, and another person has to administer preparate medications. And do not press their neck or chest because it can cause asphyxia. And do not do hobble restraints, which means tying hands and legs backside of the patients. and explains to patients what's going on every time. And physical restraint should always be followed up with chemical and mechanical restraint, and you can remove it easily and always check neurovascular injury if there is or no. You have to put the patient's supine position and elevate the head roughly 30 degrees to protect aspiration risk, and no need to use pillow, and perform cycle limb release. And you have to make sure the patient's fluid maintains, toileting, you have fully responsible all the things. And this is a good expression by Dr. Billy Mellon. You cannot change someone's personality, but you can obliterate with drugs. So there are some kind of indications for the giving a medication. If the patient is a serious threat to staff and or themselves, and you cannot unable to make a decision, and you tried less invasive options like verbal de-escalation, it doesn't work. And for the assessment, intervention, and the treatment, benzo is one of them. The experts recommended for the undifferentiated agitations for the first-line treatment, for the drug and alcohol intoxication or withdrawal, but we must be careful administrating it to intoxication patients, because both benzos and alcohol can cause respiratory depression. Some of the people have died because of this reason, particularly when they haven't been placed on the monitor. And it's more effective than neuroleptics in reducing delirium and mortality and for the seizure. Lorazepam and midazolam are commonly used due to its rapidity of action, effectiveness, but we have to concern about the elimination half-time of it. Midazolam is short of half-time, because the per-hospital setting, some of the staff give lots of midazolam or lorazepam, and after that, when the patient get into emergency department, the physician can give more sedative medications, and it can cause respiratory depression. And excessive somnolence and paradoxal disinhibition can cause their adverse events. There are two types of antipsychotics: first generation, which is typical, and the second generation, which is atypical. Antipsychotics for severely violent patients requiring immediate sedation, and for patients with undifferentiated sedation, the experts prefer benzos. If you don't have any benzos, you can use first generation antipsychotics. If you know the patient's mental disease, then you can prefer the antipsychotics. Those are the first generation antipsychotics. Haloperidol and droperidol are used most common to manage acute agitation. But in 2001, droperidol was given a black box warning by FDA because of the risk of QT prolongation. It's the same with haloperidol, and haloperidol received a similar warning from the FDA in 2007. Droperidol was given a black box warning the same year as Zofran. So I think the black box warning was probably not based on evidence. I'm not sure, but we can ask our colleagues who work in the United States. But I asked my colleagues who work in the United States, they couldn't find any droperidol. But it's really good drug for managed agitated patients, specifically extremely agitated patients, like excited delirious syndrome. And first generation antipsychotics can cause extrapyramidal side effects and delayed dystonic reaction. Some of them can cause neuroleptic malignant syndrome. Second generation atypical antipsychotics cause fewer extrapyramidal side effects and less sedation than compared to the first generation. Most often in the acute setting, to control severe acute agitation in the ED is limited, but growing and preliminary studies suggest that they can affect the agitation. If the patient willing to take an oral medication, you may give risperidone. It's a good choice for it. Ziprasidone causes the most QT prolongation of any antipsychotic drugs. If you compare the droperidol, the ziprasidone causes the most QT prolongation. There is a combination therapy and with benzos plus first-generation antipsychotics. If you want a more rapid sedation and reduce the side effects, it makes sense to use it. And now I'm going to mention about some valuable articles about this topic. In this prospective observational study, they compared the 4 agents for the undifferentiated agitation in the ED for mild and moderate agitation. The researchers categorized the suspect cause of patients' agitation into alcohol intoxication, drug intoxication, psychiatric, medical, or combination of the causes. IM midazolam more rapid sedation, as was more likely to require additional medications for continued sedation. Olanzapine more effective, and all of the complications rates were low overall and similar across the various medications. In this double-blind randomized trial, they managed the agitated patients with droperidol and IV midazolam, and the patient had a mental illness, intox, or both. Their primary outcome were median time of sedation and adequately sedated at 5 to 10 minutes. Midazolam was as effective as droperidol in achieving sedation in 10 minutes, but midazolam group temporarily required assist ventilation and one was intubated, not because of the droperidol, midazolam. In this double-blind randomized trial, patients treated with midazolam achieved more rapid sedation, but often more rescue medication for breakthrough symptoms, and respiratory depression was very high in midazolam group again. In one of retrospective review, the patients treated by droperidol in the ED, and only 6 serious adverse events were identified, and a single cardiac arrest in patient with a normal QT interval, and it's not clear that droperidol was causative. This is another important article for the droperidol. In a retrospective review, they reviewed roughly 12,000 patients with acute agitation due to alcohol intox. Droperidol given as monotherapy and significantly shortened median length of stay in the ED, which is very important for the emergency physicians, and no cases of sudden cardiac death occurred. In a retrospective review, the primary outcome was the rate of rescue medications in 1 hour. Olanzapine or droperidol were less likely to require rescue medication. But midazolam, if you give the patients midazolam, that means you may need more medication for the patients, and you can cause a more respiratory depression. Several studies suggest that IV olanzapine at doses 5 to 10 milligram may be safe and effective treatment for acute agitation. For the community therapy, their primary outcome was time to sedation, and they researched the need for rescue drugs and adverse events. And combination therapy provided more rapid sedation than midazolam alone, and without an increase in adverse event, and with less need for rescue medication. This is a systematic review for of the 7 studies. The outcomes proportion of patients sedated at 15-10 minutes, and they researched experienced adverse effect and requiring rescue sedation, repeat sedation. Combination therapy resulted in a graded proportion of patients sedated at 15 to 20 minutes, required less repeat sedation. Benzos were associated with a higher incidence of adverse event again. So this article supports the use of combination therapy over alone benzodiazepines use. And ketamine has become a popular alternative for the patients with severe uncontrollable agitation because of fast onset, preservation of airway reflex, and effectiveness via IM administration. The most common dose reported is 4 milligram per kilogram. And ketamine should probably be avoided in older people because the side effects profile is very high. And this is a single study, prospective observational study. Ketamine alone was faster in controlling agitation and had a similar rates of redosing, changes in vital signs, and adverse events. In this study, 4 milligram per kilogram IM ketamine either alone or combination therapy, was used for pre-hospital setting because of its fast, high efficacy rates and low hemodynamic and respiratory side effects. Nearly every patient who was treated with this drug was adequately sedated in average 2 minutes, but significant respiratory depressions occur in 3 subjects. In all 3 cases, had also received midazolam. In this systematic review study, rapid sedation, ketamine provided rapid sedation for the patient with undifferentiated agitation, and however, caution is needed in the pre-hospital setting, given reported high incidence for intubation. And conclusions are very old because they had so many intubation, which could be because the physician in the emergency department, as I told you before, may not know how sedate the patient would become after ketamine. This high intubation rate is not consistent with the other studies. Future options for calming medications in the agitation patients may include inhalated loxapine or IM dexmedetomidine, but strong evidence is pending. I don't know, again, maybe we can ask the expert who works in the United States. Dex is still expensive in the US. I think that's why they rarely use in the emergency department. I don't know, we can ask them. And this is the study for nebulized loxapine case series. All patients were under effect of substance, cocaine, cannabis. The acute agitation was effectively and quickly managed with inhaled loxapine in all poisoned patients. Another thing, the expert review, clinical studies have confirmed the efficacy, rapid onset of action, and safety in psychiatric emergency. And that one is an effective and appropriate option for use in emergency setting in patients with acute agitations. For the DEX study, this is 2 cases of amphetamine-induced agitation successfully sedated with it. And that one is 2 asthma cases were reported that they sedated the patient with safety profile and meaningful effect on respiratory function. And this one, 3 adolescent cases were reported that the researchers controlled the agitation with DEX. So I want to summarize the presentation. The drug and alcohol intoxication or withdrawal are the most common causes. And verbal de-escalation deserve the chance to calm down in response to verbal techniques. And physical restraint, despite the proper approach to combative patients and verbal techniques are unsuccessful. Those are the summarize of the drugs. For the intox, if the patient gets the stimulant drug without psychosis, give benzo. If the patient got the stimulant drug with psychosis, give antipsychotic and benzo. If intox with alcohol, give antipsychotic, probably because of the hallucination. And for the psychiatric illness, if there is any psychiatric disorder, give antipsychotic. For the delirium, if the patient on benzo and alcohol withdrawal, give antipsychotic, specifically for the 2nd generation. If you don't know the etiology and the patients don't have any psychosis, give benzo. If the patient has a psycho, give antipsychotic. So we have the drug. Again, I'm gonna mention about this expression. We have the drugs. They have the receptors. Just put two together. Thank you so much.
Okay, we will proceed. The question will be Dr. Aslam is head of Maltepe University, Faculty of Medicine. He is emergency physician at the same university in Istanbul. He has published in both national and international articles and contributed several book chapters. His talk will be about intubation of poisoned patients, when and how.
Hi to everyone. It's always been a hard period of time to talk after the lunch. I hope I complete my speech without boring you. Today I will talk about the intubation of the poisoned. So let's begin. In 2017, American Association of Poison Control Centers released the 35th annual report. This report stated that over 2 million encounters were logged by the by National Poison Data System, and NPDS documented over 3,000 human exposures resulting in death. According to the same report, serious exposures are increasing by years. Since 2008, less serious exposures tend to decrease by the year 2018. Attention has been drawn to the increase in deaths over the years. In over approximately 30 years, a tenfold increase in deaths is remarkable. The greatest rate of exposure increase since the year 2000 for more severe outcome categories include analgesics, antidepressants, cardiovascular drugs, and sedative hypnotics. This figure shows the increase by the years. Between 2000 and 2013, over 320,000 toxic exposures associated with intubation were reported. The reference is the NPDS 2015 report. In a retrospective review by Bichamp et al., published in the Journal of Emergency Medicine 2016, cases managed with endotracheal intubation in the ACMT toxic registry were analyzed. The data were from the American College of Medical Toxicology, Toxicology Investigators Consortium, TOXIC. ACMT TOXIC was established in 2010 and maintains a prospective case registry of all patients managed at the bedside by medical toxicologists in the US, Australia, Canada, Saudi Arabia, and Israel. It publishes annual reports summarizing demographics, source of consultation, agents involved in toxicologic exposures, signs, symptoms, clinical findings, treatments provided, and fatalities. Sedative hypnotics were the most commonly involved, followed by antidepressants and opioids. Multiple substances were involved in 30% of exposures. Both of the top three categories of single and multiple exposures consist of the same substances. Central nervous system and respiratory depression were the most common findings in patients managed with intubation. Although there are differences between age groups in pediatric population, CNS medications are in the top three. Endotracheal intubation requirements can be summarized as airway management, altered mental status, acidosis, electrolyte abnormality, respiratory failure, hemodynamic instability, and seizure. Airway protection need in patients treated with activated charcoal is also another indication for intubation. So simply, intubation need for the poisoned patients is usually the same as and no different from the usual medical conditions. However, there are special circumstances need to be mentioned, such as salicylate poisoning. Let's take a look to a case. A 58-year-old male brought to the emergency medicine because of large dose of aspirin in suicidal gesture. On presentation, he was diaphoretic, tachypneic, and the initial salicylate level was 111 milligram per liter. An arterial blood gas measurement revealed pH of 7.5, a carbon dioxide pressure of 17 millimeters mercury, and a bicarbonate 13 millimole per liter. He was treated with activated charcoal, IV fluids, and IV sodium bicarbonate. Unfortunately, the attending physician noted marked tachypnea and thought that the patient might tire. Consequently, the patient was endotracheal intubated. Immediately after intubation, the patient's pH dropped to 7 and he died 40 minutes later. What a surprise. This case was published in the Annals of Emergency Medicine in 2003 as a letter to the editor. In salicylate poisoning, intubation is a classical point where these patients rapidly deteriorate. Paralyzing patients for rapid seconds intubation leads to a sudden loss of respiratory compensation for the acidosis and the precipitous fall in pH. After the intubation, it is unfortunately too common to reflexively set the vent with a normal rate and a tidal volume. Unless the patient is decompensating, early mechanical ventilation should be avoided. Similar to diabetic ketoacidosis, it is difficult to artificially achieve adequate minute ventilation that sufficiently matches the patient's own respiratory compensation. In addition, the loss of ventilation during the intubation results in rapid loss of respiratory compensation and worsening acidemia. Pesticides have an important place among poisonings that are still problematic. This topic will be discussed by Dr. Agarwal shortly after, so I will be content to touch briefly. Organophosphate toxicity is represented by the sludge or dumbbell syndrome, manifested by accumulation of acetylcholine at receptor sites. Pulmonary edema can occur and shouldn't be confused with bronchospasm. Pulmonary edema results from many factors, including the release of inflammatory mediators, cells, and increased vascular permeability. Additionally, pulmonary edema, bronchospasm, bronchoria, and respiratory muscle paralysis all contribute to respiratory failure. Because that is a result of airway and respiratory failure, supportive care should be directed primarily toward airway management, oxygenation, and ventilatory support. Succinylcholine, commonly used paralytic for emergency orotracheal intubation. It is metabolized by cholinesterases and may have a prolonged duration of effect, approximately 6 hours. If succinylcholine is used as a paralytic drug, anticipate the need for prolonged sedation and ventilatory support. But still, a non-depolarizing paralytic drug not metabolized by cholinesterases such as rocuronium is preferable. The next group is the antidepressants. In fact, it's a group of drugs that should be mentioned a lot, but I'd like to say a few words for each group briefly. MAO inhibitors overdoses may result in hyperthermia. Stabilization of the airway, adequate ventilation, and volume repletion are the primary goals. Despite administration of benzodiazepines and external cooling measures may need intubation, ventilation, and chemical paralysis with a non-depolarizing neuromuscular blocker. The use of succinylcholine may incite hyperkalemia if rhabdomyolysis has occurred, and fasciculation from succinylcholine might further increase metabolic heat production. And non-depolarizing agents such as rocuronium should be the first choice. Overdose of SSRIs is usually well tolerated and rarely fatal, with ingestions of up to 30 times the daily dose associated with few or no symptoms. Care of the patient with an SNRI overdose is supportive, with focus on ensuring airway patency and adequate ventilation. Because induction of seizures is common, if needed, RSI should contain benzodiazepines. In severe acute barbiturate intoxication, CNS depression progresses from stupor to deep coma and respiratory arrest. The life threat in severe barbiturate toxicity is respiratory depression. Because respirations can be rapid but shallow, the degree of hypoventilation may not be apparent on clinical examination, and pulse oximetry or capnography may be needed to detect the ventilation compromise. Barbiturates have no specific antidote. The key to managing these patients is supportive care, particularly with respect to the cardiovascular and respiratory systems. Severely intoxicated patients are unable to protect their airway and have decreased ventilatory drive. Long-term induced paralysis are rarely necessary, and additional sedation usually is unnecessary for mechanical ventilation. Most benzodiazepine overdoses follow a relatively benign clinical course. Benzodiazepines produce sedative, hypnotic, anxiolytic, and anticonvulsant effects by enhancing the inhibitory actions of GABA. Binding of a benzodiazepine to a specific benzodiazepine receptor potentiates GABA effects on the chloride channel at the GABA-A receptor, increasing intracellular flux of chloride ions and hyperpolarizing the cell. The net effect is a diminished ability of the nerve cell to initiate an action potential, inhibiting neural transmission. Initial stabilization, including endotracheal intubation, shouldn't be delayed by the administration of an antidote. Most benzodiazepine overdoses can be managed expectantly with supportive care alone. The use of flumazenil as an antidote represents a special feature. Seizures and cardiac dysrhythmias can occur after flumazenil administration, and fatalities have been reported. Flumazenil may cause harm when it is given to patients who have co-ingested seizure-generating drugs, such as cocaine, because of loss of the benzodiazepine's protective anticonvulsant properties. Intubation may be required in such cases. Opioid toxicity can occur as a consequence of intentional overdose or abuse, or as an adverse effect of therapeutic use. Approximately 15,000 Americans die annually due to prescription of opioid overdose. The hallmarks of the opioid toxidrome are CNS and respiratory depression. Respiratory depression is caused by opioids' effect on the medullary respiratory center via suppressing its sensitivity to hypercapnia and overriding the hypoxic drive. When combined with CNS depression, prolonged hypopnea can lead to hypoxia, causing further neurologic complications. Acute lung injury and pulmonary edema can cause a failure of oxygenation. This manifests as desaturations on pulse oximetry, despite an adequate respiratory rate, and rails on lung examination. Patients with acute lung injury may require oxygen and positive pressure modalities such as BPAP, CPAP, or mechanical ventilation with PEEP. If naloxone reverses the symptoms, but the patient later develops recurrent respiratory depression, then repeated naloxone doses, a continuous naloxone infusion, or endotracheal intubation should be considered. I think fentanyl deserves a special part. Also, this topic is fully mentioned in yesterday's course session. The CDC reported fentanyl and fentanyl analogs were the cause of death in more than 50% of the US deaths related to opioids in 2016, and were estimated to be higher for the next years. Like all narcotics, given in sufficient quantity, fentanyl and fentanyl analogs can induce dose-dependent respiratory depression, hypoxia, and death. This figure shows the effects of the potency and the narrow therapeutic window of fentanyl and the most common drugs involved in the US overdose deaths as of 2017. The number of fentanyl and fentanyl analogs related deaths have increased dramatically from approximately 1,000 in 2010 and approximately 3,000 fentanyl related deaths in 2013 to currently over 30,000 deaths. According to European Drug Report, fentanyl does not seem to be a serious problem as in the US yet, but it appears to be in a short time. The rapid increase and high rate in Estonia should be a warning that shows the importance of this issue. Unlike morphine-derived alkaloids, fentanyl and fentanyl analogs can rapidly induce a combination of laryngospasm and severe muscle rigidity in the chest wall and diaphragm at doses within therapeutic range used for analgesia and lower than those doses known to cause severe respiratory depression. Emergency rooms and first response personnel have reported that the normal dose range of the opioid reversal agent naloxone seem inadequate to reverse fentanyl and fentanyl analogs effect, and also difficulty performing chest compressions or ventilation in fentanyl overdose due to chest wall rigidity. Emergency room admissions and survival rate studies of overdoses have shown that the ratios for emergency room visits to deaths are 1-to-1 for fentanyl. Laryngospasm is generally managed in the operating room or emergency room with the administration of muscle paralytics. Without pharmacologic intervention, the glottic structures can remain closed for a period of 15 minutes. Doses as small as 3 mg of 6-phenylcholine can relax the vocal cords without interrupting the mechanical capacity of respiration. However, wooden chest syndrome is treated with full doses of muscle paralytics, followed by endotracheal intubation. Finally, endotracheal intubation remains a cornerstone of early resuscitation of the poisoned patient, but still special circumstances does exist. In patients with salicylate poisoning, intubation should be dry. The hallmarks of the opioid toxidrome are CNS and respiratory depression, and usually managed with intubation. Fentanyl is a serious problem that resulted in deaths and increased every year. Treatment in complications such as wooden chest syndrome and respiratory depression is neuromuscular blocking agent and intubation. Thanks for your attention and patience.
Thank you very much. I think we'll hold on questions until the end. I'd like to bring up our next speaker, Dr. Bruno Megerban is a long-term member and leader of the Menatox Society. He is professor of critical care medicine at the Paris Diderot University and directs the research team there. He's the head of the Department of Medical and Toxicological Critical Care, a member and leader of the XTRIP working group on extracorporeal poison removal, and he's going to be talking about extracorporeal toxin removal in the poison patient.
Thank you very much, Paul, for this very kind introduction. So we'll talk now about extracorporeal toxin removal in the poison patient. As you know, treatments in medical toxicology are divided in about 0.04%. Then there is a requirement for an elimination enhancement technique by renal extracorporeal support. When such a technique is required, then it should be immediately available within a short time. And of course, generally the patient is in the ICU, and it looks like the one at your right hand rather than the one at your left hand. What we'll discuss is unfortunately based only on opinions of experts. There is low evidence data and no randomized prospective study. However, when you have to decide about treatment of a poison patient with extracorporeal elimination enhancement technique, your decision should rely on first the knowledge of the technique principles and the drug kinetics, and second, reports from the literature showing that there is some chance to eliminate the toxicant by these techniques with removal kinetics before, during, and after the elimination, and some chance that this elimination will result in an improvement of the patient's situation. These patients who should be treated with these techniques usually have severe poisonings with a drug which elimination could be enhanced, and of course severe features, failure to respond to full supportive care, impairment of the normal route of elimination, and a relatively good correlation between blood concentrations and symptoms, since all these techniques will only eliminate the toxicant that is present in the blood. First point is hemodialysis is the method of reference to enhance the elimination of the toxicant. What are the chemical characteristics of the toxicants that could be removed by hemodialysis? It should be of relatively low weight, less than 500 daltons, water soluble, low steric hindrance, poor binding ratio to plasma proteins, less than 60%, small volume of distribution, less than 1 liter per kilo, low endogenous clearance, less than 4 milliliter per minute, and for the best, with a single compartment kinetics. All these properties are difficult to find in internet rapidly or in a textbook, so what is recommended is to calculate the ratio between the percentage of the free drug in the blood and the volume of distribution, and you see that this ratio is lower than 20, then there is no chance to enhance anything by using hemodialysis for your poison patient. So, based on these kinetic properties, and based on the data providing some benefit in the patient poisoned, there is, to my opinion, 4 toxicants for which dialysis should be considered: salicylate, lithium, toxic alcohols, and metformin. But of course, the list is much more longer for toxicants for which you have or you may discuss the role of hemodialysis by case. So this is not a closed list, but the 4 toxicants are those where it is mandatory to consider dialysis for the treatment. So we'll consider each of these rapidly. Salicylate poisoning is now getting rarer. Of course, dialysis is the method of choice, and the patients who should be dialyzed are those who are the most severely poisoned, with generally severe features like coma, seizures, non-cardiogenic pulmonary edema, and acute renal failure. They usually present severe acidosis, metabolic acidosis, resistant to correction, and usually you have a contraindication for urine alkalinization due to renal or cardiac insufficiency. Sometimes you have only to rely on the concentration of salicylate, and you see the threshold is 1 gram per liter, measured 6 hours after the ingestion, and this threshold is lower for children or in case of chronic salicylate poisoning. Second indication is lithium. It is much more frequent, about 10,000 cases per year in the US. And you know that lithium is mainly responsible for neurological toxicity. Here you have to distinguish 3 patterns of poisoning. Acute poisoning in a previously untreated patient, acute and chronic poisoning in a previously treated patient who take an overdose, and chronic poisoning in treated patients who develop progressive lithium accumulation due to acute renal failure. Why you have to distinguish these 3 patterns? Because the relation between plasma lithium concentration and the severity of neurological toxicity is different. You see that with acute poisoning, you may have very elevated concentrations but very weak toxicity. With acute and chronic poisoning, you may have less elevated concentrations but more severe toxicity, and with chronic poisoning, almost supratherapeutic concentrations with very severe toxicity. And remember that hemodialysis will only eliminate lithium from the plasma. So this will not modify the lithium in the brain, and with lithium, the problem is the blood-brain barrier. So you can eliminate the lithium from the blood, but you cannot eliminate the lithium from the brain, and this will take time to go out of the brain. Lithium is the perfect toxicant that could be eliminated by dialysis, and this has been demonstrated for a long time based on Albert Jäger's investigations in the 90s, and he showed that half-life could be decreased and clearance enhanced. But you see, and that is interesting, you have a rebound after the stopping of the hemodialysis due to the redistribution of lithium from the erythrocytes to the plasma. Who to dialyze? This is the question. You have to rely on 3 important aspects. First, of course, you have to consider the severity of the poisoning. That means the presence of severe neurological features like coma or seizures. Second, you have to consider the existence of some alterations in renal elimination. And third, of course, you have to consider the concentration of the lithium in the plasma, and you see that this concentration will vary according to the pattern of poisoning. In chronic accumulation, you will have a lower threshold to decide hemodialysis, and in acute overdose a higher threshold. We reviewed our cases in Paris, in our ICU, and we divided the patients according to two parameters, serum creatinine and lithium concentration. And you see that we were able, with a good sensitivity and specificity, to separate the patients according to if they were or not hemodialyzed based on the advices of the physician in charge. And we showed that these two criteria seem to be relatively easy to decide to dialyze or not a patient. So if a patient has a concentration of creatinine above 200 micromole per liter or a concentration of lithium above 5.2 millimole per liter, then it's recommended to hemodialyze him. And we were able to demonstrate that in the patients who presented these criteria but who were not dialyzed based on the advice of the physician in charge, it seems in this subgroup that neurological impairments were more important at ICU discharge despite an ICU stay length of the same length, an ICU stay of the same length. So maybe this is a sort of evidence to support the role of hemodialysis in these patients. The third situation is toxic alcohol poisonings, methanol and ethylene glycol. We talked about that previously. Both alcohols are not toxic, but their metabolites, due to alcohol dehydrogenase, are responsible for metabolic acidosis and organ injuries. Methanol is responsible for blindness mainly, and ethylene glycol for acute renal failure. And here the management is based, of course, on alkalinization, but mainly on the administration of an antidote, ethanol or famotidine, and of course the consideration of intermittent dialysis to remove the toxic metabolites and to shorten the course of hospitalization. The choice of antidote is debatable. In France, famotidine is the first-line antidote to treat toxic alcohol, but if famotidine is unavailable or expensive, you may use ethanol with the same effectiveness. Famotidine has the advantage not to require monitoring of its concentration, and it is devoid of any neurological side effects. So it is easier to use, and in some rare cases it may obviate the need for hemodialysis. So in a number of cases, hemodialysis should be considered, especially if you have a severe metabolic acidosis, renal failure, deterioration of neurological situation, or the onset of visual impairments with methanol. Based on the concentration, there's no necessity for absolute hemodialysis with ethylene glycol. So ethylene glycol of more than 50 milligrams per deciliter should not remain an independent criterion for dialysis. However, with methanol, this criteria is debated because, of course, if you dialyze, you may shorten the duration of management in the ICU, and it is possibly cost-effective. So in the US, all the patients with methanol more than 50 milligrams per deciliter are hemodialyzed, while in France we have the chance to be able to spend more money for health problems. We can not dialyze such patients. The fourth situation is metformin poisoning. You know here that this is an increasing situation due to the large prescriptions of metformin in diabetic patients. There are two situations. The first one is acute poisoning, so you will have very elevated metformin concentrations, but a rather better prognosis. And the second is the chronic overdose by metformin due to acute renal failure in a patient who has a comorbidity, or an acute morbidity like sepsis or like drug-drug interaction. So here you will have low concentration of metformin, but very bad prognosis. Dialysis is also the treatment. This was established only recently. You see that before 2009, metformin poisoned patients were not dialyzed because metformin has not good parameters suggesting its easy elimination by hemodialysis. Its volume of distribution is very elevated, so that if you want to use hemodialysis, you have to increase the duration, 16 hours of intermittent hemodialysis to eliminate metformin, and you see that the kinetics is in two phases. The first one is relatively quick. You eliminate rapidly the metformin from the plasma. And the second is, you see here, the first one is not working, but the first one is rapid and then very slow because you have to eliminate the metformin from the erythrocytes and from the tissues, and this is slower. So you need 16 hours, and your indications are severe lactic acidosis with acute renal failure and situations with increasing lactate above 5 millimole per liter. And in this situation, you may save, hemodialysis may be life-saving in the majority of the patients. Are there alternatives to hemodialysis? Of course, continuous dialysis and continuous treatments are interesting because they are more available. They could be suitable in hemodynamically unstable patients. They are easier to use to regulate fluid volume, and they may increase the clearance of mid-molecular weight solutes. However, they have some inconveniences. They have, and the most important one is that they have a lower clearance. So you will eliminate the toxicant more slowly. And the second inconvenience is that you require continuous anticoagulation to avoid the clotting of the extracorporeal circuit and the membrane. So when to use these continuous techniques? In lithium poisoning, it is recommended to use it immediately after hemodialysis. So you hemodialyze the patient during 6 hours, and then to avoid the rebound, you put a continuous hemodialysis. And in this case, as shown here, you have no rebound. In methanol poisoning, especially in case of an outbreak, you will have so many patients who will be referred to the ICU, so hemodialysis devices will not be sufficient to treat all the patients, and this was the case in the Czech Republic methanol outbreak, and patients were treated with continuous hemodialysis. And you see on this slide that, of course, clearance was lower, but the patients were correctly treated, and the condition is to increase to the maximum the blood and dialyzed flow rates to increase the rate of elimination. Are there any additional or any alternatives techniques? Charcoal hemoperfusion. Of course, you may increase the clearance of some toxicants with charcoal, like carbamazepine, phenobarbital, phenytoin, paraquat, theophylline. So there may be some advantages. However, there are major inconveniences. You require greater anticoagulation. The charcoal cartridge are rapidly saturated, so there is a cost for this technique, and the tolerance is very bad. So, to my opinion, don't use charcoal hemoperfusion. What about exchange blood transfusion and plasmapheresis? It's more complicated. It is, of course, not so obvious to think that if you change the blood, then you will eliminate the toxicant, because the toxicant is in the cells, the tissues. But in some very specific situations, like acute and severe hemolysis, intravascular hemolysis with, for instance, methemoglobinemia, it may be appropriate to do exchange blood transfusions. So just exceptionally use these techniques. What about albumin dialysis? It may be interesting to use albumin dialysis to enhance the elimination of toxicants that are linked to albumin. And this is the principle of the Mars system. But the problem is that this technique is very difficult to set up. You require a specialized nurse, and he will require about 3 to 4 hours just to set up the device. So it is very time-consuming, and the benefit till now is not proved. So just use this technique if you want to investigate the ability of this system to increase the enhancement, to increase the clearance of the toxicant. So, as you see, there is no recommendation, and there is no high-level evidence to use or not dialysis, or to use or not such device. So there is an international group, I have the chance to be a part of this, called XTRIP, and we met several times, and we made some recommendations regarding the elimination techniques and indications in poisonings, and many of the resulting recommendations are published, and you can find them on PubMed. So in conclusion, for most severely poisoned patients, supportive care and antidotes are all that is necessary. There is no need for anything else, and no need for extracorporeal renal support. But in some limited cases, there is an indication. And this indication could be life-saving and is urgent. So in practice, hemodialysis should be considered in severe poisoning with salicylates, lithium, methanol, ethylene glycol, and metformin, and in all other toxicants, it should be discussed at the basis of a case-by-case discussion. And of course, as you understood, further studies, and especially randomized studies, are needed to evaluate the benefit, and further experience is also needed to evaluate the other techniques than hemodialysis, like continuous techniques. Thank you very much.
Thank you very much. That was a wonderful overview. At this point, we'll have the questions at the end of this session, so thank you. And so we'll move on to our final speaker. It's really my delight to introduce Dr. Praveen Agarwal. Praveen is a professor of emergency medicine at the AIMS Institute in New Delhi. He's chairman of emergency medicine and one of the leading toxicologists in India, along with Ashish Bala, who you heard from earlier today. And I also had the opportunity to be involved with training Dr. Agarwal many years ago in the States to teach him a little bit about American toxicology, but he's taught me much now about Indian toxicology. And they have a lot of particular expertise, particularly coming to the topic that he's going to be discussing today. And he's going to discuss an update in the management of OP pesticide poison patients in the emergency department.
Thank you, Dr. Paul, for your kind introduction. In fact, as he said, I worked under him in 1999, got training in toxicology at USA. Thank you, Dr. Paul. So I'll be discussing about the management of acute the pesticide poisoning and update in emergency department. So as you know, pesticides are widely used in industries, in the agriculture, in the domestic houses for various purposes. And it's a major problem, the poisoning is a major problem across Asia-Pacific region. Nearly 3 million cases of poisoning occur every year across the globe. And of these, about 200 to 300,000 people die because of pesticide poisoning. Majority of these pesticide poisoning are because of organophosphates. So remember, organophosphates is the major killer across all over the world, but most likely in the Asia-Pacific region. Now this slide just shows the various organophosphates. We have diethyl, dimethyl, and atypical organophosphates. The importance here is that dimethyl organophosphates, when they combine with acetylcholinesterase, they form a complex with aging of about 3.7 hours. The half-life is about 3.7 hours only. While the diethyl compounds, they form the complex with aging of about 33 hours. So there's a wide window for the diethyl organophosphates in case you want to use pyridoxine. This is just the physiology of various acetylcholine receptors present in the body. And you can see that the receptors are present in the autonomic ganglia, in the postganglionic fibers, in the adrenal glands, in the heart, in the sweat glands, in the gut, in the bladder. All of these can produce various features of acute cholinergic poisoning. This is the mechanism of toxicity of organophosphate. Normally what happens is that when acetylcholine is released into the synaptic cleft, it is metabolized, it is inactivated by acetylcholine esterase to inactive compounds. But when organophosphate is there, it inactivates acetylcholine esterase, resulting in stimulation of the post receptors by acetylcholine, causing various cholinergic features. Now, organophosphate poisoning, there are three phases of organophosphate poisoning. The first and the most important for the emergency physician is the acute cholinergic crisis, which occurs in the first few minutes to first few hours of ingestion. The second is the intermediate syndrome, which occurs with some organophosphates about 24 to 96 hours after ingestion. The third is the organophosphate-induced delayed polyneuropathy, which occurs about 2 to 4 weeks after ingestion, which is a sensory motor neuropathy. Generally, these patients won't present to the emergency department. These are the typical clinical features of organophosphate poisoning. We have dumbbells for the muscarinic, but the three important are the three killer Bs: bronchoria, bradycardia, and bronchospasm, and of course the low blood pressure. The nicotinic ones are the respiratory failure mainly, and the CNS were the confusion, coma, and convulsions. Now, important about organophosphate poisoning is that organophosphate generally dissolved in hydrocarbons. So when somebody ingests organophosphates, the person can aspirate hydrocarbons into the lungs, causing breathing difficulties, can cause ARDS also. These are some of the ECG changes which can occur with organophosphate, but important thing is the QT interval prolongation and some ventricular tachycardia, including ventricular fibrillation also. Now, this is the score which we commonly use in our emergency department, paradynia scores for severity of poisoning, which is based on the clinical features only: the pupillary size, the respiratory rate, the heart rate, presence or absence of fasciculations, the level of consciousness, and the presence or absence of seizures. These are quite good, reliable score for defining severity of organophosphate poisoning. The diagnosis is generally by clinical only. We hardly use the plasma pseudocholinesterase levels or the RBC cholinesterase levels. Now, intermediate syndrome is an important thing for emergency department. The patient may come to us with mild organophosphate poisoning with few features of cholinergic toxicity. You may discharge the patient, but the patient may come back again after about 24 to 96 hours with acute respiratory failure. So that is why patient with organophosphate poisoning should remain in the hospital for at least 96 hours. They should be closely monitored for any respiratory failure, and if required, they should be ventilated by intubating the patient. Now, coming to management of the patient with organophosphate, if there is external exposure to the patient, suppose the patient is exposed to the organophosphate through skin, external decontamination is required. Otherwise, for the injection, the patient should be resuscitated, stabilized, given muscarinic antagonist like atropine, and if indicated, gastric lavage. The role of pyridoxine, the acetylcholine reactivators, is very, very doubtful. We do not use it. And definitely, if the patient does not respond to these therapies, then we need to give some novel therapies to these patients, which I'll discuss later on. Now, the only thing about external decontamination is that you must protect yourself when providing the external decontamination. It should not happen that we have one victim of organophosphate poisoning and then we become the second victim of poisoning. So for the initial stabilization, the standard is the ABC for any emergency. But the important thing here is that if the patient comes in cardiac arrest, we start the ACLS protocol, but in addition, we start the atropine therapy also. So remember, atropine is indicated in very few situations in ACLS program. Atropine is removed from the ACLS guidelines now. But if the patient has organophosphate or carbamide toxicity and comes in cardiac arrest, then the patient will require atropine to be given to the patient. Of course, to avoid aspiration, keep the patient in left lateral position, give high flow of oxygen because they are often hypoxic, intubate the patient if the airway is breathing compromised. Now, one of my previous speakers talked about the intubation. Avoid succinylcholine again to re-emphasize it, because it also gets metabolized by the pseudocholinesterase. And if we give with succinylcholine along with the OP poisoning, the duration of succinylcholine duration will be prolonged to 6 to 12 hours. Now, atropine is the initial drug of choice for patient with organophosphate poisoning. If the patient has meiosis, small pupils, excessive sweating, has bronchoria or bronchoconstriction, has bradycardia and hypotension, the patient requires atropine. But if the patient does not have any of these 5 markers of cholinergic toxicity, then the patient should be still observed for about 12 hours for delayed toxicity. The dose of atropine is 2 milligram intravenously, and it should be given even if oxygen is not available. The dose for children is for about 0.05 milligram per kilogram, the first dose. After 5 minutes of giving atropine, check the 5 markers of cholinergic poisoning. If there is no improvement, double the dose of atropine to 4 milligram and continue to double it every 5 minutes till you get the endpoints. The endpoints will be clear chest and auscultation, heart rate more than 80 beats per minute, that is, there is no bradycardia. The systolic blood pressure is more than 90 millimeter, that is, there is no hypotension. Of course, you can look at the pupils, they should no longer be constricted. There should be no sweating, that is, axilla should be dry. This just shows a schematic diagram for the atropinization. Give doubling dose, 2 milligram, 4 milligram, 6 milligram, 8 milligram, 16 milligram, and so on. The important thing is that patients often lose a lot of fluids because of recurrent vomiting, because of urination, because of salivation, because of sweating. So along with atropine, start IV fluids, give about 500 ml to 1000 ml of saline. And also once the patient is atropinized, start the infusion of atropine at a dose of 10 to 20% of the total dose given initially, that is every hour, and assess the five parameters of cholinergic toxicity every 50 minutes. Make a diagram, like make a chart in your emergency department about the various vitals, monitor them every 15 minutes. The patient may require bolus of atropine in between, or the patient may develop atropine toxicity. Once the patient is stable, reduce the dose of atropine by 20% every 4 hours, so that generally by about 24 to 48 hours, you are able to stop atropine. These patients can also have hyperthermia, so external cooling is also important in this patient. Now, these are the features of atropine toxicity: agitation, confusion, urine retention, and paralytic ileus. Of these, most important is paralytic ileus. So keep on auscultating the abdomen every 15-20 minutes initially for any signs of atropine toxicity. If the patient develops atropine toxicity, stop infusion of atropine. Wait for about 30 minutes. The signs of toxicity disappear. Start the infusion again at about 75% of the initial infusion rate. Now, this is the one which we often use as the first intervention. Remember, gastric lavage can never be the first intervention in any of the poisonings, particularly for the pesticide poisoning. If you want to do a gastric lavage, it should be done only after the initial resuscitation, the initial dose of atropine, and there also the role of lavage in organophosphate poisoning is very, very doubtful. Again, as I said, it can increase the chances of aspiration pneumonia because organophosphate dissolved in hydrocarbons. Again, activated charcoal, probably no role again. There are studies showing that it probably doesn't act in patient with organophosphate poisoning. Now, do we have any evidence of doubling doses of atropine? We keep on doubling doses every 5 minutes. There are 2 studies which were conducted, one in Sri Lanka and second in Bangladesh. In the first study done in Sri Lanka, the 3 hospitals were chosen, and there were about 272 patients. In 2 hospitals, they gave doubling doses of atropine, and in the 3rd hospital, the standard routine was given, just the boluses of atropine were given. And what was found was that patients who received doubling doses, they received less of PAM and less of atropine. They also had lower occurrence of atropine toxicity. But there is no difference in mortality or ventilatory rate in both the groups. In contrast to this study from Bangladesh, this study was done in Bangladesh. Again, they divided into 2 groups. There were about 156 patients. And they found that giving the doubling dose of atropine reduced the mortality, reduced time to atropinization, reduced the incidence of atropine toxicity, and also reduced the incidence of ventilation. So this study clearly showed that doubling dose of atropine is quite effective in reducing all the parameters associated with organophosphate poisoning. Now coming to the second antidote, which is pralidoxime. Many physicians still use pralidoxime, and the dose recommended is 30 milligram per kilogram of PAM chloride over 15 to 20 minutes, followed by infusion of 8 to 10 milligram per kilogram per hour. In India, we have mostly PAM iodide, which is less effective compared to PAM chloride. There are several adverse effects associated with the PAM, which include tachycardia, hypertension, muscle rigidity, laryngospasm. Now, let's see whether pralidoxime is really effective or not in patients with organophosphate poisoning. It may be ineffective if there is aging of the organophosphate acetylcholinesterase complex. Also, there is a variation between the different organophosphates. They may or may not respond to pralidoxime. There are no effective protocols in terms of doses which have been established for pralidoxime. In various studies, the dose have varied from 0, that is no PAM was given, to 24 grams a day. It is also not likely to address the non-acetylcholine effects of the organophosphate. Now, organophosphate have many other effects. They can directly affect the tissues. They can directly affect the neuromuscular junctions. So that's why it is not possible that pralidoxime is going to affect all other non-acetylcholine effects of the organophosphates. In addition, in developing countries, we have the problem of cost. It costs about $5 per gram of pralidoxime. And suppose you want to get 24 grams per day, it will become very high cost for us. Now, there are many studies done on comparing various doses of pralidoxime. The first studies were done from India in 2006, reported in 2006, in which 200 patients were included. They were given, one half were given high dose of pralidoxime. The second group was given the normal low dose of pralidoxime. What they found was that in the high dose group, there was less need of atropine during the first 24 hours. There was less need of intubation, and there was lesser duration of mechanical ventilation for the patient who received high dose of pralidoxime. But there was no change in mortality. There was a second study was done from Sri Lanka, which was again a double-blinded placebo-controlled trial of 235 patients. In this study, they found the mortality was higher in pralidoxime group, and the need for intubation was similar in both the groups. There were two meta-analyses published in 2018 and 2019, and in the first meta-analysis, what they found was there was no significant difference in terms of risk of death, intubation, development of intermittent syndrome, complications, and duration of intubation between the patient who received pralidoxime and the patient who did not receive pralidoxime. The second meta-analysis was published in 2019, which again found that the mortality was probably higher in patients who received pralidoxime. So with these two meta-analyses, it is possible probably that pralidoxime should not be given to a patient with organophosphate poisoning. Now, some people do use glycopyrrolate in place of atropine because it controls the secretion better. It produces less of tachycardia. It does not cross blood-brain barrier easily, and therefore will not cause much of confusion or delirium. But the problem with glycopyrrolate is that it is less effective in treating bradycardia induced by organophosphate, and it may not reverse the CNS effects of organophosphates. So most of us may give glycopyrrolate in case the patient is not having much of bradycardia and not having much of CNS effects, but it is costlier than atropine. Now, there are several novel agents which have been used in the past, which include magnesium sulfate, clonidine, sodium bicarbonate, and recombinant bacterial enzymes like butyryl cholinesterase inhibitor, cholinesterase. There are small studies conducted on the use of these novel agents. The first study about magnesium sulfate was about 45 to 45 patients. One group got 4 gram magnesium sulfate over 24 hours as infusion. The second group did not get any magnesium sulfate. Oxime atropine was used in both the groups. So what was found was, in the magnesium group, none of the 11 patients who received magnesium died. But in the control group of 34 patients, 5 patients died who did not receive magnesium. So probably they concluded that magnesium may be effective in patients with organophosphate poisoning. But there was a study from Iran in the year 2018, which included 80 patients. Again, one group received magnesium sulfate 2 grams every 2 hourly for 3 doses versus saline, and they found there was a reduced duration of admission for patients who received magnesium sulfate. This was a meta-analysis of patients who received magnesium sulfate versus no magnesium sulfate in OP poisoning. And it was found that it probably decreased the mortality if patients were given magnesium sulfate. The second drug would be sodium bicarbonate to alkalinize the blood to a pH of about 7.45 to 7.55. It has several mechanisms of actions, including it increases the OP clearance by hydrolysis. It expands the intravascular volume. It has a direct effect on the neurovascular junction. It has probably effect on the aging of the acetylcholinesterase OP complex and probably improves the oxime activity also. Again, very small studies are available. This is a study of about 53 patients. One group received sodium bicarbonate. The second group did not receive sodium bicarbonate. So what was found was that total doses of atropine in the control group were higher than the group which received sodium bicarbonate. The admission rates were higher in the control group, that is patients who did not receive sodium bicarbonate, than the test group, that is the patient who received the sodium bicarbonate. Again, this is a very small study. Salbutamol is also being recommended, or at least thought of, as a treatment for patients with organophosphate poisoning. It relieves OP-induced bronchospasm. It increases fluid elimination from the lungs, thereby improving the oxygenation. But the recent study conducted in Bangladesh, which did not show any benefit of use of salbutamol. Now, diazepam is another antidote which is being tried in patients with organophosphate poisoning. In OP poisoning, what happens is there is uncontrolled stimulation of the respiratory center, which causes decreased renin output. Diazepam, what it does is that it attenuates the respiratory system activity, thereby inhibiting the CNS respiratory depression paradoxically. But again, we don't have much of evidence in favor of diazepam. This is a study done in animals, in rats basically, and what they found that if the patient were pre-treated with diazepam before giving dichlorvas, 44% animals or the rats survived at 10 minutes, but none survived at 24 hours. So probably again, diazepam may not be really effective in patients with organophosphate poisoning. Another concept is the use of bioscavengers, like use of cholinesterase enzyme, which sequesters organophosphate compounds in the blood so that the target concentration of organophosphate is reduced. The second is the use of hydrolysis, which hydrolyze the organophosphate in the blood, thereby reducing the concentration of organophosphate in the blood. And one of them, that is OPDA, has been found to be useful in animals. Now, there are 2 or 3 studies on bioscavengers. In the first study, again, very small study, 33 patients, 20 received atropine plus PAM, 9 received plasma, which contains butyryl cholinesterase, and 2 received plasma after they developed intermediate syndrome. Now, what they found was that patients who received only PAM and atropine, the intermediate syndrome developed in 28.8% of the patients, that is 6 out of 21, while in 9 patients who received plasma, in none of them intermediate syndrome developed. There were no deaths in the patient who received plasma, so thereby probably meaning that the giving plasma to this patient may be effective if the patient has severe organophosphate poisoning. But on the other hand, there was a second study in which they did not find any evidence of any benefit of use of plasma or 20% albumin in patient with organophosphate poisoning. Now, nicotinic receptor antagonists are also being tried because nicotine is one of the receptors at the neuromuscular junction. So if it gives something which is antagonizes the nicotine receptor, it may produce beneficial effect in patient with organophosphate poisoning. So there's a trial in the animals, not animal in the humans, but it's a phase 2 trial where the use of rocuronium has been shown to improve the outcome. But again, the number of patients very small, only phase 2 trial was there. The last one is the second last would be the use of intravenous lipid emulsion. Now it is being used in almost every poisoning. This was a study conducted from Chandigarh. Dr. Ashish Bala is here, who conducted this study. This was a study on 40 patients who were symptomatic because of organophosphate poisoning. But they found that there was no significant change in the hemodynamic parameters in patients who received intravenous lipid. Compared to the historical control, there was no change in mortality, but there was some reduction in duration of ventilation and hospital stay. There were no adverse effects. That's an important thing. Now there is a review of literature from the China. About 7 randomized controlled trials were systematically studied. All were reported from China in Chinese literature. And they have studied about 630 patients. So what they found was that intralipid improved the cure rate, it decreases the mortality rate, it decreases the respiratory muscle paralysis when the patient received intravenous lipid emulsion. So what we require is probably a larger trial on the use of intravenous lipid emulsion in a patient with severe organophosphate poisoning. Now, Dr. Bruner talked about the extracorporeal removal of the toxin. This was a study from Turkey, in which they had 260 patients who were divided into 2 groups. They had severe organophosphate poisoning. All received, at least 40 of them received hemoperfusion within 3 hours of injection, which decreased the mortality, decreased the incidence of intermediate syndrome, and decreased hospital and ICU stay. 44 patients received organ transplantations from these 20 donors, and the outcome was really good. 3 of the recipients died, 3 had graft dysfunction, but 34 had good graft function within first 6 to 12 months. So probably again, we should not declare these patients that they are not fit for organ donation. They can be taken as organ donors. If the kidneys are functioning well, the heart is functioning well, they can be good organ donors for the other patients. So to summarize, what we require is basically a large multi-center trial using these novel drugs, like we have plasma, we have sodium bicarbonate, we have intravenous lipid. Right now what we have is a single center studies having very small number of patients most often, except for the hemoperfusion study which has 260 patients. So I would feel that probably we require as a research, a multi-center group thinking about the various drugs which we can use in patients with organophosphate poisoning. Thank you.
Thank you very much. Really an excellent presentation. At this point, because of time constraints, I think we'll end this session. We're running a few minutes behind, and there is a break right now. So why don't we take a 10-minute break and begin at 4:40 for the final session of the day. Thank you.
Yeah, I'm Hussein from Tehran, and we are working together to moderate this session. And please introduce the first speaker.
All right, we're going to have an abbreviated session in that we have a couple of talks that have been canceled. So our first speaker is going to be Mohammed Al-Malki. Mohammed is a practitioner of both internal medicine and medical toxicology. He did his medical toxicology fellowship with us at Emory University. He is currently also the chairman of internal medicine at this hospital in Riyadh, which is King Saud Medical City. And he's been a board member of Minotox for over 4 years. So we want to thank him for his contributions and looking forward to his next 15 minutes of his talk.
Hello, everyone. So my talk today will be about utility of drug screen in emergency department. So this is the outline of my talk. We'll start by giving you introduction about emergency drug screen methods that we are using for emergency drug screen, including immunoassay and chromatography techniques, limitation of immunoassay techniques, some evidence from the literature about use of drug screen in emergency departments, and then a conclusion. So basically, urine drug screen is a panel of tests that are done on biological samples, and most of the time it's urine, even can be done on other samples. Then it can give you like a result it will tell you whether a specific drug or even its metabolites are present in that sample or not. Most of these screening tests does not give you quantity. Like they will tell you like if this drug is positive or negative, but they will not give you a specific concentration, despite some newer machines can give you like specific concentrations. So basically, drug screen is a two-step process. Initially, you have to do a screening test using immunoassay, and if that biologic sample tests positive for any drug, this does not mean it's positive. You have to confirm your result using another test. We call it confirmatory test, and different techniques used for that, like liquid and gas chromatography. So basically, like checkpoints at the airport. So initially, biologic sample will be screened to see if any drug is present there or not. If the test is positive, this does not mean it's positive. So you need to confirm your result by doing another test, confirmatory test, using gas and liquid chromatography. So for screening, we are using different machines are available, and most of these machines, they are using immunoassay techniques. They use antigen-antibody interactions. They have specific antibodies against specific classes of drugs or even its metabolites. So if the biologic sample contains that specific drug or even one of its metabolites, then it will give you a positive result. But again, this is not specific test. You have to confirm your result using chromatography. So commercially available immunoassays, they will test for different drugs. The most commonly tested drugs are amphetamines, barbiturates, benzodiazepines, cocaine, opiate, THC, and phencyclidine. Some machines, they will even test for more drugs like tricyclic antidepressant and the others. But these are the most commonly tested drugs. So immunoassay techniques are inexpensive, widely available in the emergency department, and easily automated. It's not sophisticated technique and can give you the results quickly. What is the problem with immunoassay techniques? We have three problems. The first one, these tests are qualitative tests. So they will not give you specific concentration for that drug. They will tell you if the drug is positive or negative, but they will not give you specific concentration. Some newer machines will give like specific concentration, but the majority of immunoassay techniques, only they will tell you if the drug is positive or negative. So the second problem with immunoassay technique is reliability issues. So these are screening tests. So they are highly sensitive. Their sensitivity is very high. So you will have low and false negative results, but they are not specific. Their specificity is low. Also, their negative predictive value is low. So if you have a positive result with the immunoassay, this is not a confirmatory test. You have to do a second step. You have to confirm your result with a more specific and diagnostic test like chromatography. So these diagnostic tests are highly sensitive and specific. The third problem with immunoassay techniques is cross-reactivity. So they have a lot of cross-reactivity with a large list of drugs. For example, if you will eat this meal, you will test an immunoassay positive for opioid. So the poppy seed, they have cross-reactivity with the opioid immunoassay. So if you can see here, like there's interaction between different immunoassays for of different drugs. It's like amphetamines, they have a huge list of interactions. They can give you a false positive result with dextroamphetamine, ephedrine, with MDMA, labetalol. Also, they can give you a positive result with if someone is using ranitidine and the others. So they have cross-reactivity with a large number of drugs. For example, also THC, they have cross-reactivity with non-steroidal anti-inflammatory drugs. They have cross-reactivity with proton pump inhibitors. Opioid also, they have cross-reactivity with poppy seeds. They have cross-reactivity with rifampicin. phencyclidine and tricyclic antidepressant. Tricyclic antidepressant, they have cross-reactivity with carbamazepine. They have like similar structure, so it can give you a false positive result in someone who is using carbamazepine. And also, they have cross-reactivity with quetiapine. So you can see a huge list of drugs that can give you false positive results. So these are not diagnostic tests, only used for screening. So if you would like to confirm your result, you have to use more sophisticated techniques like gas chromatography, liquid chromatography, and mass spectrometry. Confirmatory tests are highly specific and sensitive, but again, they require more trained technician and to perform these tests. And also, you need an expertise to give you interpretation for the results. They can give you quantitative concentrations. It's not like immunoassay techniques for a specific substance or even its metabolites. But again, they are not available everywhere. And you cannot get the results immediately like immunoassay techniques. So, clinical scenarios where emergency drug screen is used in the emergency department. Emergency drug screen has been become like standard of care for a lot of patients. It's frequently ordered in patients who present with a drug overdose to the emergency department. Also frequently ordered in patients who presented with CNS signs and symptoms, like someone with agitation, altered mental status. It has been frequently ordered. In psychiatric patients who present to the emergency department with psychiatric signs and symptoms like agitation, psychosis, delirium. Also, it has become a standard of care in trauma patients. So it's frequently ordered, but what is the utility of these tests? Do we need it? Does it change the management of these patients and their disposition in the emergency department? So what does the literature say? We have a lot of published articles discussing this issue. Over the past few decades, several articles have been published to address the utility of emergency drug screen. One of the earliest studies that has been published was in 1974. So this was a retrospective trial. 148 patients enrolled in this study, and they concluded that there is no utility for emergency drug screen in the management of patients in the emergency department. Later on, another study has been published in 1987 by Kellerman. This study was a prospective clinical trial, and they enrolled 196 patients in this study. And the main question of this study was how often emergency drug screen will have substantial change in the management of patients in emergency department. And they concluded that only 6 out of 196 patients, there was change in their management. And even 3 of these patients, the change was to discharge home as they have negative results. Sorry, just. What about psychiatric patients presenting with psychiatric signs and symptoms like agitation, delirium? So emergency drug screen has become one of the commonly ordered investigations in these patients. One study has been done in 2000. It was this one was a randomized controlled trial. They enrolled 2 groups of patients in this study. 198 patients enrolled in the urine drug screen versus 194 patients enrolled in the traditional treatment arm. And the question of this study was like if emergency drug screen has an impact on disposition of psychiatric patients in the emergency department. It has been found that there's no change in disposition of psychiatric patients who presented with psychiatric manifestations to emergency department. What about trauma patients? So emergency drug screen has been become one of the standard of care for trauma patients. It's frequently ordered in these patients, and even it has become like one of the requirement to be certified as level 1 and level 2 trauma patients to have available urine drug screen. Multiple studies has been published in the peer-reviewed literature about the utility of urine drug screen in these patients, and all of these studies they concluded that there is limited utility of routine drug screen in trauma patients. So at the end, the conclusion from the literature review, the literature does not support an emergency drug screen as being helpful in the acute management of patients in the emergency department. Also, it does not change the disposition of these patients. Screening results rarely change clinical management of a patient who presented to the emergency department. What about the clinical guidelines? So a clinical guidelines that has been developed by a UK clinical scientist and toxicologist, and by a clinical toxicologist and clinical laboratory scientist, they recommended against the availability of emergency drug screen in the emergency department. Also, a similar guideline has been made by the Alberta Medical Association, and they also make the same recommendation. There is no utility for emergency drug screen in the emergency department. So, conclusion, emergency drug screen is unlikely to significantly impact management of patients in the emergency department. Also, it has no impact on disposition of these patients. That's it, I'm done.
All right, we have some time for questions. Then on subsequent follow-up with psychiatry, it may not change their disposition at that time, but that could help the psychiatrist, someone who's an intentional adult, to know that someone has, cocaine use disorder or, marijuana use disorder, and that could help them get targeted to just different treatments that could benefit them.
I did not get across any article discussing if they are useful for follow-up. I have no idea if there's any published article to discuss utility of these emergency drug screen as a follow-up modality in psychiatric patients. I came across studies talking about useful if these urine drug screen are important for disposition in the emergency department in psychiatric patients who presented with psychiatric manifestations like agitation, delirium, etc. But I'm not sure if there are any study about usefulness of these immunoassay as a follow-up modalities.
Okay, thank you. Sure, after we finish with these questions, yeah. Okay.
I have a question, Mohammed. As a physician, I'm wondering what should I do? From tomorrow, I should stop ordering drug screening for my patients?
So,
does it mean that I should follow drug screening by confirmatory tests? Or should I do confirmatory tests from the beginning?
So basically for intoxicated patient, what we need, we mainly depend on clinical signs and symptoms. So you have to rely mainly on your toxidrome recognition. It can help you, but again, as I told you, if you have, for example, a urine drug screen which tests positive for opioid, this does not mean that your patient was using opioid, because you will have a lot of cross-reactivity, and this test should be confirmed by another confirmatory test, which is sophisticated techniques, not available everywhere, and even you need it will need sometimes 1 day or 2 days to have the results. So basically for acute intoxication, you have to depend on your toxidrome recognition. But they can help, yes, but if you have a positive result, you have to put in your mind that you can have a lot of false positive results, and also a loss of cross-reactivity with the other drugs. Like for example, if someone is using tricyclic antidepressant, it can give you a false positive result with a lot of drugs, as I showed you previously. The amphetamines, they have large list of cross-reactivity. Other questions?
Any other question from the floor? Thanks.
Okay, thank you.
Let me introduce Semih Kırkut from Turkey. He is currently working in Ministry of Health as a director of the Emergency Medical Service in Turkey.
Teşekkür ederim. İlk önce İngilizce sunum yapacağımı biraz önce öğrendim. Behçet Hoca'ya o yüzden biz sunumu Türkçe hazırladım. Behçet Hoca da ceza olsun diye çevirimizi yapacak Behçet Hoca.
Önce bir soru salonda. Who can speak? You cannot understand Turkish? How many of you? You, both, and you. You don't know Turkish, eh? No. Okay. You are here. You know? You already know Turkish. Okay.
Hazır mısın? Şimdi
just a minute. Dr. Semih Korkut, he is the manager of the emergency service of Ministry of Health of Turkey, especially for the pro-hospital. He's working a very hard-working man. You can see in the morning he's east of Turkey. In the same day of the evening, he's at the south of Turkey. So he want to present his apologize because he planned to join us for the opening ceremony. In the morning, the Ministry of Health called him to go to join another meeting. So that is why he didn't join us. So he present his apologies again. Why not he didn't join us? Okay, you are welcome. And he's also the member of the EPOD. I have said.
Okay. Türkiye'deki afetlerdeki toksikoloji durumunu anlamak için ilk önce afetleri anlamak lazım.
To understand the toxicology of the even in Turkey, first we have to understand the other events, disasters.
Şimdi Türkiye deprem bölgesinde.
Turkey is an earthquake place.
Ulaşım yollarının üzerinde. Her türlü afete açık bir ülke. Son bir ayda başımıza gelen felaketleri buradaki toksikolojiden bahsedeceğim.
In recent days we have three big disasters.
Evet. İlk önce küçük bir şeyimizi hatırlatayım. Türkiye'de 35 bin tane acil sağlık hizmetlerinde, hastane öncesi acil sağlık hizmetlerinde çalışan personelimiz var.
We have staffs at the 35 location for pre-hospital staff working.
5600 ambulans, bunların yaş ortalaması 3.6, dünyanın en genç filolarından bir tanesine sahip.
5,600 ambulance, 17 helicopter and 3 aircraft for transfer.
3 uçak ve 17 helikopter. Helikopterde ve uçakta da dünyanın genç filolarından bir tanesine sahibiz.
We are one of the youngest for the aircraft transportation in the world.
24 Ocak'ta Elazığ depremi başımıza geldi. 6.8'lik bir deprem. 20.55'te meydana geldi. En yakın istasyonumuz bir göçeye 2,5 kilometre mesafesindeydi ve 4 çağrı o istasyona geldikten sonra 4 dakika içerisinde o istasyon göçük alanındaydı.
At 25th of the January, we had an earthquake in Elazığ location. At 20:55 time, the nearest location for help was 2.5 kilometer far from the earthquake location.
Okay. Şimdi depremden yaklaşık 15 dakika sonra Sağlık Bakanlığı'nda bir koordinasyon merkezimiz var. Genel müdürlerin toplandığı. Burada önemli Halk Sağlığı Genel Müdürü, Kamu Hastaneleri Genel Müdürü olduğu veya onların olmadığı ortamda Genel Müdür Yardımcının olduğu bir ekibimiz toplandı. Ben Acil Sağlık Hizmetleri Genel Müdürü olarak o anda uçak arıyordum. Yani Elazığ'a nasıl gidebilirim diye.
Just after 5 minutes after the earthquake happened, they had an organization centers in the Ministry of Health 50 minutes later, they became together for organizing this earthquake help.
Bakanlarımıza ait özel uçakla saat 0, gece saat 12 civarında hem Sağlık Bakanımız hem de bizler olay yerindeydik ve bir kriz merkezi ortaya çıkardık.
Just 3 hours later after the earthquake, the Ministry of Health of Turkey with their personnel, they arrived to the location of the earthquake.
Elazığ, Malatya'da tabii iki tane en çok etkilenen illerimiz Elazığ ve Malatya. Burada da
The most affected cities was Malatya and Elazığ.
Şimdi Elazığ ve Malatya'da toplam 153 ambulansımız, 13.000 sağlık personelimiz, yatak kapasitesi 5.990, yoğun bakım yatak kapasitesi iki ilde 1034.
For Elazığ and Malatya cities, they have 153 ambulance, 3,300 personnel staffs for health, and about 6,000 bed capacity, and over 1,000 intensive care unit bed.
Bu çok önemli. Bizim depremden sonra hızlı reaktif olan bir şeyimiz var, bir yapımız var. Onlara biz hazır olun, depreme gidiyorsunuz, afete gidiyorsunuz demiyoruz. Bizim ekiplerimiz hazır oluyor. Sonra yola çıkarken biz yola çıkıyoruz diyor, biz dur veya kal diyoruz ona.
They have a very active team. They are always ready for help.
8 saat içerisinde 2625 tane personel deprem bölgesindeydi.
Just within 8 hours after earthquake, over 2,600 personnel were transferred to the earthquake location.
Evet. 317 ambulansımız oradaydı.
317 ambulance were there.
Ki bu ambulans sayısı İstanbul'un yaklaşık 1.3-1.4 katı.
It is about 1.3 of Istanbul ambulance.
Aynı anda 2 helikopter ambulans, 2 uçak ambulans, pardon, 1 ambulans uçak, 4 seyyar hastane, 18 seyyar hastane ünitesi ve işte ısıtma sistemlerimiz ve jeneratör sistemlerimizi götürdük.
Simultaneously, at the same time, the two ambulance, helicopter ambulance, 15 helicopter ambulance, 2 ambulance aircraft, and four mobile hospitals, 18 mobile units, and 30 heating system was constructed at the earthquake location in Elazığ and also in Malatya.
Orada geceleyin ciddi soğuk vardı. Eksi 14 dereceye kadar soğuk.
It was very cold at the same time.
Kurduğumuz çadırlarda halk gece artı sarsıntılar olduğunda çadırların iyi bir ısıtma sistemi vardı. Hemen ısıtma sistemini kurduk. Yanında da bir jeneratör var. Artı 30 dereceye kadar içerisini ısıtabiliyordu. Halkın birçoğu tedavi olmaya değil ısınmaya bize geldi.
They constructed the heater system at the same location in a very early time.
Evet. Kurulan çadır kentlerde hızlı bir sağlık hizmeti vermeye başladık hemen. Gördüğünüz kırmızı çadırlar sağlık hizmeti verilen çadırlar. Toplam 11 tane seyyar acil sağlık ünitesi kuruldu. Buralarda hemen tedaviye başladık.
They constructed a very well done tents location for the people, injured people, within very short time.
Önemli olan şeylerden bir tanesi bizim depremlerde öğrendiğimiz şey. En son İstanbul 5.8'de yaşamıştık. Haberleşme çok önemli. Haberleşmenin kesintisi olması lazım. Biz buraya 5 tane mobil komut aracı gönderdik.
Nice. The communication in such disaster is very important. We can understand again how the communication is very important. So they communicate, they construct the communicate systems also at the same time within a very short time.
5 mobil komut aracından 2 tanesini yalnızca kullandık. O da telsiz desteği için. Yeni gelen 300 küsur ambulansa telsiz desteği vermek için kullandık. Yoksa telefon kapasitemiz iyiydi. Yerel ağdaki telsiz sistemimizde herhangi bir sıkıntı yaşamadık.
They prepared and constructed 2 mobile cars for communications.
Hastaların %65'ini orada bir yeni oluşturduğumuz bir şehir hastanesi vardı. Toplam 1631 hastanın %65'i Elazığ Şehir Hastanesi'nde tedavi edildi.
Of the injured patients, about 65% were treated in the Elazığ State Hospital, University Hospital, sorry.
Burada en önemli nokta afetçiler için Enkazdan canlı kurtardığımız 45 tane yaralımız vardı. Hiçbir tanesini kaybetmedik bu yaraları. Canlı çıkardıktan sonra stabilledik, aldık, hastaneye götürdük. Hiçbir tanesinin hayatı gitmedi.
The most important point is that they took about 35 injured people under the destruction, and all of them are alive, still alive.
Evet, önemli konulardan bir tanesi halk sağlığı hizmetleri. İnsanlar hemen anında göçükten çıkarıldıktan sonra başka problemler ortaya çıkmaya başlıyor.
Another one important point is the community health system. To organize it. Organizing community health system is very important.
1000'in üzerinde su numunesi alındı.
They get over 1000 sample from the water.
Hızlı bir şekilde göçmen sağlığı, orada da Suriyeli göçmenler var. Göçmen sağlığı merkezi kuruldu.
They have also Syrian migration refugees at the same location.
Riskli gebeler tespit edilip anne otelimiz var bizim orada. Anne oteline misafir ettik.
They take the pregnant women in a very short time.
Şimdi burada 2 tane hastane var. İlk göreceğiniz videodaki hastane, oradaki daha önce yapılmış bir hastane. İkinci hastane Elazığ Şehir Hastanesi. İkisinin arasındaki fark, bir tanesinde izolatör var, bir tanesinde izolatör yok. Depremde izolatörlü hastanelerin ne kadar önemli olduğunu orada daha iyi anladık.
Okay, another important issue is that having an isolator in the hospital. They have two hospitals in this location. One of them had, the other doesn't have.
Müzik benden değil.
This is a view from the time of the earthquake. It is about 5.4, I think, isn't it?
İkinci hastane izolatörlü hastane, şehir hastanesi. Başkanımıza bu görüntüleri vermeyeceğim. Şu gördüğünüz izolatörler.
These are the isolators.
Elektrikler kesiliyor. Otomatik aydınlatmalar devreye giriyor.
Electricity is cutting. Destroyed, totally destroyed.
Yukarıdaki sallanan hastaneyi görüyorsunuz.
As you see, it is sliding due to the earthquake.
İstanbul'da bu yıl içerisinde bir tanesi 2800 yataklı, 2 tanesi 1000 yatağın üzerinde, 3 tane hastane bu şekilde devreye giriyor.
In Istanbul?
İstanbul'da, evet.
Okay.
Bu kızımız böyle 1.50 boyunda, küçük bir kız. Orada umkeciler tamamen gönüllü biliyorsunuz. Kısa boylu birisini arıyorlar göçün altına sokmak için. Bu kızımız gönüllü oluyor. Böyle gözüktüğü kadar büyük bir şey değil.
The majority of the helpers or supportive are involunteers. This is a very short girl. She is also a volunteer for helping, for supporting the injured patients.
Ben evdeydim o sırada, kek yapıyordum. Hemen çantamı hazırladım ve yarım saat içinde
She was at home at the same time. When heard the earthquake, left the home immediately.
Olduğu için ona müdahale edecek ufak tefek birine ihtiyaç olduğunu söylediler. Ben hemen gönüllü oldum. Hayatımda açtığım en zor damar yoluydu diyebilirim. Benim sıvıyı gönderebileceğim bir alan söz konusu değildi. Çünkü serum setini yukarı dahi kaldırmıyordum.
She's when injured people and having intravenous assessment and give the fluids to these patients.
Ayşe Hanım'a böyle bir müdahalede bulundum.
It was very difficult for her to have an intravenous assessment. She's volunteer, not official staff.
Şimdi göçün altına giriyor. 5-6 metre ilerliyor. Alan çok daralıyor. Sonra hareket edemiyor ve montunu çıkarıp öyle ilerliyor.
She enters the inside of the injured destructive area 5 or 6 meters to the deep for following the injured patient.
Bunun en güzel tarafı bir tarafta artçı sarsıntılar oluyor 4 şiddetinde.
At the same time the earthquake is continuous.
Bu sarsıntılarda bu kadar yerin altına girip bu kişi gönüllü olarak bu işi yapıyor. Yani bu işi yaptığı için herhangi bir para almıyor.
Even though the earthquake still continues, she inserted 6 meters underground for rescuing the patients, the injured patients.
Göçük altında 5 kişi 112 arıyor.
Under the destruction, she called for the 113 staff, emergency med staff.
112 göçük altındaki arayan kişilerle göçün oradaki olan sağlık personeliyle konuşturuyor.
The emergency staff called with this lady while she was under the destructive area and connected to the patients.
Azize bak sen bir annesin. Aşağıdaki herkesin şu an annesi sensin. Ve bizim tek iletişim kurduğumuz kişi sensin. Bütün güç sende. Tamam mı canım? Sen daha güçlü olacaksın.
She is trying to stabilize the patient who are under restrictions.
Evet, Türkiye'de 11.900 tane gönüllü var. Günlük rakamı
We
değişiyor,
have
artıyor, eksiliyor.
about 12,000 volunteers
Evet.
for disaster management.
Dünyadaki örnekleri için Amerika Birleşik Devletleri ve Türkiye karşılaştırması var.
This is a comparison of Turkish and the United States volunteers.
Üst tarafta nüfus, ortada medikal kurtarma ekibi isimleri, aşağıda da toplam personel sayısı.
Yes, in the up you can see the population number, and down you'll see the volunteers numbers. Turkey is about 83 millions. US is over 27 millions, but their volunteers is just 5,000. The Turkish volunteers is about 12,000.
Bu gönüllerin tamamı sağlık personeli.
These all volunteers are staff. They are working in different places.
İşlerinde acil tıp uzmanı, radyoloji uzmanı, toksikoloji uzmanı,
This
halk
teams-
sağlığı uzmanı.
These teams includes emergency medicine physicians, health physicians, and general practitioners, and also paramedics.
Yalnızca tabii başımıza deprem gelmedi. Aynı dönemde depremden yaklaşık 15-20 gün sonra Van'da bir çığ felaketi yaşadık.
We didn't just have the earthquake disaster, we also have an snow sliding just 20 days after this earthquake in the east side of the Turkey.
40'ın üzerinde hayat kaybı yaşadık.
We have over 14 deaths in this sliding, snow
Bu da
sliding.
Dünya Sağlık Örgütü'nün UMKE ile ilgili, bizim kurtarma örgütümüzle ilgili düşünceleri. Dünya Sağlık Örgütü'nün Türkiye temsilcisi konuşuyor. Şu
This
anda
is this is one responsible of the WHO, the WHO. He's declared his opinion about the Turkish team supportive.
The standard procedures are in line with the best international practices for rescue medical teams. The last 15 years proved that UMKE is also an indispensable rapid response team regionally and globally. UMKE provided support during many emergencies, from Haiti to Japan or Indonesia to Iran, and recently in Albania. With its 12,000 volunteers, health professionals, UMKE is surely ready to respond rapidly and save lives all over the world.
yaşadığımız afetlerden sonra devlet büyüklerimiz bize çok ciddi destek oluyor.
After this disaster, the manager of the, especially the president, they supported this team very well. They thanked to them.
Evet. Teşekkür ederim. Bunun peki toksikolojiyle ne ilgisi var?
Okay, he thanks and he's going to explain what is the relationship with this presentation and toxicology.
Evet. Şimdi başta gördüğünüz gibi
as you see it in the beginning, very beginning,
kurtarma örgütümüz var. 112
we have yes, rescue teams.
Evet. İlk herhangi bir vakayla karşılaştığımızda sahada 112 ve UMKE ekiplerimiz olay yerine gidiyor.
When we face any problem, especially disaster, our UMKE is a team for first aid. They transfer to the location.
Üst kuruluşumuz olan AFAD bizden önce ulaşmışsa kırmızı bölgede yaralıları çıkarıp bize teslim ediyor. Eğer bizden önce ulaşmamışsa ve geç geleceğini düşünüyorsak bizim buna karşı donanımımız var ve olay yerine biz giriyoruz.
AFAD is the top construction for the first aid in Turkey. First they are transferred to the location when they get they get the injured patient and deliver this patient to the next teams.
Buradan hastayı aldıktan sonra eğer olay yerinde çok fazla hasta varsa, yıkanması gerekiyorsa, KBRN gibi düşünmemiz gerekiyorsa onunla ilgili modüler taşıyabildiğimiz çadırlarımız, konteynerlarımızı ve hastayı oradan alıp temizleyip araçlarımızı alıyoruz.
Okay, they are doing triage for triage and the location, the scan. They have mobile cars for first aid, especially for the chemical exposure or biological exposure in the scan. They have mobile. They are doing this jobs in mobile cars.
Burada temizledikten sonra en yakın hastaneye götürüyoruz. En yakın hastanede yine temizlenmesi gerekiyorsa burada da KBL ünitelerimiz var. Hastayı temizleyip sonra izole bir odaya alıyoruz.
Okay, they do this triage in scan during the transfersion. When they arrive to the hospital or any units, they do the same triage at all parts, and then transfer the patient to the available units or intensive care units or bed.
Depremde toksikoloji ile ilgili ne olmuş olabilir? Başımıza ne gelmiş olabilir?
What about in the earthquake about toxicology?
Çadırları kurduktan sonra çok
After they
sayıda kişinin
constructed the tents,
elektrikli ısıtıcılar yetmediği için veya gazlı ısıtıcılar yetmediği için soba kurduğunu gördük ve sobadan karbon monoksit zehirlenmelerine maruz kaldığını gördük.
Due to the deficiency of the electricity, they construct the heater. So due to this heater, the carbon monoxide intoxication maybe happened.
Çığ bölgesinde de
Because these patients are not used to live with the heater.
Bizim kurduğumuz bir çadırda orada bizden izinsiz bir soba türü bir şey kurulmuş. Bir gazlı ısıtıcı kurulmuş. O bölgede de kurtarma personelinin oradaki gazdan zehirlendiğini arkadaşlar fark ettiler, müdahale ettiler. Çok büyümeden önledik.
In snow sliding disaster, some of patients they established in the tent without getting permission and constructed that heater, and they had a carbon monoxide intoxication.
Ve burada bahsetmediğim Sabiha Gökçen uçak kazası oldu. Sabiha Gökçen uçak kazasında 183 tane kazazedemiz vardı. 3 kişi hayatını kaybetti.
After the snow sliding, we had an aircraft accident in the Sabiha Gökçen airport. It enrolled 183 injured patients.
Biz buraya 105 ambulansla müdahale ettik ama beklemediğimiz bir şey daha oldu.
We act with 105 ambulance to this accident.
Aynı anda uçak kazasında olduğu halde uçak kazasına yardıma giden, desteğe giden aynı anda 5 polis bir araçta giderken araç trafik kazası yaptı. Aynı yerde oluyor bu olay. Uçak kazasının olduğu yerde. Onlar yaralandı. Aynı tarafta onlar da kazazede, onlara koştuk.
For supported this accident, a police car included 5 persons had an accident at the same time, at the same location.
Pendik'te olaydan yaklaşık 30 dakika sonra Pendik'te bir metro çökmesi olayı oldu. İnşaatı çöktü. Orada da 4 yaralımız vardı. Onlara da aynı anda müdahalede bulunduk.
Okay. After 30 minutes, just after this aircraft accident, a metro accident has happened. Very clear, very close to this location.
Ve toksikoloji ile ilgili bir şey oldu. Tahmin etmek isteyen var mı?
A toxicological event happened that. Who want to imagine?
Ve 16 kişi maruz kaldı bu olaya.
16 persons were affected. Kimyasal maruziyet? Petrol?
Yok, hayır.
What else? Want to imagine?
Şöyle.
Just wait.
Uçak yakıtında.
Do you have any gift? Do you have a gift for? Yani bir ödülünüz var mı bilene?
Nasıl?
Bilene bir ödülünüz var mı?
Ödül,
Do you have a gift?
Ödül konusu Başar hocamın. O zaman biraz da hocam.
Yes, President, he's going to give a books. No. Who will say 3 answers?
Ne oldu?
You? Can you ask the question again? Sorunuzu tekrar sorun diyor. At the metro accident,
bir toksikolojik bir olay yaşadık.
They had a toxicology event.
16 kişi zehirlendi.
16 people were injured in this toxicology event. What could be? Huh?
It's somewhere, yeah.
No, what did you say? Metroda mı?
Yok, hayır, yorum yok.
Ha? There is no comment for
location.
Huh? No, there is no comment. There is no comment for location. They have 3 accidents: aircraft accident, metro accident, and car accidents.
Kurtarma ekipleri
just
hocam.
A minute. Did you understand the question? Let me. Just. They have 3 accidents at the same time. First, aircraft. Second, car accident include 5 injured. and metro accident includes 16 injured. Among these three accidents, there was an toxicological events, and 16 persons were injured. What could be? This is the question.
It was inside the subway or somewhere else?
Huh?
It was inside the subway or somewhere else?
There is no comment. No comment.
Evet hocam şey yapalım. Uçak yakından zehirlendiler.
Ha?
Şöyle.
Yeah.
Evet. Şimdi
They were the toxicological even happened due to the aircraft oil.
Şimdi 16 kişi uçak yakından zehirlendi ve biz bu hastaları taşıdık. 105 ambulans, Sağlık Bakanı'nın ambulansı artı diğer ambulanslarla birlikte havalimanı ambulansları, belediye ambulansla birlikte 123 ambulansla müdahale olduk.
Yes.
Müdahale olduğumuzda
They act with 126 ambulance to the this event. Dr. Hussein, imagine it. Dr. Hussein of the right question. Let us have a coupling to him. Dr. Hussein, you gain an book. Sit down, sit. Have a seat, please. Have a seat. Then after lecture, find President Dr. Bashar, get him from him a book.
Hocam misafirlerimize kısa bir şey yapayım. Amsterdam uçak kazasıyla.
He is going to compare the accident, similar accident happened in Amsterdam.
Sabiha Gökçen uçak kazasının kısa bir karşılaştırmasını yapmak istiyorum. Amsterdam uçak kazasında ilk hasta olay yerinden 74. dakikada hastaneye nakledildi.
A similar accident, aircraft accident happened in Amsterdam. The first patient transferred to the hospital get 74 minutes after accident.
Türkiye'de ilk hasta 21. dakikada hastaneye nakledildi.
Hastanedeydi
hasta.
As this accident happened in Sabiha Gökçen Airport, the first patient was transferred to the hospital within just 25 minutes. But you should imagine the crowd in Istanbul and in Amsterdam.
Amsterdam uçak kazasında 54. dakikada bir hasta uçağın yanında, bir kazazede uçağın yanında ambulans beklerken hayatını kaybetti.
One patient in Amsterdam accident that died in 54 minutes while waiting for the transfer to hospital.
Türkiye'de uçak düştükten sonra hiçbir hastamızı olay anı haricinde kaybetmedik.
In Turkey, never any patient was lost during this accident happened in Sabiha Gökçen.
Teşekkür ederim.
Thanks. I just want to thank to Dr. Semi and his team. They are really very hardworking and they are have a well done organizations. And acting the accident immediately with their whole team, included emergency medicine physicians, health physicians, paramedics, and also with securities person. So really, their results is very, very nice when you compare this with the other event happened in the world. They are going to establish this. They are going to publish this results, I think, isn't it? Bunları yayınlayacaksınız herhalde bu sonuçları. Yes, they are going to publish this results soon, so you can be able to find and to follow them from the publishments. Any questions?
Sorry.
Thank you. Halas. Evet.
Olarak bize oradaki tecrübelerinizden az da olsa bahsedebilir misiniz? Özellikle hastane öncesinde ne gibi hazırlıklar yapıldı?
He's asking about their experience that they did in snow sliding.
Sağlık ekipleri orada doğru yerde duruyordu. Olay yeri yönetimini doğru yaptılar. Olması gereken yerde duruyorlardı ve sağlık ekipleri ikinci çığdan sonra olaya ilk müdahale olan ekipler.
Okay. I need an explanation. May our guests do not know it. In the snow sliding, first we have a slope sliding, and about 5 persons were lost. Why, during the people were working for rescue, a second one happened. Just after the second snow sliding, the person who were trying to rescue the patients, about 35 of them, they injured and died. He's asking about their experience for this event.
Teşekkürler Başbakan. Teşekkür ederim. Çok sağ olun.
Allah, خلاص.
I get the privilege to introduce the next speaker. This is Dr. Amin Kazi, who's a professor of emergency medicine at the American University of Beirut in Lebanon. Amin did emergency medicine residency at Henry Ford Hospital in Detroit, Michigan, and he has many passions about the practice of emergency medicine, and today he's going to talk about emergency medicine practice in the MENA region.
Hello. Good afternoon. So I was preparing for 15 minutes. So I tried to reduce my slides to something that would drive a message that I think would bring us all in common as we are opening a new page in our relationship, hopefully, across the region, across the world. The sky is the limit in terms of collaboration, and I look forward to working with my new friends, the ones I made in this visit. I want to start by thanking EPAT and MENA Talks and all the sponsors and everybody involved in making this event happen. I'm going to talk about something basic that we all live, but is simple enough that I guess we will have some lessons all to really derive from. It's about the challenge of establishing the specialty of emergency medicine. What I have learned personally from experiencing emergency medicine from the time I was a student in the late 80s in Detroit to the time when I was a junior faculty to the point where I was chairing departments and establishing residency programs and journals and books. And the journey has given me the privilege of remembering what Turkish emergency medicine was like in the early 90s when I used to climb hills with Tintinelli here. It has given me the pleasure of, today actually I was talking to Dr. Gucha about the existence of two societies in Turkey. And what I tried to highlight, and it's very important to remember that the emergence of more than one society in the actual description of international emergency medicine is actually a sign of health, not only of positive challenge, but actually it highlights the complexity in which emergency medicine has gotten to be in Turkey. That itself is a sign of development that has taken you from being embryonic emergency medicine to developing to developed. You are now in the developed phase of emergency medicine where you have the complexity that it takes to be able to build new models and think differently, complement each other, and we'll move forward towards the future. So, what can we discuss today that could be a good ground rule for us all to collaborate? Let's go to the next slide, or I guess I can do that. How did emergency medicine start? You may have seen some of these slides because they talk about the history of emergency medicine in the United States. In between 1940 and 1955, emergency department visits had gone up by 400%. Industrial revolution, people were moving from the model of having a primary care doctor in the small village in Ohio to having people from New York living in California with no access to doctors. Everything, it's an industrial revolution. People are traveling, living, moving. There was a collapse of the traditional model of the primary family doctor who knows you, tells you, oh, you got a pneumonia. Why don't I admit you to the community hospital? So you go to the community hospital where they put you on their name and they take care of you with IV antibiotics. Things changed. Numbers were going up. People had nowhere to go but to the hospital, to the emergency room. To the emergency room, which at the time was a room. At the same time, early then, we didn't have the interventions we had now. There was no defibrillation. It was in the late 60s, mid-60s that they started introducing that on humans and in emergency departments, that people started using that as a therapy. We did not have CT scans. We did not have thrombolytics. People were still actually who were our grandfathers, did not have the complexity in interventions, diagnostic tools and protocols and standards which we have now. They were still embryonic in their thinking in the resources that they had. They had antibiotics, they had laparotomies, but they did not have everything we have now in advanced airway techniques and in different perspectives on the management of disease and clinical conditions. When they came back from Korea, the Americans noticed during an accident where somebody kind of had multiple injuries in his own family in the Midwest, Dr. Kennedy realized and published in the Bulletin of the American College of Surgery at the time, the Annals of Surgery, he actually, which is now the Annals of Surgery, he published a statement in which he said, the weakest link in the chain of hospital care in most hospitals is the ER care of the injured. Of course, he's a surgeon, he would think normally of trauma. But to them, in Korea, they were providing better care for injured patients than they were in everyday life in their own country. Why? Because there was no categorization, no trauma systems, none of this existed. So they were receiving poor care in the community hospitals. It does not really help to just have a wonderful tertiary care center. You need to have the type of care go across the whole nation into community hospitals in the smaller communities, be able to uplift and improve emergency care everywhere. Public pressure, public awareness that there was a problem grew. And the public, through lawsuits, through articles in the media, pressured authorities and declared that what they needed, this was in the New England Journal of Medicine in 1958, they were calling for experience and judgment of the physician who's directing this. This was no longer just about providing a good defibrillator, a very solid bed. It wasn't about the physical space and equipment. It was now about experience, therefore retention of experience, and judgment. To have judgment, you have to have training. You had load and complexity increasing, and it was increasingly important to have adequate training and mature judgment, experience, and adequate training was for the personnel, not only physicians. So they started calling for comprehensive training in around 1958. There were no emergency physicians yet. And everybody was calling for physician experience in the emergency ward for medical and surgical patients. Certainly, they were internists and surgeons talking, so they missed pediatrics, ophthalmologic, obstetric, gynecologic, urologic, toxicologic. So you can imagine the scope. I'll spare you the history. The history is how they started developing staffing for emergency departments, where in Pontiac and in Virginia, in Michigan and in Virginia, doctors started working part-time. 24 doctors left their practices and started doing part-time rotations to staff an emergency department. Another model, 6, 7 doctors left their practices full-time and started practicing full-time emergency medicine to take care of patients. This was the early 60s, the Pontiac and the Virginia plans. The Alexandria, Virginia plan. Those two plans were the first people who said, we are emergency physicians. Part-time and full-time. By the late 1960s, 68, people were starting in the United States, in Canada, in Australia. At the same time, people were coming together and starting to do training in emergency medicine. Dr. Bruce Janiak, who wrote his own curriculum in the University of Cincinnati and started introducing himself as an emergency medicine resident, even though there was no program. So he's a resident without a program. And then in USC, University of Southern California, Gail Anderson, an obstetrician, actually was appointed to start a residency program at the time with four spots only, that were basically the first residency program in 1970. 1970, 71, you had a surge of programs such as Henry Ford Hospital, University of Chicago, where Peter Rosen was, and there was, then you had this growth of programs across the United States and later across the world. And sounds for me, thank you. Here we go, I should close it. would a nation, a community, or government want? What is the ideal center? What do they want? Three things. The people, the community, the nation wants three things. Easy access to emergency care, quality emergency care, affordable emergency care. They want easy access, they want quality, and they want to be able to afford it. What is easy access? It has to be nearby, proximity, no obstacles, no restrictions, no gatekeeping, no need to pre-authorize the care, no financial administrative bureaucracy, none of that. They don't want to do full paperwork, they just want to show up, receive the care, and leave. No delays in receiving a CAT scan, a study, a consultant. If you break your leg, you want the orthopedist to be there before you. This is what the public wants. Easy access is having all these resources without bureaucracy and nearby. On the other hand, of course, if you welcome all comers, you have a problem. So the other option is to limit access via pre-authorization requirements, denying care, restricting care, and the institution of co-payments, annual deductibles, qualified triage and medical screening, with directing patients or away from the ED to the clinics, or securing prompt access to alternative resources where they can get the care. So you have a balance between these two in restricting or making available these resources with regard to the concept of easy access. Of course, proximity to an emergency department when every minute counts and the golden hour of trauma is a principle requires proper planning, proper distribution without redundancy and duplication. You want to avoid the fragmentation of services. You can't have an obstetrician waiting in every room 24/7, just for 1 to 2% of our cases are OBGYN in my department at AUB and the University of California. So if all those cases are 2% of the cases we receive in the emergency department, should we have an obstetrician waiting there at all times, or should we train someone to do the stabilization and avoid the redundancy and the fragmentation? When I went to AUB, we had an OB room, OB ED, pediatric ED, surgery ED, ortho room. I mean, everybody had sectioned the place, fragmented it, and God forbid you came with abdominal pain because of Mediterranean fever, and you were a woman, you'd go from OB to internal medicine to surgery, and you'd be flipping around, and delayed and sometimes missed. So you need, avoiding fragmentation, you need to categorize emergency services in all hospitals, addressing the plan, especially addressing and having a plan for the special challenge of rural and remote area. We can make rules that can apply in Istanbul, in Antalya, but can we apply that in small little villages, have the same staffing and concepts apply? What do you do? Telemedicine, lower level providers that are agreeing to pay less, to be paid less, and yet to do more? And how do you provide that support for them? Provide teletransportation, transport these patients every time they have an issue. How many scanners do you have? How many emergency departments, ultrasounds? The Russians, in a country as big as Turkey, they have for every 20,000 to 40,000, for every 1,000 people, they have a GP. For every 20 to 40,000 patients, they have an ultrasound and an urgent care center. For every 200,000 people, they have a scanner. For every 2 million people, they have MRIs and tertiary care centers. So you have to think, compare that to your own countries and realize redundancy, fragmentation, cost of care. Easy access requires categorization based on capacity. And when I say capacity, it's not the ED capacity only. It's the institutional capacity. Institutional capacity because it requires ICU, stroke capacity, imaging, turnaround times in reading of this imaging. That's how you end up having the capacity to define level 1 and level 2 trauma centers, paramedic receiving centers for cardiac cases, cardiac receiving centers with cath labs, stroke centers, replantation services, as well as classifying them as urgent care. There's no shame with just being an urgent care center. If you don't have the capacity, do not claim to have it, you will hurt people. Very difficult in the MENA region. I don't know about Turkey, but I can tell you 150 institutions in Lebanon, the size of Orange County, we need 25 to 30, 40 maximum emergency department. We have 150 that claim to have it. Therefore, you have 100 at least places where you can have disasters every day because people don't know how to intubate and they're receiving any cases. Nobody will agree to say, we don't have it. So you have delays and problems. It's Georgia. Second concept is quality. Easy access, okay. Quality. What defines quality? And how do you measure quality? When you're arguing with other disciplines over emergency medicine and how necessary, often I used to hear, prove to us that you're better. How do you prove that? There are a few studies that prove that we can do things better, but not many. Not many. We can prove that we can make a difference, but there aren't a lot of studies that do so. However, we all agree that to have quality, you need training, clinical experience and maturity, maintenance of quality, and administrative excellence. I believe these four elements are necessary to secure quality. Quality of training through emergency medicine residents and the development of EM specialists, as well as the provision of proper support to have community emergency physicians who may not be trained in emergency medicine yet, or may never be, because some of our graduates will not work in Yosemite National Park where they have to deliver babies and provide treatment for diaper rashes. They're the only doctor for large community. They will do things that are not strictly resuscitation and diagnosis. They will have to be the family doctor also for these rural areas. So where is the proper balance and how can we embrace it rather than deny its existence is a challenge. We train physicians, but if we don't train nurses and our paramedical providers, we are, and I'm not talking only about paramedical pre-hospital personnel, I'm talking about the clerks, the technician, the orderly, the transportation. Everybody has to have a code of ethic and code of work. And they have to be oriented, trained, and retained. Retained is a very important concept. Leaders and administrators in the ED also require training to be able to be effective. Training has to be curriculum-based, supervised 24/7 by qualified faculty. The concept of having a consultant drink coffee in the office while the resident is seeing patients and they just review the charts or only the bad cases is not an option. Proper supervision in this day and age, quality supervision requires the resident to be your assistant while you are overseeing how they are performing. When they are more senior, to have independence and autonomy and be able to supervise them is in a different way is something we grow into, but supervision has to be at the bedside and 24/7. We no longer should be having supervision without that. With every patient encounter, these training centers must be accredited by national or regional or international agencies as meeting adequate standards for specialty training. And my hope is that we will be able to work in the MENA region with the EPAT and other organizations to develop these standards for specialty training, for accreditation of training centers, and the accreditation of certification bodies. The minimum is 3 years of full-time categorical residency training. This little bit here, little bit there is not, these small little courses are not training. Accreditation through categorical programs with proper ED volume. You have to have a minimum number of patients in the emergency department to provide this training, and they should be audited to make sure that we have enough trauma, enough procedures, enough pathology that can provide the training. And if you don't have it, you go to another center to secure that too. Continuing medical education activities to cover the curriculum for the residents and for the graduates, as well as research and administrative training. They're both important to really provide the success of the specialty. unrestricted access to all clinical conditions. It's not good to have trauma cases. I went to UC Irvine. When I arrived in 1992, we were holding the curtain. The trauma team would come in and we're no longer allowed to touch the patient. That didn't last more than 6 months. By that time, the trauma surgeon moved to Santa Barbara. But the point is, we won that battle and we started doing if you don't have access to patients to do things to them, you don't get access to the training. It's not enough to be a witness. It's also important to start teaching our residents and physicians who to admit, who not to admit, to do workups in the ED rather than in hospitals in Lebanon. The way to avoid, when they don't have good training, what they do is they over-admit everybody. So you have 60%, 40% of emergency patients get admitted so that they get the workup inpatient. In our ED, when we developed the residency program, we went from 21% admission rate to 16% admission rate because we started doing longer workup, more expensive, but less costly in terms of total admission because we were sending patients home. So indirectly, you develop clinical skills and you reduce the cost of care. And you need to maintain quality through continuing medical education, long life learning assessments and exams, through the retention. You know, we have annual exams we take to make sure we're up to date. This concept should be maintained for all our graduates. It's not enough to just graduate and get certified. It has to be ongoing. And in my department, I can tell you, we provide every 3 months ongoing individual OPPE, professional physician performance assessment evaluation, where we sit with every doctor and we give them the number of patients that they admitted, the percentage they admit, how many times they used carbamazepines, how many times they ordered troponins, how many CT scans they order. So we monitor the average and the trends, how many bounce backs, how many mortality, morbidity they have had. This is done on every 3 months to make sure we are maintaining quality. Day-to-day operational oversight with the medical director or program director, operation performance improvement measures, administrative resources are required to do that. Therefore, money, time, protected time is essential to provide quality. Maintaining quality requires also maturity. I spoke about this earlier. It is important to retain emergency physicians and nurses. To have experience and maturity, people have to stay, and our field is extremely demanding. We have a high burnout, high attrition. We have high risk with exposure to tuberculosis, to violence, to aggression, to liability issues. So we have undesirable practice conditions and physical demands, working night shifts, working weekends. People have to be careful about the number of hours we work, and we have to support our physicians and nurses to be retained within the specialty. This support is critical to retain people and retain the expertise, and requires a commitment by institutions and authorities to do so. Last is affordable emergency care. What's affordable emergency care? Who pays for emergency care? Where does the money come from? Government agencies, private insurance plans, cooperative funds, self-payers, and personal means. People who use cash, their own. Anybody knows any other way to really pay for health care? Not pay. Because I mean, it's so easy to see people say, you need to take care of the poor, you need to take care of so and so, how could it be so expensive? But people cannot want two things at the same time. At the end of the day, what we provide is going to cost money, and somebody has to flip the bill. And if it's all paid for by the government, then expect high taxes. So, and then therefore also higher bureaucracy. So what is the proper balance? To patients, affordable means free. Get someone else to pay it. To insurance, affordable means coerce facilities and providers to accept the least for providing it. To the government, affordable means restrict access to resources, to limit utilizations when it is most needed and yet most difficult to say no to the patient. So when the patient comes in distress and you cannot say no, limit it, restrict it. So everybody is pushing you in a different direction, and this requires a lot of maturity and diplomatic skill to be able to steer emergency medicine the right way, and I'm confident that EPAT and the authorities in Turkey are working on this together. So is access to all emergency care and urgent care a civil right? Is it a legal right, a humanitarian right? What do you do with illegal immigrants? With the unemployed who do not pay taxes? Do you provide them everything? Will you go bankrupt to provide a transplantation for someone who can't afford it, who's not even Turkish or Lebanese? Big questions. Or do we transport them back to Syria? We've had those questions come in our department. Who makes the decision? And are we really providing everything ethically? What would the public, the voters paying patients or private insurers do if they realized they were paying for the others who do not contribute through cost shifting or a high tax burden? Are they aware that this is the case? Is the public educated? I'll stop here. The rest would be more negative. So, any questions? So, in other words, I hope that we will be able to work with EPAT on establishing the criteria and the standards for proper training and certification and ongoing lifelong learning. Standards that we need to provide that are tailored to our region and to our nations. Thank you for having me. Any questions?
You had a slide, it was written there, avoiding for fragmentation the emergency service. What did you mean?
Fragmentation, the biggest classic, the biggest classic form of fragmentation, Bashar, is when you remember the traditional emergency departments where you had ER surgery, ER pediatrics. That's one form of fragmentation. So or even fragmentation when you bring a patient in the ED and there is no room inside pediatrics. What do? You make them wait, or you put them in the urgent care and see them there. So we need to have people, snap people out of the concept of this is not my patient or this is my patient. So you don't want people to say this is my patient, don't touch it. This is wrong. But you also don't want to say this is my room, don't go in. So fragmentation is when you compromise proper patient care in the name of my turf. This is my turf. I'm under my authority. No one else does it. That's one form.
Thank you very much. I'm totally agree with this procedure because in the past we had such system in Turkey, especially in the government hospital, state hospital. In emergency department, it includes different rooms. This is the pediatric, for orthopedic and for neurosurgeon and for even eyes. So we remove all them from the emergency department. Now the emergency department just depends to the emergency physician now.
Of course,
but we still have some.
It's no longer the trauma room; it's the resuscitation room. You need to go into the. It's a procedure room, not the casting room. You know, we have to start thinking differently. Thank you.
Thanks, everyone. Okay. About information resource for poison centers. I think every presentation is 20 minutes, not 10, like Mark.
It's probably going to be closer to 10
okay,
room for questions. But okay. Yeah, so it's all right. Yeah, super short. So good morning. It's good to see you all again this morning. I'm Lucy Schiffelbein, so I'm from the New Zealand National Poison Centre. And I just want to talk a bit about information resources that are available to poison centres and that we consider to be essential and ones that are probably not quite so useful. Can I have a... Thank you. Okay, let's see. So basically we're looking at, does Dr. Google know everything? Who uses Google here to search for information? We all do. So first of all, just disclosure. I'm the manager for the Toxins Poisons Information Database and a member of the Toxins Advisory Group. And Toxins is a sponsor of this meeting. But here this morning, I'm speaking to you in my capacity as Managing Director of the National Poison Centre. So the primary aim of a poison centre is to reduce the morbidity and mortality due to poisonings. And the primary role is to perform risk assessment and provide management and treatment advice. But in order to meet that aim, to reduce morbidity and mortality, early treatment and management advice is essential. So you don't want to be thumbing through pages and pages of information and taking forever to find the information you need. So we obviously need information on chemicals, hazardous materials, household products, therapeutic medicines, plants, fungi and venomous creatures. But again, it needs to be readily accessible and it needs to be reliable. So who here can tell me what is the best resource that a poison centre has? Anybody want to guess? Your senior colleagues and clinicians, they are a wealth of information and they're a great go-to source. So what resources should a poison centre have? Well, I guess you need to look at what are the activities of the poison centre. Are you just a poison control centre? Do you provide drug information service? What about pregnancy and lactation service? Or veterinary information? So considering all those services will help form what resources you need to have on hand. So things like conference abstracts are a great source of information, and internal treatment guidelines and protocols. You heard Dr. Lopez say yesterday that they had some internal protocols that they refer to. A lot of poison centres will have protocols on the most common poisons or the most serious, or the top sort of 30 toxidromes, and they're written and developed in-house, and they're quite a useful source of information. Journal articles. People often have interesting cases they write up. It's another great source of information. And then there's electronic databases and textbooks. So WHO actually has a recommended list of texts, probably slightly out of date in terms of this was written in the day, well, a few years ago when internet accessibility wasn't quite as good as it is now. It was expensive and not everybody had access to the internet. So they have a list of textbooks, and you've probably all seen these, and hopefully you all have them. Some of the editions may have changed, but they have a list on their website if anybody wants to look at that. So let's talk a bit about electronic databases. First up, there's ones that are accessible by paid subscription only. So there's Toxins, which is the poisons information database developed by the New Zealand National Poison Centre. Poisindex by Micromedics, that was originally developed by the Rocky Mountain Poison Centre quite some years ago, and it's now commercial. And again, it's by paid access. And the third key electronic database is ToxBase, and that's produced by the UK Poison Centres. So there's also access to a lot of information, and one of those databases through Hinari, which is free to developing countries. If anybody needs information on how to sign up to access these resources, I'm more than happy to show you how to do that. So some of the free online databases that you don't need to pay for, some of the chemical ones, you've got the IPCS InChem program, and that's got information on exposures like environmental, food and occupational exposures. Then we've got the PubChem, and that's free. All of these databases used to be under ToxNet, but then ToxNet was kind of retired and all of these databases were rearranged. And I'm happy to share the slides that have got the links in them if anybody wants them. So again, that's another chemistry type database. Searching PubMed for toxicology literature is quite easy. They have a little, you can define it so that it searches only toxicology information or toxicology literature, so you're not searching the entire PubMed database, which makes it a lot faster to access. Pregnancy, breastfeeding, lactation information, so there's breastfeeding and drugs, which again is free, so that's the LactMed database. Another chemical one, which is the ChemID Plus. It's got 400,000 chemicals on it. And then there's the developmental toxicology literature, again, searching through PubMed, but putting a refined search in, so it's only searching for the DART information. Drug-induced liver injury, which is liver tox. It's free online. And household product safety. So if you've got someone who's swallowed a a new cosmetic that's new on the market and you're not sure what the constituents are, you can search for it and it'll bring up the ingredients. And then there's the occupational exposures, the HAZMAP database. And then last of all, there's the EPA risk assessment IRIS program. Okay, so let's talk about Dr. Google. Let's have a go. Let's ask Dr. Google to find the intervention criteria for a diltiazem overdose. So what is the problem with using Dr. Google? Well, where does the information come from? Who wrote it? Are they even qualified to write it? Basically, I could write a data sheet on anything and stick it on the internet and say that it's credible, but how do you know? When was it last updated or reviewed? What search terms do you need to use to find the information you're looking for? When you ask Google a question, it's going to answer what you ask. So if you don't ask the right question, you're not going to get the right answer. And how many results do you have to troll through to find what you're looking for? You know, sometimes you can scroll through pages and pages of information, and it's sort of hit or miss to get the right result. So here we are, we'll look for information on a diltiazem overdose. First thing that comes up is the pet poisons line. I'm not entirely sure that it's going to be useful in this situation. So if you scroll down the search results, you'll find a lot of PDFs and a lot of blogs and a lot of information. Which one, do you have to open every one to find what you're looking for? So you see there at the top we can find, it's brought up to date, but again that requires paid access. And if I scroll right down to the bottom of the page, you can see there that I've got Medscape, which is free, and I can access that easily. So let's have a look at that. So that's got some really interesting treatment information. It's got some, what have we got there? Some treatment approaches, some therapies. But what's missing? It's telling me here that I should admit all patients with a calcium channel blocker ingestion to ICU. That's quite a broad statement. What if my patient's only taken one tablet? So what's missing here? The intervention. How much is too much? It's fine telling you how to treat the patient, but you have to be aware of what are you treating and why are you treating. Also too, look for things like who was it written by, when was it updated, so that gives a piece of information some credibility, so you can usually click on those links and it'll tell you a bit about the authors and when it was updated and where they're from. So just to recap, poison centres need to have access to both print and electronic resources. All information resources need to be credible, reliable and up to date, and access to information needs to be rapid. The information should be clear and concise. It shouldn't have any guesswork in it.
Please.
Thank you. I wanted to ask you a little bit about language, availability of resources in different languages. Mm-hmm. I know we collaborated with toxins in Kazakhstan, for example, and Kazakhstan, the language is difficult for them a little bit in terms of English. They prefer to have something in Russian. Are there any solutions, there's no easy solution, but are there any potential solutions for translating some of these references, or is it impossible?
But given the nature, we've looked at making the database localised, obviously in different languages, but given that there's hundreds of thousands of substances on there to translate it, it would be quite difficult. So we are exploring different models whereby we could have the database and somebody in that region would be responsible for updating the content and translating it. So you'd have different languages for different regions. And again, we're still exploring that. We definitely acknowledge that language is an issue.
Are there any other languages other than English? I mean, are there any resources in Spanish or Portuguese or?
So again, other than Google Translate.
Yeah.
What do you do in Italy as well?
Actually, we use the English-based information, and I was curious to ask you, what about plants? Because it's really difficult, in my opinion, to find something about some database about plants, mainly because of the different geographic distribution?
So on toxins, we do have images, so you can verify a plant.
Yeah.
And because toxins is an international database, we try and have as many sort of international themed plants, venomous creatures, and the likes, which also have images that are, you know, for that region.
Yeah, okay. Thank you. Yeah, please.
Thank you for the presentation. We almost 26 years experience in poison center in our department and in Turkey, in 9 Eylül University. From the beginning to now, we use poison database, and this database is very user-friendly and simple English, and it's easy to find the data. What do you think about what are the difference between the poison decks and toxins? I don't know. I didn't know this database up to now.
Yep. So, I'll just quickly say, if anybody
That's
wants...
a great question. Dr. Yasin Tunçuk is also the president of the Turkish Society of Pharmacology, so thank you.
Okay. Good to meet you. So toxins, I'm happy to give anybody free access so you can actually have a look and decide for yourself whether it's a good resource. One of the key differences with toxins and poison decks is when you search on toxins, straight away it brings up summary information. So very clear, succinct summary treatment advice, so you don't have to scroll through and look for it. It's right there. Products that have multiple constituents with poison decks, I know that you have to search for each ingredient separately, so that's potentially 3 different searches. Toxins will bring up all of the ingredients in the same monograph, and it will have the adult and pediatric intervention criteria for each ingredient listed one below each other, so you don't have to search and flip between pages. So that's quite another handy feature as well. Other than that, they're very similar databases.
I would add also, from my experience, is that in some developing countries or other settings, the cost is a problem. You know, I think yeah, toxins is, so first of all, with the Hinari database that she mentioned, did you mention that?
Yes, yes, a Hinari.
So that you can get access to it for free.
If you're on the developing country list.
Yeah, if you're on the specific list, low-income country, I think. And
unfortunately, Turkey is considered too rich to qualify.
Even if you are in the not eligible for the free, the cost, what is the cost for a subscription?
So in US dollars, it is $2,500 for a single user license for a year. So it's about 15,000 lira for one user for 12 months. So it's quite affordable.
Yeah.
Any other questions? Azura?
Yeah. So let's continue with Dr. Eva Karakilik. Curious about the answer.
Okay, thank you. Good morning, everybody. I'm Eva Karakilik. I'm from Turkey. I'm working in Eskişehir. Also, I'm an emergency physician and pharmaceutical toxicologist in Turkey. So, this is the different question. Does the emergency physician need to call poison control services? So we have a lot of poisoning patients in our department, intentional or unintentional. The percentage you can see, it is little size, but it's important for poisoned patient, because if you don't treat these patients, it can be mortal and it is not good for us. So we have to need good data, because we don't know everything about poisoned patients. When we are managing these patients, we have a lot of initial things, initial evaluation, stabilization, toxidromes, a lot of things we have to need, okay? When we are managing these patients, what is the diagnosis and what can we do treat these patients? So we need reliable reference sources. Okay, a lot of reliable reference source information about toxicology. So we can find everything in our department and we can ask somebody else, or we can call the poison control services. So textbook we can use, databases, applications, but the poison control centers, it is important for us. What is the telemedicine? The first time a grandma calls the doctor for their child. And the doctor holds the receiver close to the child's head to hear cawing. And then doctor says that the child did not have Krupp's cause, and the matter could be postponed till morning. This is the first telemedicine in the world. Yeah, this is the original paper in the Lancet. I wondered what is the first telemedicine in the world. That was good, and it is a good idea to write this conversation. It is another thing for me. For example, I can do this, but I couldn't. I want to write this. It is important. It is a good idea for this doctor. Okay, so we have complicated telemedicine now, poison control centers. These centers, special information set up, inform people about how to respond to potential poisoning and maintaining databases, poisoning and appropriate emergency treatment for healthcare providers. So these are reliable sources for us. It is important for us. Okay. Poison control centers provide direct services to the public and emergency healthcare professional and public health agencies. There are a lot of data, but I don't know how many people use the poison control centers. For example, in 2018, Poison Control Center says 2 billion people calls the poison control centers. So it is a huge number. It is important. For example, in USA, more call from public, but in the Turkey, not this not a I couldn't find a paper how many people, how many doctors calls the emergency poison control service, but more of them healthcare professionals. So PCC what is the poison control center's activities? What they do? So, first of all, they are gathering data regarding exposure and information about hazardous location and types of injury. The second activities is data collection. Reporting are the clinical activities, poison control centers. Another activities is poison control centers provide public education about poisoning and healthcare profession. For a healthcare professional, they can do educations because they have good information about your region and your country. Okay, so poison control centers working 7 days, 24 hours, and they gives information from pediatric exposure to the include adult exposure. So they gives me or they gives healthcare professionals guidance related to poison identifications, anticipated toxins effect, initial intervention, differential diagnosis and appropriate treatment, information about transferring high-level center, etc. A lot of things they can say to physician. Okay. So what kind of database they use? So first of all, they use a lot of things, micromedex, toxicology website, a lot of things they can use. But these database reliable for us. It is important, okay? Working a lot of persons, a lot of kind of persons, for example, specially trained nurses, pharmacists, physicians, and clinical toxicologists, for example. So they give a lot of information for us. Okay, poison control centers and emergency physicians, what kind of data use? In emergency physician, textbooks, database, websites, and our colleagues we can use how to manage our patients. So it is more important than the other. We, emergency physician have clinical experiences about poisoned patients. It is important. This is the different role for treatments. This is a question. Do the specialists in the poison control centers can be manage our poisoned patients? This is the important question for us. They don't see our patients. They don't close to our patients. So we say some things and they give information about the patients. So we can differentiate these conditions so we can do an important role in emergency departments. The role of poison control centers, what is the role, can we say? Maintaining and interpreting database for xenobiotics and reducing healthcare costs related to poisoning, especially information and advice to health professionals to improve their diagnosis and care of patients. Other role, collecting epidemiological data and incidence and severity of poisoning, integrating epidemiologic data as a part of the public health surveillance system, and educating and contributing science of toxicology. Poison control centers advanced database acts as a protective screen for poisoning outbreaks across your country, across your region. So methodologically searching and analyzing potential poisoning trends and ranging from contaminated peanut butter to biologic warfare. So at the end of this knowledge, we can say that poison control centers providing information and advice to the healthcare professionals to improve the diagnosis and care of patients who present to the healthcare. And it is important we can access reliable data in our departments. At the end of this presentation, so emergency physician need to call poison control centers. We can say that emergency physicians can be managed poisoned patients themselves. You can use your books, database application, etc. And they need reliable data about poisoning patients. And we have no more times for investigate all data. But we need to contribute data collection and data for education in toxicology. So, in my opinion, we have to need to call poison control centers. Perhaps not everything, but we can manage a lot of patients ourselves in emergency departments. but we have to need to call poison control centers for contributing data collection and for education in toxicology. Okay, thanks a lot. Thanks for your listening. Okay.
Yeah, please.
Thank you. I agree that, poison centers, calling the poison center helps with education as well as surveillance, but I disagree with you. I think when I work as a bedside consultant or at the poison center, I would say more frequently than not, I make a difference in the care of the patient, and the clinician who's calling me, I would say, needs what I have to say. You're right, not every case. If you have a simple case like somebody who overdoses on fluoxetine or a simple drug, but many times we diagnose serotonin syndrome, we diagnose neuroleptic malignant syndrome, we talk about the EKG changes with tricyclic antidepressants, triaging to telemetry versus regular bed, use of the antidote, stopping the antidote, the dose of the therapy. So I wouldn't say that, emergency physicians are able to manage all cases. I would say maybe, the simple cases. That's my opinion, at least, because I feel like I make a difference.
Okay.
Please.
I feel like they change their plan.
Okay.
Yep.
I completely agree with Dr. Ziad, although I come from a country where actually we don't have an active poison control, but I'm the clinical toxicologist in the service and I get called as a poison control for my own institutions. And for sure, we make huge difference. I mean, probably it's related to the setup of their poison control. I'm not sure how many toxicologist backup you have. Is it a specialist informations only, or you have a lot of toxicologists? Because the country setup also make difference, like whom you are staffing your poison control with and how many toxicologists they can access to if they needed to consult for specific patients. So that probably can make the difference. The other thing, yes, I know. And then the other thing I think, which Dr. Ziad already mentioned, is the cost effectiveness. And I think probably that's something that you can study in your own country. Like, what difference will it make in terms of length of admission, number of investigations, doses? Yes, so basically how many pitfalls happen, which actually already, like for me, I start observing it at my own setting, and I'm sure in US they already have published studies about the cost effectiveness of their poison control because they have plenty, they have many toxicologists. In your country, probably it's going to be something that you need to look at. Is it really worth it in terms of cost? And I'm sure you are going to have a difference.
Okay, thank you.
Please, please, yeah.
You made a controversial statement, now you're going to have it.
Yeah.
Thank you for your presentation. This is Yeşim Tunçok, and I also agree Ziad and other colleague about the poison control center consultation is really needed, and emergency medicine physician can take the responsibility of the patient, but with the poison center consultation, because the emergency room is very busy, crowded, and lots of patients are waiting for your care, and you have no time to explore all the things, and maybe you can miss something for the patient care. That's why poison control center is very important, and I think you require, you need to call poison control center. Another thing I would like to say, you are right, in United States, poison control center are called by the public health, but in Turkey, healthcare physicians, physicians are calling this center. You can find this type of evidence in our annual report. We have numbers about that. You said that you cannot find any evidence. But evidence is in our annual report. We have but I think it's old, but in 2007, we have an report, and in other a paper, we also gave the numbers of the PCC consultations by healthcare providers.
Okay,
Thank you.
Look at. Okay.
And I want to add something because I'm totally agree, and I think that you said a really important thing, because I think that the physician of the poison control center can totally share the responsibility of the patient, and I think it depends also on the education that emergency physicians receive on clinical toxicology. And I don't know in your country, but in Italy, it's not every emergency medicine physician receive an education on clinical toxicology.
Okay, it's important, yes, yeah.
Okay, please, yeah. Quickly.
So it just was interesting to see that more healthcare professionals are calling them members of the public. Do you have a sense of why that is? Is that because members of the public aren't aware that they can call, or they're using their phones to get the information, or are they just simply turning up to the hospital? And that's what, as poison control, we're trying to avoid. So have you got a good understanding as to why people don't phone from the public?
Yeah, it's a different way. In Turkey, you can easily can go to the hospital if you have a problem about everything. So it is important role for calling PCC. Because if some patients have a problem, they can go to the hospital easily, and they can access very short time to see the doctor. So it is I think it is the important role for calling PCC.
Okay.
We're kind of having a discussion. Is that okay? We have time.
Yeah. It's perfect.
So I want to ask, in Turkey, is there a medical legal burden? So do people make a lawsuit to the doctor if there was maybe a bad outcome or something? Do they sue? Do they sue doctors in Turkey or no? Was I clear? Like,
do you have?
Yeah, I think.
Okay.
I don't know if any legal things to call. You must call the poison center for this.
Do they get sued? Doctors here, do they get sued?
In general, yeah.
Okay.
No.
Yeah, in Italy,
many doctors will call the poison center and say on the chart, I called the poison center and they recommended. And I think Gaylord can comment on this.
Okay.
For me, and I appreciate your lecture, one of the key components for us is the use of our poison specialist, right? Yeah. And for us, it's a matter of training, because many of the cases that you're talking about in the hospital are only managed not by the doctors, but by the poison specialist. Mm-hmm. The most difficult cases, we consult with the doctors, mainly because of medical legal reasons. If it's really difficult, our poison specialists do consult the medical toxicologist. But I will tell you, in our area where we get 80,000 exposure calls per year, the poison specialist probably handles I would say over 97% of the calls. So a very small percentage are handled by emergency room physicians. Imagine the workload burden if they had to handle all these cases. So for us, it's a matter of training, and as you look at developing your systems here, whether you follow the Western model or not, we rely in the Western model on the nurses, pharmacists, and poison specialists to do the majority of the work. The more difficult cases go to a Dr. Kazi or Dr. Morgan or myself. So we're involved in very few cases. Yeah. The poison specialists take care of most of them.
Okay.
Thank you.
Now we pass to the next talk from Dr. Lopez from Georgia about occupational chemical exposure, the role of the Poison Control Center.
Welcome everyone to the last session of the day. Finally, we made it. So far, We are, I think, only running 10 minutes behind schedule. So without much ado, I'll start with the session. I'm Ashish Bhalla. I am Professor of Medicine at PGI Chandigarh, and I'll be moderating this session. The first speaker for the session is Dr. Paul Wax, and since he's been speaking since morning, this is probably his 6th lecture, so I don't think he needs any introduction. He is the Executive Director of ACMT and Professor of Toxicology, a teacher of teachers, and he's going to talk about his experience with environmental mercury poisoning. Over to Paul.
Greetings once again, and thank you for the very kind introduction. Dr. Kazi has had me talk on a number of different subjects over the conference, but they're all kind of passions of mine, and each topic is really a fascinating story. And I have a story to tell you in terms of this mercury toxicity, but just by a show of hands, how many have actually taken care of a patient with mercury toxicity? Has anyone had that experience? So a couple of the more senior folks have had that experience, and perhaps not as much among some of the junior folks. But you know, mercury is a heavy metal which is ubiquitous both in. Okay, thank you. So mercury is a heavy metal which is ubiquitous in society, and it accumulates both in the West as well as in the East. And I'm going to share an experience that I had with mercury poisoning where I practiced in Dallas, Texas at UT Southwestern. And it involved a mercury incident that involved a family and a school and the public health community. And the purpose of this talk is to kind of weave together both the clinical and the public health aspects of mercury poisoning case. So this involved a 14-year-old who presented to the emergency department with a fever for one day and a rash for a few hours, had a past medical history of asthma, and was given some ibuprofen, thought to have a viral syndrome, and sent home. And the following day, he returned back to the emergency department with a fever and ongoing rash, and he developed some other symptoms, dry cough, malaise, sore throat, and generalized headache. Again, very consistent with a viral syndrome. On physical exam, his blood pressure was perhaps a touch high for a 14-year-old, 125/74. He had some injective conjunctiva, erythema of his oral pharynx. His neck was supple. Chest exam, he had some coarse breath sounds. Neuro exam, there was no evidence of a tremor. He had a normal exam. But on the skin exam, he had this rash, this kind of erythematous confluent rash involving both his face and also his extremities. So at the same time that he came to the emergency department, his younger sibling, his sister, came as well. She was 9 and had relatively similar symptoms, fever, a rash, also had a history of asthma. You know, they'd both been in the emergency department on the first day, and they went home and weren't better, so they came back on the second day. And her exam was also consistent with just the rash, really no other positive physical finding. And here are some pictures of her rash on her trunk, and of interest, she did not really have much of a rash on the hand itself, but she did have some rash on the leg and the trunk. And as it turns out, the next day, the other sibling, the third sibling, in between, an 11-year-old, also came into the emergency department with similar symptoms: rash, fever, cough, and a physical exam, which was consistent with the other two presentations just discussed. So what diagnosis should be considered in children who present with a rash and a fever? Well, the topic is mercury poisoning, so clearly we're moving in that direction, but you don't really think too much about mercury when some child comes into the emergency department or into the office or the clinic with a fever and a rash. So this was certainly a very unusual presentation. So these are some of the entities you think about with fever and rash. Obviously, infectious etiologies, viral is most common, occasionally some bacterial, and some other less common presentations as well. All can cause fever and rash. But what tipped us off here, and this was not a challenge in terms of suspecting what might be the diagnosis. The challenge here was how to manage the case, as we'll discuss. But fortuitously, on the second visit to the emergency department, the 14-year-old brought in a bottle which was labeled as elemental mercury. So if we didn't have that information, I'm not sure whether we would have ever been consulted as a toxicologist. We were consulted to come down to the emergency department to see these patients. Once the emergency physician suspected it may or may not have something to do with this mercury. But as it turns out, the 14-year-old had been playing with this mercury at home. He found it along a railroad track, and when he came back the second time, he brought the bottle with him because he actually started reading on the internet. A curious kid, he started reading on the internet about mercury, and that could be potentially toxic. So he brought it into the emergency department. Of course, most emergency doctors don't see mercury poisoning very often. Very, very unusual. They're not sure whether this was consistent with the fever and the rash, and that's why they called the toxicologist, myself and my fellows, to come evaluate the patient. So what are some key components of an exposure history? And in this case, we wanted to figure out exactly what was going on. We wanted to establish the route of exposure. Would they have been exposed to a burden of mercury that was large enough to potentially cause some symptomatology, and also to start to investigate exactly who else might have been exposed to the mercury. So there were a lot of different factors here, and I have to say, having evaluated a number of mercury cases over the years, most of these cases I evaluate are patients that come in with high mercury levels. Someone's measured mercury in the urine or the blood, and the level is high, but they're not symptomatic. So in this case, we don't have a blood level or a urine level at this point. What we have is a bottle of mercury, and we have 3 children with a fever and a rash. So when you investigate what are the symptoms of elemental mercury poisoning, you can sometimes see a fever and a rash. As it turns out, the rash is often described as being on the palms and the soles. In this case, it was neither on the palms or soles. It was more on the trunk and the more proximal extremities. But still, it was kind of curious. All 3 kids were sick, and they definitely had been playing with this mercury. So in terms of the exposure history, we learned that the child found this mercury along a railroad track, which at the time I had a hard time piecing that together. But as it turns out, some of the switches that are used in a railroad have traditionally used mercury in some of the instrumentation. And so this was probably a bottle of discarded mercury that someone just kind of left along the railroad track, and the child picked it up and brought it home. Now, mercury, if you've ever seen elemental mercury or played with elemental mercury, which is not very advisable, is a very unusual substance. It's extraordinarily dense. It's about 3 times the specific gravity of water. So it's kind of fun to kind of play with just because it's so heavy. And in fact, this bottle, I showed the picture on a few slides before, was very, very heavy. And it kind of moves in funny ways. It's really different than most substances one encounters. So the kids were quite curious about it. What they did is they opened up the bottle, they took it out. In fact, one of the kids tried to light it on fire, which is the worst possible thing you'd want to do with mercury, as we'll talk about it in a minute. And as it turns out, although we did not know this on the initial evaluation, but on our subsequent evaluation with some further questions, we asked if they had brought this mercury anyplace. And in fact, they were so fascinated with the mercury that the child brought the mercury to the school, which led to all sorts of red flags. So what public health resources are available to aid in this investigation?
So typically, as clinicians, we usually deal with a patient, or occasionally there's a couple patients. Now, with an infectious disease, it's more likely that you'd have multiple people present with the same sort of presentation. With a chemical etiology, if there's a common source exposure, obviously it could affect multiple people. And in this case, playing with the mercury, there were the children, they were sick. We didn't have any levels, but we had some suspicion now that it may be due to mercury, and we wanted to investigate this further. And we were also concerned about who else might have been exposed to the mercury, because these kids didn't live by themselves. They lived with family. There were other family members. And also, if they had indeed brought the mercury to the school, and the child said that he had, could other children have been exposed to the mercury in the school? So there are a lot of different issues that came up. So through experience gained over a number of years, I learned about some of the public health resources that we could call into play here, because clearly this went beyond what we usually do in our clinical evaluation within a hospital setting. In the U.S., there is some public health infrastructure in place, although it's mainly designed for infectious disease outbreaks. And in fact, the health department that I worked with almost exclusively had been involved with infectious disease outbreaks in the past, and for them to start to investigate a chemical multi-source, multi-person exposure was definitely outside of their usual comfort zone. But nonetheless, this was potentially a public health problem, maybe even a public health emergency, and so it required some investigation. And I briefly mentioned at an earlier talk today that the CDC has this agency that works with them called the Agency for Toxic Substances and Disease Registry, and it was founded specifically to look into the public health aspects of toxic chemicals, and specifically some of these toxic chemical dumps, factories and other sorts of groups that have kind of dumped toxic chemicals into the land. We hope to, clean it up. The EPA is the regulatory agency that's involved with the cleanup, but from a public health concern, there wasn't any governmental entity responsible for that until the development of this ATSQR group. And so, knowing this group, I contacted them, and the first thing they did is contacted the EPA. So the EPA, Environmental Protective Agency, is a group that's typically responsible for chemical cleanups. At least they know what to do, and they use a series of contractors. And so these pictures you see on the screen is the EPA folks actually going out to the school, because the concern about the school being contaminated was quite worrisome, because potentially this could have affected many, many children. And there were 3 children that were sick that we actually admitted to the hospital because of our concern about their illness and the fact that it might be from the mercury, and if it was from the mercury, they might have needed some sort of treatment. And moreover, if they were exposed to the mercury in their home, maybe their home was contaminated with the mercury, and it would be a very unsafe environment for them to go back to their home. So there were multiple issues here. They weren't super sick. They had a fever, they had a rash, they had a little bit of a cough, but we decided to admit them to the hospital and do this further evaluation. So where and what environmental samplings should be measured, and what are the recommended actions levels for mercury in the residential setting? So as medical toxicologists and physicians, we're more accustomed to look at testing in blood or in urine, testing of chemicals or drugs or other sorts of chemical testing that we do as routine medical evaluations. But in this setting, we were also concerned about some sort of exposure, and the exposure might be in the air, and is the air contaminated with the mercury? And that's some of the issues that we were confronting, because in terms of the route of exposure, the children denied ingesting any of the mercury. And in fact, with elemental mercury, if you ingest it, you tend not to absorb it, and you tend not to get sick from ingesting elemental mercury. Now, that's not true with other forms of mercury, such as mercuric chloride or a salt of mercury. That can be very toxic and corrosive if it's ingested. But elemental mercury tends not to be absorbed through an intact GI tract, but it can be absorbed through inhalation, and mercury tends to be quite volatile. And in fact, if you heat up mercury, it tends to even be much more volatile. And that's why when I heard that the kid took a lighter to try to heat up the mercury, that's the worst possible thing. And one of the reasons we don't recommend cleaning up mercury with a vacuum cleaner is just because it may heat up the mercury and present more of a potential air burden of the mercury that might be absorbed. And so there are special devices that can actually measure mercury in the air. These are rather expensive devices, and many health authorities do not have access to these devices, unfortunately. But since I was able to contact the EPA, I knew that they had such a device, and they could take it out to the home, and that's the first place I wanted them to investigate to see whether there were high levels of mercury in the home. Because if there were, then there were other people at risk. The children were hospitalized, but how about the parents or other relatives that lived in this actually relatively small home? So one of the meters that we use is called the Jerome meter or the Lumex meter, and these are rather expensive devices. So they actually went out to the home. Now this was a rather poor family. They did not have a lot of money, and they didn't even live really in a regular house. They lived in the garage adjoining a house. And in modern day home construction, there's a lot of ventilation. There's plans for air moving into a home and air moving out of a home, and they're designed carefully to have air turnover within a home. But in this case, it wasn't even a home. It was just a garage meant for a car, but the family was actually living in this garage. And so the EPA went out to this home. You see the pictures there, and they sniffed, we call it a mercury sniffer. They sniffed for the mercury, and they found very elevated levels. I mean, above 50 micrograms per cubic meter, which is extraordinarily high. I mean, the recommended safe level is below 1 microgram per cubic meter. So this was like 50 times above the safe level. So thinking about these kids who were in the hospital now, we did not have a blood level or urine level back, but we had an exposure assessment suggesting that they'd been living in this home with very, very high levels of mercury, and that they probably had become poisoned because they had these symptoms, which, although weren't the typical textbook symptoms of mercury poisoning, were certainly consistent with elemental mercury poisoning. So what are recommended action levels for mercury in a school setting? So this brought up a number of other issues because according to the child, they brought the mercury to the school. So we had to have the EPA go out to the school, use the same meter to see if there was any evidence of any mercury that had been spilled. And indeed, there was evidence that mercury had been spilled in the school. The levels were elevated. They weren't nearly as elevated as they were in the home, but nonetheless, there should have been no mercury in the air in the school, and there was mercury in the air in the school. And so the range in terms of what's tolerated, what's acceptable for mercury in the school is different than mercury in the home. The reason being is in a home you might be there 24 hours a day or 16 hours a day, but in a school you're only there 6 hours or 7 or 8 hours a day. So in terms of what's an acceptable level, it's a little bit higher in a school than it is in a home. And it has ramifications because when you clean up the environment, you have to clean it up until you get below a certain level. And so these levels are used as thresholds in terms of the cleanup, and it differs between the school and the home. So what additional procedures need to be followed when the environmental mercury testing at the school came back elevated? Well, we needed to try to assess whether all these children in the school were exposed to the mercury or not. And one way to assess it might be to get blood levels or urine levels, but that tends to be quite invasive. And the level in the air in the school was elevated, but it was not nearly as high as it was in the home where these 3 kids lived. So we weren't, and there were no kids from the school other than these 3 kids that were ill. So we were certainly less concerned that they had a very elevated level of mercury, but we wanted to ascertain that it wasn't even above what was considered a safe threshold. So as a surrogate to evaluate whether they were exposed to the mercury, we decided to test their shoes. Not uncommonly, if someone walks through a contaminated area where they've spilled mercury, it may get onto their shoes. And if it gets onto their shoes, then they may track the mercury to wherever they go, like back to their home. And so worst case scenario was the several hundred kids who lived in this school were all contaminated with the mercury on their shoes, and they would have brought the mercury back to these 200 homes, and we would have really had a mass toxic exposure. And so what we did is we ended up testing the mercury in the shoes. And you can see in these pictures that there are some plastic bags. And what we recommended was all the children to bring their shoes into the school, and then we put them in the plastic bags. And the plastic bags were left on the field for several hours, and it was a warm day, so it could heat up whatever might be in the bag that had clung to the shoe. So if there indeed had been mercury that had attached to the shoe, and then we heated it up in the bag, and then you use the environmental meter to assess the mercury. If it's elevated, then that would certainly be a concern. So they tested several hundred shoes, and fortunately only 2 of the shoes were elevated. But those 2 shoes that were elevated, they then had to go out to those homes, or those children that had shoes that had been contaminated with the mercury, just to make sure that those homes were safe. And they went out to the homes, and in neither home was there any sort of consequential mercury level. So that was the result of the shoe testing. Now, how do we manage this public health problem? Because typically when you're dealing with one patient or maybe 2 patients, the doctor and the patients have this relationship, and it's confined to the doctor and the patients, and we make sure that communication is compliant with typical doctor-patient relationships. But now there was this concern about all these people that were being exposed, and we were asking children to bring their shoes into the school to be tested, and certainly a lot of parents might be concerned, and the teachers might be concerned as well. So the communication here is critically important. So we called for a public meeting. And a public meeting basically is a meeting that you invite various groups that have some sort of stake in the issue, and you be very transparent, and you discuss the problem with them. And that's exactly what we did. We called for a meeting in the evening. It was just a couple days after this initial event. We invited the parents and the teachers to come to the meeting, and then both the physicians, including myself and some of my EPA colleagues and school officials, then addressed the parents to try to alleviate their concerns. I mean, there were parents who were pregnant and had other sick children at home, and a lot of worried issues about this mercury. And so fortunately, we were I think satisfactory in alleviating their concerns. And we told them that, yes, we found a little bit of mercury in the school, but the levels were relatively low. We tested the shoes, in only 2 cases were the shoes elevated. So for all these other people, we tried to alleviate their concerns and tell them that there really wasn't anything to worry about, but also we were available for questions and further concerns. And
Paul, you have just 1 minute.
Anything off.
You have just last minute.
Yep. So in the end, because this was part of a much longer presentation. So the levels in the kids came back elevated. And as you can see on this slide, the blood level and the urine levels were in the hundreds. And typically what is a normal level is below 1. So in the end, these children were significantly exposed to mercury. They became poisoned with the mercury. They had symptoms consistent with the mercury poisoning, and we treated them with chelation, and they gradually got better and left the hospital. But we all learned a tremendous amount about this sort of presentation, because not only did it involve the children themselves, but it involved all the public health implications of such a mercury exposure. And I'll end it on that note.
Thank you, Paul, for I'm sorry, it was very interesting, but since we're running
yes,
short on time, so
okay,
I thought
I'll be available for questions later on.
any
questions.
one question? So if I'm allowed one, if nobody else is asking, how did you actually end up treating these?
Yeah, so we treated them with Kemet, which is DMSA, which is traditionally used for lead poisoning. There's not a ton of literature about the use of it in mercury, but there's some scattered literature about it. It's a relatively safe chelator. It's administered orally. We also added on N-acetylcysteine. There was some literature to suggest that N-acetylcysteine may also be beneficial. So while they were in the hospital, they got IV N-acetylcysteine, and we started the oral DMSA, and then they went home still on the DMSA for several weeks, and then we would follow their levels, and their levels started sky high. So after their first round of treatment, we would retest them, and the levels remained high, and we gave them, I think, about 3 rounds of treatment over the course of several months, and we followed them very closely in the clinic, and ultimately they all got better and didn't have any residual symptoms.
I think that was a wonderful, wonderful talk. Let's give him a big round of applause. It's difficult to diagnose and difficult to treat cases in the absence of any definitive levels when you have so many patients. Now for the next talk, let me invite Dr. Charles McKay. He's been here. He is the immediate past president of ACMT and is still the associate director of the Poison Control Center at Connecticut. And he's going to talk about arsenic poisoning. Chuck, you have 20 minutes, so over to you. Yeah.
I'll use that extra 2 that's
Sure.
sitting on the screen there.
Yeah.
All right. So I have another story to tell you, sort of like Paul did. I wanted to take you through a little description of how we go from something like this, which is a form of mercury in the environment, arsenic in the environment, cover the mercury already, and how we go to a symptomatic individual. And the central diagram here is really the interplay of both the hazard, the substance that we're concerned about, and the patient, and the role that environment, or in this case the route of exposure, the setting of exposure, that kind of thing plays. And the importance of this is that it goes past, just these somewhat esoteric metals that we're talking about. This is really something that has an interplay for every patient we see where we are considering a toxicology diagnosis. Also, I'd just mention, since we're going to be kind of pushing through these cases fairly quickly, there was a symposium that we held down with the CDC in 2013 on chelation issues related to heavy metals, because in the United States, this has become a very significant issue with a lot of practitioners preying on the fear of the public regarding chemical exposure and using laboratory testing inappropriately to kind of support treatment that is not indicated for diseases the patient doesn't have. So much as with mercury, arsenic poisoning is a fairly uncommon event, but the diagnosis or misdiagnosis is actually fairly common in certain practices. Actually, the first patient I was consulted on as a medical toxicologist was an arsenic poisoned patient. I'll mention some of those features while we're going through this. And I think we'll go through this. Okay, so what I'd like to, at the end of this, is to have you guys be familiar or comfortable with the idea that you're going from the existence of a substance that could be a hazard, a substance itself is a hazard or not, depending on the characteristics of the substance, to a risk to whether the person may or may not be injured by this hazard. And the importance of dose, route, and timing, which is the kind of the tenets of medical toxicology, and then a difference between individual health risk and a public health concern, because with all of the environmental issues that we're talking about, that becomes the real crux of the communication that then needs to happen with the public or with responsible officials if that's the venue you're working in. So arsenic it's an element. It's found in ores. It contaminates a large number of ores. Those that contain iron often contain a fair amount of arsenic as well. When it's more present as just the sulfide, it has these pretty crystalline shapes to it. But but it is not present in nature as a pure substance. It's extracted from these ores and then used for a variety of different things. And these are just some of the lists of over the years, the centuries really, where arsenic has been used. So it's been used as a medicinal. It kills organisms. It's been used both to treat skin conditions, so topically. It's been used as a cosmetic, not necessarily for good reasons. It's been used intravenously, and you think about old uses where it was a treatment for syphilis back 100 years ago, but now it's also being used in pediatric facilities predominantly for the treatment of promyelocytic leukemia. So arsenic trioxide, the same form of arsenic that is the most dangerous in terms of its environmental exposure, is also used intentionally, therapeutically, to treat children with a leukemia. It is also present, since it's leached out of those sources in the ores into water. It's present in groundwater, and it is then taken from wherever that water source is on out to the sea, and you end up with contamination or incorporation into organisms and therefore seafood as well. Arsenic is not just it doesn't just stay inorganic. However, it's incorporated into organic compounds such as arsenal sugars or arsenobetane, which is one common form that's present with seafood. And those two forms, in contrast to, say, with mercury, where organic mercury is a very, very, very potent toxin, are fairly non-toxic. So organic arsenic, in contrast to organic mercury, is fairly non-toxic. It's used in industrial purposes for a number of different reasons, and because of its toxicity, it's also used to kill things. So it's used as a rodenticide, it's used as for homicide. This was the inheritance powder from the Medici families and others, where that would be used as a way of ensuring that you got your parents' stuff because you killed them and you were the only one left. So these are just a few uses. Some of these solutions were used. Fowler solution was used right up and through the 1960s, I think, over about a period of 200 years. The pigment, the Paris green, was actually used as a rodenticide in the Paris sewers, but it was also used as a pigment in wallpaper back in the mid-1800s, and would leach out of that, and actually because of the process of both the moisture and the mold growth, as well as heating the area with flames, fire, they would convert that into a gaseous form of arsenic called arsine, which is also used in industry currently, causes a completely different set of symptoms, but all of these are forms of arsenic that were very commonly present in the environment over a period of time. So we have a number of mass poisonings that occurred over the years. Some of these are back in the mid-1800s, but if you look at this adulterated donuts in the 1980s, this was actually an individual who has a fairly extensive history in the medical toxicology area, which is Michael Swango, who's a physician who felt that he really needed to poison people, felt that that was what his skill set should be used for, and killed a number of people. Was convicted of killing 4, but is thought to have killed scores of people in Zimbabwe, as well as a number of people in the U.S. When he was in Illinois waiting for his licensure during a period of time when he'd already been convicted of or sent away from some other facilities where he was thought to have had a role in patient deaths, used arsenic to poison his fellow paramedics, and that's where that issue came up. In Maine, just a few years ago, we were peripherally involved. It's a state near where I practice, where a custodian of a church had poisoned the communal coffee urn in New Sweden, Maine, and killed a couple of individuals, sickened about half a dozen of his fellow churchgoers. This was a very, very small town, and as you might imagine, this fellow who was found criminally responsible committed suicide shortly after being arrested, but tended to implicate in a letter that he wrote some other unnamed individual, and that's completely changed the whole manner of living in this small town, and people are still to this day, you know, uncertain and fearful of their neighbors, and they lock their doors, and they never used to do it, that kind of thing. So arsenic has a long history, and the question is, how would you ever recognize it? And the clinical presentation of arsenic poisoning is very much different whether people are getting a large dose, a small dose repetitively, or even lower dose over a long period of time. So clinical acute arsenic poisoning would be only present from what would be called high-dose arsenic exposure. But high dose, we're talking about a couple hundred milligrams. So this is a fraction of a sugar packet, for example, of arsenic would be enough to cause this spectrum of toxicity. And usually very early onset of very, very bad GI symptoms with very prominent diarrhea and dehydration in that setting. You can end up with other organ systems affected as noted there, but those tend to be fairly significant doses. It's much more common for people to have what's called a subacute arsenic toxicity, and this would be often following a attempt at murder, where people will show up having reported an acute GI illness a couple of weeks earlier, and now complaining of some numbness and tingling, kind of a stocking glove paresthesia, as well as just noting that their hair was falling out, funny looking lines on their nails, although not pathognomonic for arsenic poisoning, can occur with selenium and with thallium and a few other things, but you'll notice these transverse white lines, picture in the next slide coming up, and those tend to be a little bit more delayed. And so people have a GI symptom as a prodrome followed by a neurologic and hair, nail kind of group of symptoms. And if you hear that, that should really raise in your mind the possibility of a heavy metal poisoning. In this case, arsenic or antimony would be suspects, but you will be hearing just shortly about yet another metal where that it can be the presentation as well. And a lot of dermatologic changes that occur with this as well. So here, although it's not a clinical finding, once you start looking at their blood smear, for example, you'll notice that there's some fragmentation of the nucleus within the white cells, which suggests a part of the problem that this element can cause. You also notice these Mies or transverse white lines that are across the nails, and that'll actually be useful to date the period of time of exposure, because the nails grow about a millimeter a week, and so you can kind of date from the time that they clear the perinacial fold when the exposure might have occurred. And this is actually the first patient that I was consulted on, was somebody who was referred up for an oncology evaluation because of the abnormal white blood cells that had been observed, and they thought the person had leukemia. They did a bone marrow evaluation, which was actually normal in terms of any leukemia, but they had these Mies lines present, and they sent off an arsenic measurement in the urine. It came back in the thousands of micrograms per liter, where it normally should be maybe 20 or 50, and we were consulted on that patient. A much more problematic issue for large swaths of the population, though, is chronic arsenic poisoning, and this is a real problem because it causes an increased risk for a lot of chronic health conditions, diabetes, cardiovascular disease, as well as a number of cancers, both lung, liver, bladder, and skin cancers, where these hyperkeratotic pigmentation will progress on towards a squamous cell cancer. And this is an issue that is affecting, more than 40 million people in East India and Bangladesh at this point. Talk about that in just a minute. And not going to get into it here, but the idea is that the trivalent arsenic, which is this arsenic trioxide, for example, form, has an effect on potentially a couple hundred enzymes are inhibited or altered in their function by exposure to arsenic. Pentavalent arsenic, which is what's commonly present in foods that are grown in soil that has a heavy arsenic contamination, will not be as toxic, but in the body it can be converted to trivalent arsenic and therefore presents a potential risk for further toxicity. I mentioned that the issue is most prominent here in this area of the world, and perhaps Ashish could even mention a little about this a little bit later. But this is a real concern with millions of people who are exposed in what was initially a public health attempt to decrease acute disease. By the drilling of tube wells, they go down deep, sample from the aquifers. The aquifers unfortunately contaminated with arsenic as they leached out of the normal and natural occurring ores there. But in trying to avoid a parasitic disease, now millions of people are confronted with this issue relating to arsenic. And I'm not sure you can read it up here, but this map shows you the likelihood of having an arsenic level above, and the units translate to 50 micrograms per liter. And as you can see, most of those areas are actually likely to have a greater than 50 micrograms per liter. And that contrasts with the United States' current level for EPA for drinking water, which is 10 micrograms per liter. So, it is several fold higher than that. And the highest concentrations are actually up in the 2,000 micrograms per liter, a couple as high as, say, 3,000. So these are very, very large concentrations of arsenic. It isn't only in that area of the world, though. This is a picture of the northeast United States. Actually, I live right there. And this is the state of Maine. And large areas of the water sources off of the mountains in these areas have also what is considered high, by U.S. standards, arsenic levels. But again, these are now 5 microgram per liter, so completely different scale than what we're used to. But we do see arsenic poisoning in the United States, and this is a woman who one of my fellows saw when he was practicing up in Maine, who had noticed that she was getting more and more freckled, as she thought it was, although it was an itchy rash that she was having on her legs and the soles as well. And she was complaining of increasing numbness. This was increasing over a period of about 10 years. And it was attributed to the fact that they were using a private well, which is not regulated in our country. You're responsible for your own water condition there if you have a private well. And they didn't really stumble on this as a concern until a neighbor dug a well and had it tested and found that it had 2,500 micrograms per liter of arsenic, and this is the same water that the neighbors had been drinking for 17 years. So they needed to get a new water system in place. So real arsenic poisoning, this is what's being experienced in Bangladesh and East Bengal. If you think about it, people are consuming large quantities of water with very contaminated sources, and they are ending up with this chronic health issues. In the United States, and this is kind of to focus on the public health aspect of this, when we went from 50 parts per billion to 10 parts per billion, suddenly a whole large numbers of water systems were out of compliance. And this is one, Exeter, New Hampshire, which on that map is just a little bit west of where I was showing you. They found some measurements that were 11. 11's higher than 10. It was less than 50. It wasn't a problem. And suddenly now they're in violation, and these whole communities have to put in very expensive systems to try and filter the water. It's gone on further, and from our point of view, they're maybe going a little too far. This is copper chromate arsenic treated wood, which is a preservative, is used in a large number of building issues for playscapes and decks, put outside the back of your house, that kind of thing. And now the concern is that this is going to leach into the soil, or people might get exposed if the kids are playing on the playscape for too long. Large number of studies coming out about the degree of contamination that's causing. And what it basically led to was the EPA saying that no more can you use CCA-treated wood, and everybody should take it apart and demolish everything that they've used. Don't burn it, because actually that is a good way of getting very exposed. But the data that they were using for that was along the lines of if you were 3 years old all your life and ate a sandwich on the deck every day of your life and then had a lot of hand-to-mouth behavior, you might get too much arsenic to be safe. Now, first off, you can't be 3 your whole life, and even if you were, you might vary your diet from a sandwich, and you don't have to eat on your deck every day. But that's the kind of thought process that went into some of our safety regulations. So there's a lot of data that we're not going to take time to go through here, but I'd be happy to point you to some of those. Some of the epidemiology studies that started talking about the risk for a lot of chronic health effects that drove now our safe level were based on statistically significant changes, but they were using the population in Bangladesh, where the concentrations of arsenic in the water were orders of magnitude above most of what we were having to deal with in the United States anyways, and also above where their safe levels are now. And then there were some bad studies that are out there, which is always something I want you to remember to pay attention to when you're trying to look at the literature. This was just a study where they took people who had diabetes and then measured arsenic in their urine, and there was an association with diabetes. But if you think about it, if you have diabetes and you're not in great control, you're having an osmotic diuresis, and therefore you're drinking more water. So if you have arsenic in your water and you drink more water, you're going to have higher arsenic levels. So it's reverse causation. The arsenic comes because you have diabetes, not causing your diabetes.
Last 10 seconds.
So laboratory diagnosis, we use urine as the method. Nails and hair can be done if you're doing a forensic investigation for potential criminal activity. Treatment is really supportive care, getting people out of the situation where they're continuing to be exposed. And if you have acute toxicity, as Paul was mentioning, for mercury, for elemental mercury, we do have chelators that will work. DMPS has been used and was used in that main case. Succimer or DMSA is our ready go-to, and BAL or British anti-leucite is the older agent. And I'll just leave you with this, these are just some things to keep in mind when you're going through the literature. Be careful about people who extrapolate from cell culture data to humans without really taking care with the steps in between. We have to be careful when we're using regulatory language because, and this could go either way, if you say, well, it's safe for somebody working in that environment, but now you're applying it to an infant who's in that environment 24 hours a day, kind of like the difference between the mercury levels of home versus school. You want to be careful you don't misapply a regulatory framework to an individual exposure. And you can't extrapolate from low-level to high-level exposure just because you're ignoring a lot of reparative mechanisms as well as differences between experimental animals and humans. This has continued to be an issue. We have TV people who provide advice that people like to follow. I don't know if you catch our shows or if you have a similar issue here, but one of our guys is Dr. Oz, who's out there. And now, although he was a cardiac surgeon, he now is a toxicologist and a laboratorian. This talks about him running tests on apple juice, looking at contamination with arsenic. And actually, he's never been in a lab, so it was other people that ran the tests. But the things you need to remember is, is this a setting that's got any similarity to the concern? So they were applying the levels found in juice to water consumption, and we never could suggest that people drink a liter or two of juice a day. Water is got multiple safety factors on its regulatory limit, and it's inorganic arsenic, not organic arsenic. So I mentioned the organic arsenic issue, and those are things to keep in mind because if you take somebody and you measure their urine and they have been eating seafood or shellfish, they will have high arsenic measurements, but it's almost all organic arsenic, which is non-toxic. So you have to speciate the arsenic, which is a completely different test. It means running it through a liquid chromatograph and an ICP-MS, which is a difficult set of tests to perform. So we want you to just take away that it is possible. If you have a private well, it should always be checked for a number of different substances. If you have a very high measurement, then it should be mediated or remediated. If it's just above a regulatory limit slightly, probably doesn't mean anything for your individual health. There's a lot of different sources of exposure to arsenic, including smoking. And try to not take all the media reports as verbatim. And I'll leave it with that. Thank you.
Thank you. Chuck, you took 3 minutes extra, but then it was very interesting to listen to you. Since we are running short of time, so I won't allow any questions for this talk because I want to listen to the next speaker, who is Dr. Abdul Qadir. He's professor and head of emergency medicine at Kansas Technical University, and he's an expert on mad honey poisoning. So who best to talk to you about mad honey than the expert himself?
Well, I'm not sure what I am doing in the poison control track, but I think it's related to public health somehow. And you must be wondering what is my topic is about. So let's start. So my name is Dr. Saad Labri. I'm actually a clinical toxicologist and an emergency physician consultant at Sultan Qaboos University Hospital in Oman. And I hope you know where my country is. It's nearby you. It is a beautiful country. So what I'm going to be talking about, you must be wondering, is it going to be about your cup of coffee that you take in the morning? Extra cup of coffee, extra caffeine? No, I'm not going to be talking about that. So I'm going to start with 2 cases which actually I had during my clinical practice, and as a toxicologist, I was involved somehow. So the first case is a 27-year-old man who was previously well, healthy, was brought in cardiac arrest, and the only positive history, he's working in a gym, and he started using supplements just 6 months back. The second case is a 29-year-old male who is a bodybuilder, came with a shortness of breath. He had been diagnosed recently to have cardiomyopathy with ejection fraction of around 20%, and he was on anti-failure medication. And he was not looking well, basically. So what is common factors between two cases? So they were both young. They are previously healthy. They are taking some sort of supplements. And one more thing, apart from the fact both of them had very bad outcome, they were looking like this. Actually very huge and muscular. So the outline of my talk is going to be about what is actually performance-enhancing drugs, what is the epidemiology all over, and what is the common misperception about them, what is the reported cardiotoxicity, and at the end, summary. And I think the right side of the screen can tell you about the whole topic. So actually, the performance-enhancing are pharmacologically produced agents. They are not supplements. They are not nutrient. They are not natural by any way, despite what the manufacturers and the company says. And the common use for them are by athletes and non-athletes, weightlifters, to enhance a performance. And that's even a misperception. Why then we should be concerned if it is an athletes or sport-related thing? Unfortunately, it's not. Well, to start with, it started with athletes, but because of the common belief, they can actually give an enhanced performance in terms of gaining more muscles, becoming more strong in weightlifting. People start using them in the public, specifically the young age group. And there have been a lot of fight initially by the ethicists, like, why not? Isn't it like we are supposed to go for physical excellence, and the more good we look, it's actually the better? But unfortunately, it's not true. So actually in US, at least 3 million performance-enhancing drug users alone, and this is just based on one studies, and it ranks on top of type 1 diabetes and HIV infection prevalence, which is really serious, which make it #1 health threat. Specifically, across all the studies that reported it, it's a very common thing in young age group. It's between 22 to 24. So the young generation are the most commonly using these drugs. And I actually have abstracts in this conference about just a pilot study that we did in the country, and it was randomly selected 120 gym only in the capital itself. It's not even all the country, which is I'm planning to do next. And the age group, almost 64% were also young age group, 80 to 40. 75% of these people are actually using supplement. And they are gym members. And again, reminding you, they're not athletes. They are actually regular people who are going to the gym. And unfortunately, 53%, they don't even know any side effects. So lack of awareness completely about side effects. And they don't even have a proper trainer or proper medical checkup, which was really shocking. So what is the misperception then? Why the young age group go for these supplements? They don't know what they are. They're just using them. Actually, it's because of the media influence. So a lot of them, they just get the peer effect, the pressure effect. Okay, I want to look better. I want to have more muscular, and what is actually the best and fast way of doing it. And unfortunately, the media is not helping, because previously, the attention used to be regarding the athletes that use it just to gain competitions, and then a lot of illegal action have been done for these sport people, but then no real educations or awareness or even banning or bringing to the attention about the health risks. So most of what happened is, okay, so this sport competitor was actually rewarded because he was using illegal supplements, but nothing really beyond that. So public attention is not there. And the vast majority now, it's not athletes, are actually the normal public. They are the normal people who are going to the gym. And it is greatly underperceived. And it's not even performance enhancing anymore. Actually, now the terminology itself is changing. It's either a body image enhancing drugs or appearance enhancing drugs. They are not performance. Actually, most of the people that use them now, they are not behind performance. They are more behind looking more muscular and lean. And then there are lots of kind of reports coming out of a very famous bodybuilders who are having actually stunning, shocking death at the young age group. And despite that, still the problem continue. And this is one of the very common famous case that went to the court in US that have DMAA, which is dithylamylene, which is one of the stimulants, and unfortunately the disease was a soldier man who ended up having lawsuits by his family against the GNC websites, which is actually was really kind of advertising this product very heavily as an ultra-intense muscle gorging strength, energy power, and endurance. And now it became a banned product after a lot of deaths, including acute MI and sudden cardiac arrest. But it used to be really publicly used by the bodybuilders. So what are the cardiovascular effects that have been reported with these performance enhancers? So cardiomyopathy, myocardial infarction, you just name it, cardiovascular accidents, conduction abnormality, coagulation abnormality, and then each one of these compounds have its own kind of risk factors, because when we say body enhanced drugs or these supplements come in different shape and format and compositions. They are not only one type. If you can see, there are multiple. So you have oxygen carrying modulators that have erythropoietin, and then you have the anabolic agents. You have also adrenergic receptors antagonists, and you have also the receptor modulators. So it comes in multiple things. And the cardiovascular risks that are reported here are mainly the direct cardiovascular risk. There are also other indirect cardiovascular risks. And if you can see, the majority of these reports come from the anabolic agents or androgenous anabolic steroids. So we'll move on to the anabolic steroids, since they are the commonly reported cardiotoxicity literature actually come from those agents. And the mortality among athletes using these supplements is almost 6 to 20 folds more than the clean athletes. This is only athletes report. And 1/3, again, as I mentioned before, one third of these deaths are actually related to cardiovascular. So what is the direct? As you see in the previous slides, it's either dyslipidemia, so they can have decreased HDL, increased LDL, and then this is more pronounced if they are having oral intake of these anabolic steroids. You know that they come in injectable format, and unfortunately in my study it was very hard for us to get this information out because injectable anabolic steroids are illegal there. So it's kind of going to be very hard to convince people to disclose this information for even a study purpose. But I know it exists, and I know people actually getting it illegally from other sources. And the other sad part of this story, actually, performance-enhancing drugs, and this also reported in the literature, it's the door to start using even other illicit drugs. So usually it starts with supplements, and then they move on to any other kind of drugs. And in my country, I actually noticed this in my clinical practice, like most of the drug abusers actually are commonly going to the gym and getting their drugs even from the gym. I'm not saying you guys don't go to the gym, but it's a common factor. So what is the evidence also existing for their cardiovascular toxicity? You have also postpartum. Most of the evidence existing are by case report and case series. As everything in toxicology, it's very hard to have ethically approved study to compare the effect between these supplements. But then postmortem and experimental, there are actually recent conduction studies that showed decreased cardiac electrical stability, autonomic cardiac regulation is also affected. You have abnormal ventricular reboalization, and as a result, you definitely have more risk of arrhythmia. And this specific finding was also tested in rats, and it was proven to be also correct. There was also other study looking at 87 diseased men, and which were tested positive for anabolic steroids, and what they found, they had great cardiac mass comparing to other kind of men if they adjusted all other factors. And also there is ventricular hypertrophy, fibrosis, and myocyte lysis in cardiac death in anabolic steroids. What about radiological studies? So this is in living people who are actually using anabolic steroids compared to those non-users. There is definitely decreased ventricular ejection fractions, reduced diastolic tissue velocities, and one study is demonstrated specifically decreased aortic elasticity, and I'm going to discuss this later on. Again, there is also coronary artery calcium scores higher based on the also radiological studies compared to men at a comparable age, which again put them at risk of atherosclerosis and MIs compared to normal populations. What about human growth factors? Isn't it that if you grow better, bigger, it's going to be better? I don't think so. So it's actually little known specifically about the cardiovascular effects, but if you see the acromegaly patients who have actually excess, like if you just extrapolate the results of acromegaly patients, they have hypertension, congestive cardiac failure, and cardiomyopathy. So you can guess if they have excess growth hormone, definitely risk of cardiovascular is there. Beta-alanine supplements is one of the commonly used now between athletes and non-athletes due to the illegality of anabolic steroids. Actually, it's found in 60% of sport codes because now it's self-reported because it's actually not a banned product. And what do we know about the supplement itself? Is it really toxic? Studies of adverse effects itself is not really there because we need time in order to see the long-term health effects with these supplements, but neurotoxicity, respiratory distress, myotonia is all seen in humans who have excess beta-alanine in metabolic cases specifically. So again, if you extrapolate the results, you could expect some effect to be there. And this is also one study done in Tour de France cyclist events, which is a common cyclist event done. Actually, the first cardiac death happened in this event. It was back in the 1960s, but this study specifically checked between 2 years, like 1995, the blue one, and then 1999, and they were checking their ejection fraction and cardiac mass by echo, and they noted like their heart is becoming bigger as the year go, and they're actually their function or ejection fraction is becoming less. And at this specific year, the use of performance-enhancing supplement was becoming very popular. So that's one thing to be put in mind. Animal studies also have demonstrated some bad effects of clenbuterol. So there was increased atrial and ventricular size and increased aortic root again, and kind of a decrease in the elasticity, and they notice actually sudden death in horses. So this is experimental study done in horses, and the poor horses end up dying from aortic rupture. There are other modulators or androgen receptor modulator, and the reason why these substances came in because androgen steroids were becoming illegal, so they were trying to bypass detection, so they brought these receptor modulator. Common example is thiomycin beta 4, and they dissociate the androgen and anabolic effects, making them undetectable. Still, very little is known about their cardiovascular risk, but if you just think about it, if they are going to be acting on the same receptors, probably effect is going to be there. We just need to wait and see the effect. And the end results for some of these people, so if they did not die, some of them, they may end up having really very bad cardiomyopathy. And the example is the patient I saw. He was huge, young, but cannot even walk without assistance. He will probably need eventually a heart transplant. His heart is big and not working well. And some of these people walk around with their external ventricular device, assessing them in their daily lives. So in summary, it's actually a very common use in young, and this is even in my country, leave alone other countries, and even in US it have been reported. There are many types, and unfortunately the young generation, they don't even know what they are using. They just want the quickest way to look fit, big, and lean, regardless of what will happen next. And this is really striking and frightening. And there is no awareness of adverse effects. And there is no even increase kind of public educations regarding this, because it's having lots of opposite action from the companies who are making them. Actually, what I came to know, that trainers in the gym, they get some sort of commission and advantage the more they sell these products. So it's a kind of a revenue and big business. So it's going to be hard to actually oppose business. And lack of regulation and proper control. A lot of these are regulated in the sport activity scenes, but in public there is no proper actually control. People can access whatever they want, and there is no shop, no place now where they don't have the supplements displayed there without a proper warning. And definitely cardiac toxicity does exist, including sudden death or long-term cardiac diseases. That's all about my presentation. These are my list of references, and keep calm and call toxicologists. Thank you.
Thank you. We have time for 2 questions, I think.
Any questions? Yes.
Please.
Yes. That's striking?
Maybe not. Supplements, is it like multivitamins? Is it on?
So supplements, no, so supplements, what we specifically meant, supplements in the gym. So it's not, they were not talking about vitamins. And even majority of them, they don't even know. They are just buying supplements to enhance their performance and gaining more muscles, but they have no idea what supplements they use. Some of them, they were actually not kind of keen to give us the informations because they were afraid that some illegal actions will be taken about. But I knew, like from my own sources in the gym, they are injectable, like some of these supplements come injectable, and most probably they are steroids.
Is it the time now that there should be some regulations for any gym to be open?
Absolutely.
To have a specific recommendation to be assigned to a physician, a doctor, and maybe not to leave it like this?
Absolutely, and this is what I'm trying to do, because the first thing, you need to prove that problem exists, and you have to submit the data. So what I did only a pilot study in Muscat. Now I'm planning to extend my study to include all the country and just to screen what's going on there. And I'm trying to get more information to actually submit it. Huh? Oh, great. And the thing is, the problem is, what I noticed, lots of opposition from the gym themselves to participate in the studies, because again, it's a money-making revenue for them. Like the more they provide supplements, the more they get money, and they try to convince people who are there to actually, and you know what's striking, which I did not mention, many of these actually users are undergrad. They're too young even to be knowledgeable to know or decide. They're undergrad. They are not even like, they just either finished their secondary school, they're just in college, so they don't even have the full potential to understand the consequences. They just want to look good, no matter how they will end up.
I have one question. In your country, is it easy to buy on internet, or there is?
Yeah, this is another thing which in US probably it's very easy to get things through the internet.
Yeah.
Well, we don't need to bring it through the internet.
Exactly.
A lot of people smuggle things through the borders, and it can get access easily. So they don't need to order it through the internet, so they can get it delivered to them in the gym. And as a toxicologist, I'm telling you, most of what I see as overdoses cases, when I ask them where are the sources you get your drugs, it's the gym. Like they have a connection, they can get things easily.
It's the same in Italy.
Yeah.
Okay, thank you.
It's easy. There are a lot of shopping centers.
Yeah. Vitamin shop called.
Like there are so many gym there, but probably only 2 are certified for selling specific products. The rest are just on their own, unfortunately. Yes.
Please.
So I'm curious, with these drug users, are they doing injections?
Yeah, this is what I try to get. So even when we went to the questions, is it orally or injectable? Nobody want to answer the injectable ones, because the moment you say injectable, it's actually most probably anabolic steroids. So I had hard time getting any of these answers, but they were answering we were taking supplements. So I have to go again and review my data with the members who were with me, and then actually when they question, without them, they said, we are not gonna write, we are taking injections, because they are so scared to actually declare this information.
So my question for injection drug users, does Oman have resources for harm reduction to prevent transmission of diseases?
Actually, illegal. So injectable supplements are illegal in the country. They are not supposed to come there. But again, we are talking about getting it in a legal way, and still they are using it the way they use IV drug. It's illegal. I mean, IV drug abusers, they use IV, right? It's illegal, but still people can get access to.
Sure,
so you are talking about infection risk the same way that it's existing. But how to monitor it, how to report it, that's the challenge.
Understood. But are there practices in Oman to provide people clean needles and teach them how to prevent?
Oh, no, they are so meticulous now about actually getting their own needles for injections. So risk of infection probably is less. So they get a one-time loaded syringe, I guess.
Thank you.
Thank you.
So thank you. I think we can go to the coffee break.
Okay, thank you.
Thank you. Thank you, all the speakers.
Audience to join us. So we're going to start this afternoon session on clinical research in emergency medicine. Our first speaker is a regular Menatox presenter and well-loved. Dr. Lisa Marina Walton is a professor of EM at Louisiana State University, president of the American Academy of Emergency Medicine. Besides having an MD, she also has a master's in clinical research. Lisa has numerous research grants, over 350 national and international research presentations, and now she's going to speak to us about emergency medicine research.
Thank you.
Okay, I don't have a microphone, but I don't think you'll have trouble hearing me. It's kind of a small room, and I've got a big mouth from the South Bronx. So I'm going to talk to you a little bit about how to conduct research in the emergency department with somewhat of a focus on toxicology. The clicker is not working. Can you plug it in? Give me something that works. This doesn't work. Okay, good. All right, so we're going to talk about what research is. So I like to use the NIH definition of research. It is a systematic investigation designed to develop or contribute to generalizable knowledge. So there's a little bit of a problem sometimes with generalizable knowledge. As we saw with the panel discussion last time, Generalizable, it doesn't always work, especially in toxicology, right? Snakes are not the same in every country. I think they can hear me, thanks. Envenomations are different, poisons are different. You see a lot of organophosphate poisoning in Eastern countries. You don't see it as much in the US and Canada. So generalizable knowledge can be a problem, but certainly doing a systematic investigation that is well designed and develops knowledge is critically important. So how does good research start? Good research, I always like to say, starts with a good doctor. So you're a good doctor, you're in the emergency department, you're doing your toxicology consults, and you start to think about why do we do things the way we do them, why do diagnoses present with certain symptoms, what resources do we need to give better patient care, especially important in toxicology with antidotes and antivenoms, and can teaching be enhanced? I notice that patients do better when I do X. So all of these things can help you to develop your research question, and then you have to pass certain tests, right? Now there are a whole lot of tests that people use to say, is this going to be a publishable project? Is this going to be something that I can do? And I'm going to go through these one by one. These are the ones that I use. So who cares? So a common question is, you may be passionate about something, but other people might not. But everybody is passionate about teaching. But there is a certain problem that I see all the time with junior investigators, and that is people who are teaching in a clinical setting devise some sort of a teaching tool that they use and that is very effective, and then they want to publish it. So they say, well, we're going to find out whether people know more after they use my curriculum and whether they're more comfortable doing this procedure or engaging in this particular patients with this particular diagnosis. So I'm going to steal a quote from Michelle Byros, and Professor Byros was the editor of Academic Emergency Medicine for a number of years, and she said, look, medical students and residents are intelligent people. If you teach them something, they'll learn. And if you let somebody do something, they're going to be more comfortable with it. So this is not the kind of a thing that anybody cares about. This from and why, because it was the expectancy effect. So what I expect from people is what I get. This is really important in my teaching on diversity and cultural competency because we have implicit biases based on what people look like, what we think they're going to act like, and who they're going to be. But this involved a lot. So this was not an ethical study, and it would never get through the hierarchy now. But you can do certain studies when you want to see the impact of people's behavior, or you want to see the impact of certain interventions, and it's unethical to obviously lie to your patients or lie to physicians. So you could do retrospective studies that give you information that you can't ethically get prospectively. You can look at variables that impacted patients with good outcomes and poor outcomes. For example, we know, and this is relevant to disparities, we know that if you are black in the United States and you have peripheral vascular disease, you're going to get an amputation. And if you're white in the United States and you have peripheral vascular disease, you're going to get revascularization. So how do we know this? We don't do a prospective study, but we look back at the data and we see how people are treated. So how about in toxicology? If you live in a certain country, are you less likely to survive a particular overdose because resources are not available? If you live in a rural area of that same country, are you less likely to survive an envenomation or an overdose because the antidotes are not available, or atropine is not available, or something else is not available? So cultural competency and healthcare disparities can actually be looked at even within the same country. If you look at different castes, if you look at different sects, if you look at different religions, if you look at rural versus urban. So you can actually do these things in an ethical way by looking back in time and doing a retrospective study. I did a study on presumptive treatment of STDs in the emergency department because I suspected that blacks were being treated differently than whites. And sure enough, we showed that black and Hispanic women were more likely to be treated for STDs than white women, treated presumptively. Why? Because of bias. You can do this with toxicologic studies in your country as well. So can you get information? Things like will patients tell you? So questions about sexual behavior or how you discipline your children. Often we think that patients are not going to tell us that. But you could actually do a study asking patients whether they would discuss things like this. You can do questionnaire studies which become publishable, and then you can do the study afterwards. Can the information be known? So if you have a pre-verbal child, you can't necessarily know why that child is screaming and yelling when you take them to CAT scan. There are other things that you simply can't do because you just don't have the data available, or you don't have an electronic medical record. Because we can query an electronic medical record and say, I want to look at every single patient who came in with an organophosphate poisoning in the past 10 years. I can look through my EMR and look at my ICD-10 code and find that out. But what if you can't do that? What can you do instead? Well, you can try a questionnaire asking patients if they would share information that you don't think is available. If things are not recorded in the chart, do a prospective model, right? So if you can't query the chart for all the ICD-10 codes, say, let's start a prospective study. Let's look at all the people who come in with organophosphate poisoning or a coral snake envenomation. Enlist your colleagues and make sure that you're getting all those patients. You can have a student or a resident who every single day goes back and hand checks every single patient that registered in the emergency department and what they registered for. The things that we may do retrospectively in countries where we have a vigorous electronic medical record system, you can do prospectively in your country by having vigorous medical students who are willing to check for those things. You can get a team together to extract data from a paper chart, or consider using a shorter study period or 2 study periods, right? If you want to take, for example, winter and summer. So in my country, winter and summer will affect what kind of envenomations people experience, what kind of spider bites they experience. how many fish stores are there, and then just mapped all this out using big data, and again, got a huge grant then to study nutritional deserts. What could this mean to you as a toxicologist? U.S. poison control data. You could compare your country to the U.S. poison control data. What else can you do? Canada has a huge database. They have a National Health Service. How do you think the auto-animal rules got developed? How do you think the autoimmune rules got developed, or the Canadian C-spine rules, or the Canadian HCT rules? Because for the auto-ankle rules, they had 23,000 people who had ankle fractures. So they just looked at those 23,000 people who had ankle fractures, and then they looked at all the other people who came in with a chief complaint of an ankle injury and didn't have a fracture, and they developed the rules, and the rules are like 100% reliable. You can have access to the Canadian health records. You can have access to some of the UK health records. Here are some other things. Denmark, every citizen gets a number when they're born, and everything about them is reported under that number. It's like the U.S. Social Security number. All the health data is available, and it's all online, and it's already de-identified. You don't have to live in a country to write about it. You can also compare another country to your country. What else is available? The National Geophysical Database collects climate data from all over the world. It's in the United States, but it collects information about all over the world. You have to know, right, that temperature affects outbreaks of flu, cholera, typhoid. Are there correlations between climate factors and overdose? Well, there are in Scandinavia. More people try to kill themselves in Scandinavia when it's cold and dark. During their 6 months of cold darkness, more people try to kill themselves. Think about climate factors in your country. What might be going on? What might you be curious about? What might you think that climate, rain, ice, snow might impact the way that people behave and whether they take overdoses or exposed to poisons? What about climate envenomation? Climate affects animals. Other large data sets, AWS public data sets, Amazon makes large data sets available on their website platform. Google public data sets, www.datasciencecentral.com, DataQuest.io, they sell it to you, but it may be worth it to you to get something published. What else? There's a couple other data sets there that you can just take a picture of this, go Google it, go online, look at these data sets, and think about how you can use them. Do you know someone who has Cerna? Cerna, which is an electronic medical record, is now making every single hospital that uses Cerna participate in a data dump. So if you have Cerna, or if you have a friend who has Cerna, they can get data from every hospital that uses Cerna in a data dump, already de-identified and already readily available. So think about how any of those variables you can get data on can impact exposures or outcomes from a toxin. What about high-yield information? So you think about some of the studies that have been done. I know every time we want to admit a patient to orthopedics, they want an ESR. Does it matter? No. It doesn't matter in the outcome. Yes, so they watch the ESR go down and they go, oh, yeah, it's going down. Who cares? The same thing with patients who are decompensated psych patients who come in with an elevated CPK. Well, it's elevated because they're running around and screaming and they're agitated. And when you sedate them, it's going to go down. But think about other biomarkers that actually were important. Elevated troponin. 10% of people who have a STEMI have an N-STEMI. And when I was in medical school 20 years ago, we used to send them all home. And then they'd have a big myocardial infarction. And they'd come back cardiac or dead. So now we can measure troponin. That's an important biomarker. What else? Sepsis. We have sepsis bundles now. We have increased survival. That is important. So what can you do if you don't have access to those big sinus things? Think of a disease with high stakes. What do you notice about patients who do well and patients who don't? And study that variable. Talk to your basic science colleagues. They have access to some of these tests medical toxicology, you can look at that with antidotes and antidotes. And you can do it in a very ethical way. You can pick two venues, one which has the antidote and one which doesn't. And your big question, therapeutic dose versus toxic dose and drug safety. So I'm not going to go into those since my time is running out. But controlled trials without randomization are another study. Anti-spectrum, meaning what happened before the intervention, what happened after. So what was going on before I had the antidote in my hospital and what goes on afterwards. Prove the effectiveness to your government, to your hospital, of actually stopping an antidote. Intervention impact studies, right? What kind of counseling programs can you, we did this a lot with HIV in the United States, what kind of counseling programs can you put in place that will have an impact on people's behavior, and then you'll see less of that disease coming into the emergency department. You can do that, again, with medication safety. You can do that with vaping. You can do that with a lot of exposures that are relevant to toxicology, right? So toxicology intervention impact. What is the % decrease in overall pediatric mortality from unintentional drug ingestion with the introduction of certified medical toxicologists in Oman? Talk to the three of them. They're here. Ever since they developed the Poison Control Center in Oman, there has been a significant decrease in deaths because the ER doctors have someone to consult. Take that information, bring that to your government, to your hospital administrator, and prove to them why you need toxicology in your hospital and in your country. What is the % increase in survival from snakebite since the hospital began stocking antivenom? What is the absolute decrease in the number of accidental drug ingestions from the introduction of a poisoning prevention educational program in public school? I'm just giving you ideas. You roll with them. You make them work in your particular setting, whatever works for you. Cohort or case control studies. Follow and see what develops in the condition. Again, this is for emergency medicine, toxicology cohorts that you can look at, an exposure that's worrisome. Will the population suffer ill effects, such as Chernobyl, drinking milk that from cows exposed during Chernobyl? That was an important study that was done. And then never underestimate the power of a case report. Even though Dr. Hoffman said you guys are seeing less case reports, and I'm glad of that, because of the fact that better science is not a case report. But case reports have power, especially for very rare things. Just like, how did we discover what the cause of HIV was? We discovered it because two epidemiologists took the first 1,000 cases of HIV and looked at those patients and said, oh my God, it is caused by decreased leukocytes and CD4 cells. And lo and behold, 700 and something of the 1,000 were IV drug abusers, and 500 and something of the 1,000 were bisexual. We found the cause through a case series of what was the cause of HIV. So don't underestimate the importance of it. There are a lot of conditions where you can actually use a case series to look at what is going on. All right, I have a few minutes left. Okay, so think about the practice of evidence-based medicine. If you need me to convince you why you need to do work in your part of the world. A lot of the surviving sepsis data came out of the West. How many people are familiar with the FEAST study? I'm going to tell you, the FEAST study was a study that was funded by the British, done in Africa,
1 minute. Thank you.
Okay. So that was published in The Lancet in 1878. This image that you see here is basically the first documentation of the term telemedicine. So they talked about how they have telephotography, so now they need to have telemedicine. This was in 1927. Obviously, at that time, everyone thought this guy was crazy, but now it's actually happening. After that, we started having satellites, and with satellites came remote monitoring. NASA started using the satellite technology to monitor the physiological measures of astronauts in space. Now, that same technology, the image you see here, that's the ATS satellite in NASA. This was in the late 60s. They started using the same technology they used for the astronauts. The image you see there is a 1985 earthquake in Mexico. That technology was combined with the 1985 earthquake in Mexico to help people with telecommunication and aid in the relief support during that earthquake. And that was the first time that telehealth or telemedicine at that point in time was used in a mass casualty incident. Present day, this is present day, the image you see here. This is our Incident Command Center in the Ministry of Health. As you can see, there are tons of screens. All these screens are part of a completely integrated telehealth system. They're connected to all the hospital incident command systems and to the ambulances. So you can see exactly what's going on just by sitting in one room. I'll talk about that a little bit later. So why am I talking about telehealth? Because the current management of any disaster scenario or a mass casualty incident, it has holes. What telehealth does is fill in the cracks. The cracks that we currently have in our management, telehealth fixes them. So this is the systems that we currently have in Kuwait. It kind of matches the majority of international systems. You call 112 112, the call is dispatched to the EOC, which is the Emergency Operations Command. Then they will activate the HICS, which is the Hospital Incident Command System, which then activates the ICS, or they can directly activate the ICS, and the ICS can activate the HICS according to the scenario. So, sit, close your eyes for like 20 seconds, a little medical meditation. Imagine that you're receiving multiple calls in a metro station, and they're telling you there are tons of patients, they all have shortness of breath, they're all vomiting. What do we do? Most of these patients seem like they're going to be tagged red. What happens currently without telehealth? Imagine that scenario, and I'll go through the scenario with what happens with telehealth. This image is basically the sarin attacks that happened in the metro station in Tokyo. So this scenario that I'm running through is similar to those. What's going to happen? Step one, you're going to get a dispatch of ambulances. These are ICU ambulances. All the monitors you have here are also integrated in the telehealth system. You can get ultrasounds that can be integrated in the telehealth system. So basically, it's complete. You can re-triage, you can manage your patient through the ambulance. This is another option that you have in case it's needed. This is the HEMS. So the Hospital Emergency Medical Services or the Air Medical Services, they can also be activated as necessary. So this is basically dispatch. Now, what happens on scene? This is on scene. This was a triage scenario that we did, an MCI scenario that we did. You're going to see patients. They're going to be attached to monitors. So they're going to be tagged according to the start triage system. Now, in telehealth, what changes? This is what changes. On site, your paper triage tag is going to be changed to a PDA, which is basically a handheld first responder device. The handheld first responder device, you just scan, and it triages your patient. When you triage that patient, that information automatically goes into, it becomes data. How does that help me? Number one, it makes everything faster. Number two, I automatically have data. I don't have to have a paper and collect paper, and the paper gets lost. This is not going to happen. This also helps me with research, which you'll see how it later on affects preparedness. En route. En route, what happens? So you have the EOC, which is the image you see on the right, and you have the image on the left, which is the Hospital Incident Command Center or the telehealth center in hospitals. If you see at the EOC, you have two screens. One screen where you can have a video of the patient, and the other screen where you get the vitals. You can get a full ICU set through that screen. So why is it relevant to toxicology? If you have a patient with a toxidrome, what you see on those screens is basically all you need to make your diagnosis, give your patient the antidote en route, and then re-triage them. If necessary, they might start red, you give them the antidote, they become green. What does this help with? You're decreasing, when you're re-triaging your patient or you're treating your patient en route, you're decreasing ED flow. You're decreasing the flow to specialty centers. You're helping out the EMS, which are overrun and overwhelmed at that point in time. So this is basically what happens. Studies have shown that if you use telehealth, the number of deaths that occur during transfer from scene to a specialty center decreases. Total transfers decrease. Total number of ED beds used decrease. That increases your medical surge capacity. And ED waiting times also decrease. So it's a win-win situation. It's a lot of technology. It may be new to people, but actually putting this into our practice helps us out a lot in many, many ways. So if you think of telehealth and you think of the phases of the disaster response, it affects every single phase of the disaster response. So with preparedness and mitigation, we already talked about how what you are doing with telehealth is collecting data. Anything you get from your patient that is on your screen is automatically data. You use that, you can publish research. It's easy. You have an EHR system. You take the data from the telehealth, publish research. What does research do? It enhances our planning. It enhances our preparedness. We know what went wrong last time, and we can make sure it doesn't happen next time. What were we missing last time? We'll apply it next time. Response. We already talked about PDAs, assisting in field triage, electronic triage tags. Another point that we need to take account is virtual increase in medical surge capacity. So what is that? That's basically you're on field. You're lacking physicians, or you're lacking any healthcare providers to triage your patients. You can virtually have another physician on the site, and that physician is going to tell you, well, triage this guy red, triage this guy green, triage this guy yellow. That increases your surge capacity. Also with transport and treatment. Like, as we said, we can treat the patient en route, or we can retransport, or we can send home. Recovery. There are certain pandemics or MCIs that usually have a very prolonged recovery. Things like pandemic flus, earthquakes, tsunamis. You can assist with the recovery of the patient via telehealth. You can provide like doctors virtually to assist patients at home, to follow them up. You can follow the labs of your patients virtually, especially for psychotherapy services or family support after a disaster. That can also be all done virtually. Also, you have inter-hospital communications. So let's say you have an ED and you have a specialty center, and the specialty center wants to downgrade so they can provide more beds. Telehealth gives you that. It allows inter-hospital communication. Another thing that you can take into account is the EMS. Now, if the EMS is transporting one person to another place and you don't have a physician to assess that patient, you're going to overwhelm the EMS capacity. So basically, that inter-hospital communication really decreases all the weight on the EMS services. That is basically the telehealth. These are my sources. That's it. Thank you. Any questions?
Thank you very much. We'll take questions actually at the end of the session.
At the end. Okay. Thank you.
So this morning, I've been asked to talk about occupational chemical exposures and the role the Poison Center plays in managing these cases. And I have a unique perspective because we do have relationships with other agencies that allow us to work on these cases. So just a little bit of housekeeping, so I don't have any disclosures, but today what I want to do is make sure you understand the ways that poison centers can impact, the impact we can have when dealing with occupational chemical exposure events, understanding the importance of developing partnerships with other agencies, and then I want you to think about the last time there might have been a chemical event. Want you to assess in your mind what role your poison center or what role you played as a toxicologist in that event. So just a reminder for those of you who weren't at my talk yesterday, I am in Atlanta, Georgia. We are a population less than half of what it is here in Istanbul. We have a population of 10.5 million people. And we are housed in one of the largest teaching hospitals in the southeast. Dr. Kazi, is it an 800-bed hospital? So, yeah, something like that. 800-bed hospital in our institution, and the Poison Center is a department in that institution. We're one of 55 in the United States, as you probably know, and we are quite busy. You know, around 300 or so calls every day handled by our Poison Center. Now, in order to handle these calls, we have fairly advanced call handling capabilities, and you could compare them to what you have in your area, but communication technology and making the connection is important for us to report these cases. So for us, we have a very feature-rich telecom system. And what do I mean by a feature-rich telecom system? Well, we have various ways we can affect the queuing of the calls that come in. We have in our system what is called skill-based routing. If you're unfamiliar with skill-based routing, is say for example, we have someone who speaks the Turkish language calling in, and they only speak Turkish language, and many of us speak English. If there's one person in my department that could speak Turkish, we will give them a special designation, so even though they're still waiting for a call and they may be fourth in the queue to answer the call because they've waited a short amount of time, if you speak Turkish and you're looking for someone who speaks Turkey and they're available, the call will immediately go to them. And in our situation, we do get calls from Spanish-speaking people. Most of us speak English, but if I'm waiting for a call for English and I do speak Spanish, even though 3 of my colleagues are next to answer calls, the call will be routed to me first so the patient doesn't wait long. So it's called skill-based routing, and we're able to do fancy maneuvers with the way the calls are accepted. We also have the capability of working from home, and that's always a good benefit. In fact, some of our poison specialists work from home about 70% of their work. So 7 days out of 10, they may be working from home. They don't have to come into the hospital. They don't have to come into the office. We give them equipment. We give them a phone. We give them our resources, and they work from home as if they were in the office. One of the unique things about contacting us is that we were the first poison center in all of the United States to start accepting chat messages and email live. So these chat messages and these emails would go and mix with our phone calls, and so whether you're chatting, whether you're emailing, you could contact the poison center. Now, I don't know about some of you, I have older kids. They're in their late 20s. They don't use the phone anymore to call. They only use texting, and they only use messaging. So we have to adapt our practice so that we can attract some of these people who use alternative ways to contact us. One of the things that we're going to be adding in 2020 is accepting emergency calls by text messaging. So we have very elaborate equipment, so you can call us, you can chat with us, and you can email us, and the call or the encounter will be happening in real time. So that's what's important. Now, when you look at our technology in the Poison Center, not only do we have one phone system, we have a backup phone system. Whether that system goes down, we have to be able to provide 24-hour support to our service area. So we have 2 phone systems in the office, we have 2 phone systems in people's homes. So we're able, if in the event of an emergency, to be able to provide our services without interruption. We also have 2 different lines coming into the Poison Center. So if one of these lines get cut off, we still have backup lines to provide telephone services to the people and the public who use our phone system. So there's a lot of redundancy. And as you think about what you're doing in your centers, what you're doing in your poison service area, for us, we have a contract with public health, and we told public health, we will be available every minute of every hour of every day, regardless of the technological failures. Because all of us know things break. It's never always perfect to have communication lines open. So we have all these systems that allow us to have service. So when we have a chemical event, people will be able to call, even if one of our phone systems is not working. Now, I don't know about your capabilities, but because we're so busy, we can handle almost 70 calls simultaneously into our office. Now, the problem is I don't have 70 people working at the same time, but 70 people can simultaneously call into our area, into our phone system without getting a busy signal. Now, what happens in the event of a chemical event, a mass exposure? Will your phone system be able to handle the extra calls coming in, or will they always get busy signals? We invested our money in technology that allows us to increase the number of calls that come in to our center without a busy signal. We can handle almost, and you'll see shortly, we could handle almost 10 times the amount of calls without someone getting a busy signal. Because there's nothing more frustrating if you're calling emergency and it's busy. So we have the capability to turn on the programs that allow us to increase capacity. And I'll talk about the technology here. So it's called the SUFER phone system. I mentioned it the other day. I didn't really elaborate. But SUFER stands for Surge Public Health Emergency Response. This allows our system to increase our and expand our capabilities, but it's a technology that we've had for almost 10 years now. And not only does it provide access to more people, it also has a unique feature of being able to put messaging as if you were choosing messages from a phone tree. Press 1 if you want to hear about the common signs and symptoms. Press 2 for treatment. Press 3 for should you leave your area because of chemical gas. So instead of talking to a human, you can listen to live messages that are built for that specific event. Instead of talking to a human, I may only have 12 or 13 people in the call center. But if there's a mass event, we have in place a way that we could give people messages. Now, if they want to call us, listen to the messages, and still want to talk to a human being, there's a way for the system to route that call to a live person. So, when you look at this hotline, if there's an emergency in the state that requires, messaging, we can handle up to 580, almost 600 calls at the same time without our phone system breaking. Because you've heard of crashing the internet, right? You've heard of crashing a website. Well, why does that happen? Too many people are accessing the website, and now you can't do it anymore. The same thing works in phone systems. So in the event of an emergency where you have many more calls, your capabilities have to be increased or they will break your phone system. So we have the ability to handle almost 600 calls, and the reason why the state wanted us to have this technology is they wanted us to be prepared in the event of chemical exposures, chemical emergencies, mass exposures, for the public to be able to access us. Now, the beauty about the messaging in chemical events is it's all text to speech. So if a message is developed, we type it, we type the message, and then the translator for the computer converts it to words. And so we can put many messages, as you could see here, you could put many messages into the system and many options for someone to listen to various messages. You can, when we are asked to do special messaging, it probably takes us 30 minutes to 1 hour to fully configure the system. The one thing that we ask our partners in the health department to do is write the messages for us. we'll load it into our system, we'll type it in, we'll load the program, and then automatically the messages start talking in computer voice. So it's a great system to have in the event you're looking at developing messages in the event of a mass emergency. Now, when someone's calling in, if there's a fire in Istanbul, and you want to just let the people in Istanbul know, as opposed to if you're in Cappadocia, if the fire's only here, then you will hear specific information about the fire here that has toxic fumes. So what you need to do is call the special number, put in the designated area number that you want to hear messages for, and then you choose the message that you want, and then choose the options if you want to listen to all the messages or you want to talk to a live human being. So that's what's that's the beauty of this system, is you could listen to the computer messages as well as listen to the live voice. Now, the whole purpose of this talk is to talk about chemical occupational exposures, and we have a unique perspective in that we actually published a paper not too long ago, I think in 2017, about the relationship that we have with a governmental agency to enhance and to recognize those exposures that happen while someone is in the workplace. So these are occupational chemical exposures, and we are working with a government agency called OSHA. I don't know if they have a similar organization here in Turkey, but who is OSHA? If you're unfamiliar, back in the 1970s, the US government and the Congress passed legislation that called for a law that requires safety in the workplace. And the name of that organization they called the Occupational Safety and Health Administration, or OSHA. And what this was to promote and enforce standards for safety in the workplace. And so we have this government agency that really tries to enforce safety regulation, because when you look at the incidence of injury, there are millions of people who suffer, in the workplace. In fact, reported on a yearly basis, over 4 million workers suffer some kind of serious job-related injury or illness. And that's a lot of exposures. And so in 2014, we started doing exposures in the workplace, and we started not only tracking them, we were getting the calls already, but we were starting to report the calls to the government agency. They never asked for those calls before, but we had the database. So we would collect information about the patients. The poison specialists and the doctors would give advice on how to treat these patients. Now, the one thing that was different is when you call into our poison center, every call is kept confidential and private. We don't release the information to anybody, even the government. So we asked the patient, if you were having a problem in the workplace, will you give us the permission to notify the government that you had an injury at work? Some people, they were worried about retaliation, and so they don't want to give any information. Other folks said, yes, I want the government to investigate. So I'll give you my name, I'll give you my number, I'll give you the company that I work for. So we have to ask everybody for the permission to release their name.
But what about if they tell you, yes, let them know, but don't tell my name?
Yes, that's the first thing we do, is we release the information to the government, but what we do is we blind all the cases. So the government doesn't even know the patient. We are just trying to get permission to release the fact that an incident occurred. We don't ever release the name, but we do identify the company, so that there's the possibility of investigation. Now, with OSHA, every week we collect data from the workplace, and every week we submit them all the cases. In 2018, we had over 800 cases from the workplace that were reported to us. Of the 810 cases, only about 25% allowed us to release information. So not everybody, because they may be worried about job security. Now, one of the things that you have to do when you're having a program like this is you have to educate your staff. As I was talking earlier, Doctor, about the poison specialist, all our cases are documented. Now, the beauty of our specific EMR is that if someone has a workplace exposure, once they code and they use the code that the exposure happened in their place of business, automatically a reminder comes up. So if you tell the computer this happened at work, a reminder comes up that says, hey, what kind of occupation is this person? You know, will they allow us to pass their information to the government, so that our intakers of the calls will be reminded, so they don't forget that this is a unique case. So we have unique tools that allow us to remind us that we must ask more questions, okay? So I'm going to give you a couple of examples of cases where they called into the poison center and then we released the information to the government. For example, in this case, you have a 23-year-old who went to the emergency room after they were exposed at work to chemicals in their eye and their skin. They suffered burns to the cornea. The patient allowed us to give this case to the government, and when OSHA came in to investigate, they found some interesting things about this company. This company is an oil change company, and they failed to provide eye wash stations and other decontamination stations at work. They did not have the proper documentation at home, and after the government investigated, they fined and gave serious citations to the business of around $21,000. So the government said, you're not making your workplace safe. You have to fix the issues here before you can open your work again. In this case, case number 2, there was a 50-year-old who was exposed to chemicals for swimming pools. These chemicals fell onto his head, face, and chest. He was washed at the scene. He went into the emergency room with respiratory distress and altered mental status. OSHA came in and investigated, and here's what they found. When they investigated the company did not even report to the government that one of their workers was injured. There's a requirement for the government in these kind of businesses to report when a patient goes to the hospital. So failure number 1, they did not report the incident. Number 2, they did not provide a place that had that was free from hazards. They did not have body washing or eye exposure capabilities. They did not have the proper documentation in place for the chemicals, and they too were also cited and given tickets, and they were fined almost $30,000 for their issues. So there are many work-related exposures that get called into our poison center. We were able to collaborate with our government organizations to make the workplace safer by being able to report these cases to the government. And it's important for us that we had this relationship to forge with OSHA. So in summary, if you're looking at starting with a good communication lane for your patients to call, make sure you have a robust communication strategy. Do your job well, but once you've done your job well, look for other ways you can impact your community. And for us, it was a matter of recognizing that there were exposures happening in the workplace, that safety was being neglected. So we formed a partnership with the organization that looks for safety in the workplace, and we wanted to make, at least in Georgia, the patients that much more safer. Thank you.
Thank you. I think we have time for one question. Okay.
Thank you for your presentation about using technology in your system PCC consultation. I would like to ask, in the future, using the virtual intelligence applications, replaced by the PCC specialist. Is it any risk?
Is there any, so the question is there, because of technology and the explosion of technology, will there ever be a point where we'll replace human beings and only have a technology?
Yeah.
I don't think there's any risk for that.
No.
Because you could write a document, you could have an algorithm, but you need someone to interpret it. You need someone to understand it. And so I don't see technology being the only answer. You have to rely on experience.
Yeah.
You have to have bedside consultations. So technology
I agree with you. Thank
will,
you.
will never.
Thank you, Yellow. I'm totally agree
And
with
Andy,
you.
I could talk to you, Andy, afterwards. I could talk to you, Andy, afterwards.
Okay, so next speaker is Dr. Suad Alabri from Oman, and she's talking about cardiovascular complication of performance-enhancing drugs. Please.
I had a question for Dr. Sultan. First, I wanted to ask what happened to the camel, but you already answered that question. Secondly, is you talked about how grammar is changed from one research to the other. What is your opinion on using websites like Grammarly, which automatically changes the grammar for you in whatever whatever you have?
Yeah, I use Grammarly sometimes. So there are many softwares you can use, but sometimes you have, even after you use the software, you have to read it to make sure that it makes sense or not. You can ask sometimes a colleague, because even if you hire native English speakers, sometimes when they change things, the meaning would be changed. So you have to follow up after them. Was this the answer for? Yeah, regarding the camel, usually they slaughter the camel quickly so they can get benefit of the meat. Yeah, but mostly he was killed instantaneously.
For the most question, I kind of request you to ask your question and break, because the time is over. We have to run to catch the time. Thank you very much. We are going to finish this section. Dr. Kasi, one time we have to be here again.
Yeah, so the next session starts in just 6 minutes. Thank you.
Thank you very much. Thank you very much. As I would like to present the next speakers, Dr. Sultan Al-Waji. He is an epidemiologist and independent researcher working in Jeddah, Saudi Arabia. Graduated from Al-Qurra University in Mecca with Bachelor of Medicine, Master of Public Health from Johns Hopkins School of Public Health. Dr. Sultan, you are welcome. You have 25 minutes, please.
Although case report is underestimated sometimes, for one reason, because many people read it, but few people cite case report, because usually case report about rare things or atypical presentation. It's not about something common. That's why it's not very widely cited. That's why the editor of the journals sometimes do not like case report. But if you want to write a case report, you have to make sure that you are submitting the case report to a journal that is interested in case report, or they are publishing case report, because you don't want to go through a lengthy process, then you figure out the answer from the editor that actually we do not publish a case report, which it happens sometimes. So at the beginning, what's case report? Can you report anything, or it has to have specific like feature or criteria? What do you think? Can you hear me now, or do I have to go back to the mic? So case report, it's not necessary to be very rare. Sometimes when you want to report a case and you ask a friend or a colleague, and they would ask you that, you want to put the time? They will ask you, okay, that's fine. They will ask you, this case has already been written. So why you are writing this case? So somebody published it already. Why you are writing this case? It's not necessary to be atypical or very rare. Sometimes for educational purpose, let's say sometimes to increase awareness about specific disease that's not common in specific area. Because the main idea is to communicate with your colleague, to communicate with the other healthcare providers that we start to see these things. For example, in Saudi Arabia, let's say that, I remember a friend of mine said that female, she was a back passenger and she asked the driver to drive. He refused, but she insisted, and she was coming out of a party and she was drunk. This is new. So she drove, and she was involved in road traffic injuries. The driver was in the ICU. So it was critical. We are not used to see these things, but start to happen. So you want to increase the awareness of law enforcement people and the clinician that driving under influence start to happen in this geographical area. I said the journal editor usually do not like it because it's not cited, but sometimes because it's at the bottom of the evidence-based pyramid. We usually start from expert opinion, then we go up, and the case report usually it's down. It's not like randomized controlled clinical trial. But for rare things, you cannot actually do randomized controlled clinical trials. So sometimes the case report is the start of, let's say, a systematic review meta-analysis. Most of the bigger research started with observational study or even case report. Like Dr. Lisa, when she mentioned about the HIV in the 1981, it was a case reported in the CDC, the weekly morbidity and mortality report. Then another case came from San Francisco. A third case came from New York. Then it became as a case series. Then somebody started to do official research to figure out what's going on. Sometimes atypical presentation of common disease. Challenging sometimes case. Sometimes, so the main thing is a learning opportunity or like highlighting a message of this case. What's usually, it's not reported a lot, failure story. We need people to write about their failure. Let's say that you use something new, but you missed it miserably. We need to report about this because that's fine. Because if you do something and you fail at it, and you reported or you communicated with other physician, you are increasing the awareness that this technique does not work. So I mentioned all these, not necessary to be the first case. This was the Kaposi sarcoma in the 1981, published in the Mortality and Morbidity Weekly Report. Case series is 3 or more. Some of the people said it's 4 or more of the cases. You can call it case series. But if it's 1, 2, up to 3, you can report it as a case report. So what's the structure of the case report? Generally speaking, in research, we have specific form. We call it IMRAD, which is introduction, method, result, and discussion. And you put conclusion. So this is the main structure we usually put it for any research. But for the case report, it's a little bit different. And the good thing that case report mimic your clinical documentation. So you put an introduction, why you are writing this case, brief sentences about the disease you are describing, then case presentation, clinical history of the patient and the significant things the management or the outcome, then discussion, what do you think about this, compare it with previous case, and then you conclude. So it's very easy, you can write it in one day. But you have to know how to write the citation, the references, and usually it's preferred to use a software. So you make sure that you put the citation in the proper style, because each journal asks for specific style. Sometimes you submit it and they said this is Vancouver, we need Harvard, or we need the AMA style. So usually when you want to publish something, you have to know which journal you are submitting your paper to, take the author instruction, look at the instruction, and try to commit all the things, all the changes based on what they are looking for. So this is the structure of the case report. Title, abstract. Usually abstract is less than 100 or 200 words. And for the case report, they usually ask less than 1,500, 1,500, sometimes less than this. And this is all through the journal. You go to the journal and check what they are looking for. Introduction or background, then the case presentation, discussion, and conclusion. I will go through every one and talk briefly about the structure of case report. There is like a guidelines for any research design. For randomized controlled clinical trials, they have specific guideline. There is a guideline for case report, although not all the journal ask you to go with this guideline. The best thing, you go to the website of the journal and you see what are the requirements, what are the author instruction. If you don't find it, then you can go with the guideline. Title should be brief, informative, descriptive of a case report. Some journal ask you to write case report, like saying this is a case report of rare or atypical presentation. Other journals say no, do not mention this. So you have to make sure what they are asking for. Are they asking for this or not? Because you don't want to spend weeks, then they ask you to remove the word case report. Target MISH terms, if you go to PubMed, there is a specific characters called medical subject heading. They classify, they meet twice yearly, and they classify each disease on specific name, just to make sure when you put key terms for a specific disease, you find all the variation. For example, if I publish a paper about road traffic injuries, and you type motor vehicle collisions, you're going to get my research, because they understand these terms mean different things, and they collected in a specific place. If you go to PubMed, there is something called MISH database. You go and type the keywords there, and you try to figure out what are the MISH terms you are looking for. Some of them ask to write a rare case or atypical case. If you want to type, if you want to try writing first case, make sure it's first case. Because sometimes you say first, but if I do literature review, I'm going to find more cases of this. So as I mentioned, some say avoid, some say no. You can write a rare case or case report. Keywords, this is important. Usually choose 2 to 5. If you succeed at choosing the proper keywords, this would help other researchers when they go and do the Google Scholar search or PubMed through Medline to find your topic. And if the journal is indexed in PubMed, it's more likely that people will find your paper. Abstract brief, we said less than 200 words. Total case report, less than 2,000 or 1,500. Structure or unstructured. Sometimes they ask you for abstract, like in paragraph, mention everything, but in chronological order, introduction and methods, result. Sometimes they said no, write objectives or aim, then you put like 1 or 2 sentences, then write methods, then write. So this is the structure and this is the unstructured. Check the journal instruction. Usually check the journal instruction. Actually, it takes a lot of time to change from journal to journal. So if you get rejected or you want to change the journal, you have to change things in the paper, and usually take times, because you change the style, you change the reference sometimes, how you put the reference, you change the grammar or punctuation from American to British or Australian. Key elements in abstract, try to mention these key important things. Sometimes you write a paper and after 3 months or 6 months, when you want to publish it, they ask you for abstract. Then you write the abstract without going back to the paper. Then you figure out there's discrepancy. The things in the abstract a little bit different than the original paper. And usually do not believe any abstract Especially if you are trying to make a decision on this, you have to go and read the methods of the paper, because sometimes they mention something a little bit different than what the paper mentioned. And sometimes even things are the opposite. It shouldn't be like this, but you have to make sure you read the whole paper if you want to depend on that paper. Because sometimes you do not have access to the literature, so you just depend on the abstract. But this is not usually a good tactic. The introduction mentioned briefly things about the topic. Landmark papers, you can mention them in the introduction. Also, case presentation. This is mimicking what you have seen in the hospital. You just mentioned that we have this patient present with this disease and we did this. 2 or 3 paragraphs. Do not be obliged that you have to write everything about the patient, because you have only 2,000 words. You cannot write everything. You have to make it very short. Because in communication, you want to be clear and concise. Finish the story, even if you wait for follow-up. If you write the case and you don't know what happened to the patient, wait for a couple of days or weeks to say that patient didn't survive or went back home or deceased or something. Because it's like story. You are communicating with the clinician or other provider and you want to end it. You don't want to cut it in the middle, especially when the outcome is very important. Discussion, do brief literature review and emphasize on the learning point. Why you are reporting such case. Usually mention this. We are reporting the first case of this in this geographical area. Or we are reporting this because we started seeing these cases in our geographical area. Focus literature. When you come to the discussion, do not just report a case as if it's in solo. No, try to make a correlation between previous cases that have been reported in the literature and try to compare what's different from these previous, because discussion is like group discussion. We talk to each other. It has to be like kind of interactive. You mentioned X says, Y says, we noticed this. So do not make it like just a paragraph and you are mentioning, you are repeating the result. It has to be different than the result. It's interpretation of the result based on the other papers. Compare and contrast, finish with what your case add to the literature. In conclusion, should include evidence-based recommendation. Usually when you recommend something, especially with the case report, you have to base it on evidence, because usually this is a rare things. We do not have a lot of published recommendation about this disease. So try as much as you can support your decision in recommending specific things. Emphasize on the applicability of the practice. This is the main idea. If you want to change practice, if you want to increase awareness, you have to convince people that we did this with this case and the result was, for example, satisfactory or not satisfactory. Example of not very rare or first case. So I mentioned it doesn't have to be the first case. This is one of the case report I'm submitting now. It's a road traffic injuries in the middle of the city, in the highway, between 2 cities, but it was still in the same city. The car didn't leave. And the road wasn't lit very well. There was no light, and a camel came. It was an SUV, hit the camel. The car swerved twice, flipped over twice. The driver was putting seat belt, the baby in the back with the seat belt. The woman, the front passenger, wasn't seat belted. She was ejected and died on scene. So it's, if we report this, somebody would say, yeah, but this is a camel with the car, so what's the point? There is a point here. There is a point that although this is, it shouldn't happening, especially in a city, but it happened, we don't know what's the behavior of the accident. We usually, when we talk about accident, we talk about people who are texting and driving or people who are overspeeding, but we are not talking about uncommon things like animals. And we figure out that camels, accident with camels in the Middle East mainly, sometimes in Australia. In Australia, they have the kangaroo and other animals, but it happens, and it can increase the mortality of road traffic injuries. Then we spoke about the intervention that should have been implemented on the street, probably, or on the animals. Sometimes they put stripe with the light on these animals. Other thing, we saw a couple of cases with elderly people when Dr. Lisa talked about diabetes. I remember I was working with the Ministry of Health in health policy, And some of them, they did a research survey, and they mentioned that diabetes in Saudi Arabia, they said 8%, some of them said 10%. The problem, we are a young population. Diabetes usually happens in middle age and elderly. But when they did the subgroup analysis of that survey, people in Saudi Arabia who are 65 and above, 50% of them diabetic. Can you imagine this? So if you are 50 years old or 40, you're going to be diabetic. It's 50%. And this is previous research. We don't know if we continue on this, maybe it's going to be 60%. So one of the cases I saw in the hospital, I was taking history from the patient, and he was having a chest pain. He was 50 something. Then during the encounter with the patient, he said, this is after that pills, and he started cursing the pills. I was like, which pills? Then I figured out that he was using Viagra. At the same time, he was having angina and taking medication. So due to the interaction, he had a myocardial infarction. And the problem, they take it from the pharmacy over the counter. They do not have a prescription. And the pharmacists even do not give instruction that if you are taking medication for the heart, you have to make sure you are not taking them at the same times. So although maybe this is not a very rare, but at least you are increasing awareness and mentioning some recommendation that need to be implemented not on the physician only, but on the pharmacist or on the patient. Graphic and image, this is good. If you mention something, if you put illustration, it makes your paper looks nicer. It's kind of like entertaining. If you entertain the readers, people would read your articles. They probably would cite it. The journal would like it. But usually follow the instruction. Sometimes they don't want more than 3 table or 3 image. Be creative. Feel free to be creative. You can create something. You can draw something or hire a video animator. Like now I'm trying to hire a video animator. I contacted one of them because I figure out when there is an accident, sedan car with a camel, usually because the camel is 2-meter height and the sedan is a little bit lower. The weight of the camel is more than 500 kilograms. So if they hit the camel, usually the camel fell on the passenger and they get killed. But it's SUV or family car, usually the camel will be ejected. So this might indicate the fatality of the accident. And I think the speed has another factor. If you are driving at high speed, more likely the camel will fall on the car. But if you hit a camel on a low speed, it will fall in the front side of the car. So you can add some information, especially the mechanism of the accident. Practical tips to write and publish a case report. Consent the patient. This is the first thing you do. If you see interesting things in the hospital, consent the patient before he goes. Because if you tell me after 2 weeks, I want you to help me in writing case report, if the patient left and we do not have a consent, that's an issue. Put a deadline. If you agree with your consultant to write a case report, let's write this in 2 weeks. Or I will give you my final case report and then you review it in 1 week. Agree on authorship. Sometimes conflict happens, especially between 2 different departments. We are the emergency medicine. We saw interesting case, admitted the patient, then the radiologist, they publish the paper, but we publish at the same times. So try to, if it's different perspective, they are publishing from radiological perspective, that's fine. But if it's the same case, it doesn't look nice when you have a conflict of authorship on a case report. Plan to succeed at the 3rd trial. I'm a researcher, so I usually see clinicians, they are frustrated because they tried once, twice, or 3 times to publish something, but they weren't successful at this. Let me ask you a question. Do you think your first intubation will be successful? I don't think so. Do you think your first physical examination will be presented, or people would say that this is the best physical examination? So in research, it's the same thing. You do the research, you failed first time, you get rejected second time, third time rejected, then you resubmit again. You might succeed after 4th time, but that's fine. It's a learning opportunity. The more you try, especially with the supervisor, the more you learn. Authorship, make sure you do not have a conflict. Single author usually responsible for the load of the work. Sometimes a single author may be the senior, but the senior need to have the load of the work. Being a clinician, or if the patient is admitted under your name, doesn't give you the authorship. You can publish a case report while the treating surgeon or clinician was not involved in the case in the writing or intellectual.
Yes,
process.
1 minute.
Okay. Avoid double publication, ethics and ethical approval. You need to have the informed consent from the patient, okay? If you want to show the picture of the patient, there is another form. In some institution, they ask you for IRB, institutional review board. It's not the usual practice, but some hospital ask for this. And avoid plagiarism. You can check the journal. Sometimes they mention topics that they accept. For example, they said we take case report in trauma or injury, stuff like that. Drawback of case report, we said it's at the bottom of the evidence-based medicine. Due to the high volume, journal usually accept very few number, limited number. And some journals do not accept case report. Avoid making firm judgment because it's one observation. Do not say that this treatment is for this disease. Before claiming rarity, make sure it's rare. Few grammar mistakes is acceptable. Typos are not acceptable. Even if you are non-native speaker, typos usually means that you were in a hurry or you do not have time to review your paper. Example of non-case report, we said the AIDS, the thalidomide, it started with the case report, with the congenital anomaly, the fenfluramine, which is the appetite suppressant with the pulmonary hypertension, and the Zika virus. This is the guideline for the case report. Some journal ask for this. Yeah, so this is just a video. I was showing how when I write, usually try to use a dictionary, especially if English is not your first language, to be very handy for you. Because you need the thesaurus, you need to check for words, you need to check for spelling. If it takes you a long time, you will get bored and you wouldn't go and check the dictionary every now and then. But usually writing is not like speaking. It doesn't come from the first time. Even native speakers, sometimes they write things, and when they read it again, they do not maybe understand it, or it's not very clear. And this is the last video. You can hire somebody to check your writing, check your English, and you can pay them per page as a native speaker. That's all.
Okay, thank you very much. Thanks. We'll take questions at the end of the session.
Okay.
Our next speaker, Dr. Razan